It's time for another warm-up review. Let's get going. First question here, what are the characteristic features of pericarditis? So you're going to get pleuritic chest pain. The pain is going to be worse when supine, dyspnea, fever, cough, a pericardial friction rub, JVD, and then diffuse ST segment elevation. Next, what is the most likely cause of aortic stenosis in a 50-year-old patient? Well, you're probably going to see this in a congenital bicuspid aortic valve patient. So even though it's a congenital defect, it generally doesn't present until middle age. Next, what is the most likely cause of aortic stenosis in a 70-year-old patient? Well, that's going to be a senile calcification or degenerative calcification of a normal 3-leaflet valve. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to dive into the gastrointestinal system, starting with the esophagus. So let's start with dysphagia, which means difficulty swallowing or abnormal swallowing. Dysphagia can be caused by difficulty initiating swallowing, which is called oropharyngeal dysfunction or transfer dysfunction, or dysphagia can be caused by esophageal dysfunction, which is our focus in this lecture. Another term you should be familiar with is odynophagia, which means pain with swallowing, and this can also contribute to swallowing problems. Dysphagia may be caused by a neuromuscular motility disorder, such as achalasia or scleroderma. It can also be caused by esophageal narrowing or obstruction. The most common cause of obstruction is food impaction. Esophageal strictures can form due to acid reflux or ingestion of caustic alkaline fluid, like lye, which damages the mucosa, and then the fibrosis during healing causes scarring and stricturing. Radiation exposure, like radiation to the chest for lung cancer, can also cause fibrosis and strictures. Esophageal cancer can certainly cause some obstruction of the esophagus and some dysphagia with that, and so can esophageal webs or rings. Now, speaking of esophageal rings, there's something called Plummer-Vinson syndrome, which is the triad of esophageal webs, dysphagia, and iron deficiency anemia. Now, this is fairly uncommon in the U.S., but it's one of those classic things you should have at least heard of. The cause of dysphagia can be suggested by the patient's history. If the patient complains of feeling that food immediately gets stuck in their throat when they swallow, think oropharyngeal dysfunction. This can also cause some coughing or choking. Esophageal dysfunction usually causes problems a few seconds after swallowing. Now, the types of food they have problems swallowing may also be a helpful clue. Difficulty swallowing solids suggests esophageal obstruction, while difficulty swallowing both solids and liquids suggests a neuromuscular problem. The inability to swallow solids is a problem, but inability to swallow liquids is an even bigger problem because these patients can become dehydrated very quickly. Now, there are a few different studies you might do to evaluate dysphagia, and which test is done first depends on the patient's presentation and the risk of perforation. Upper endoscopy is the most common test used in patients with esophageal dysphagia. But a barium swallow may precede upper endoscopy if the risk of perforation is high. And then manometry is a test where you measure the pressure in the esophagus during swallowing. So this is performed in patients with dysphagia in whom upper endoscopy is unrevealing or in whom motility disorder is suspected. And while we're on the subject of radiologic studies to evaluate the GI tract, let's review which anatomical structures are visualized by each of the following radiologic studies. So the first one is a barium swallow, which looks at the esophagus, the lower esophageal sphincter, and the stomach. A gastric emptying study shows the stomach, the pyloric sphincter, and the duodenum. And keep in mind this is often used to evaluate for gastroparesis due to autonomic neuropathy and diabetes. A small bowel follow-through goes from the stomach to the terminal ileum, and then a barium enema is administered in a retrograde manner from the rectum upwards. So this looks at the colon, from the rectum distally to the appendix proximally. And upper endoscopy allows you to inspect from the oropharynx down to the proximal duodenum, but technically that isn't a radiologic study. Let's review some different methods we might use to feed a patient that's unable to eat. Some students have been asked about this on step 2, so you might be familiar with these. There are lots of reasons a patient might be unable to eat besides dysphagia. They could have a physical impairment, such as a motor neuron disease. They could have a mental impairment, like dementia. It could be a short problem following an injury or acute illness, or this could be a long-term issue following a stroke. And if the patient's unable to protect their airway during feeding, oral feedings can be dangerous because of the risk of aspiration and pneumonia. So what are some options to feed these patients? Well, the first option for the short term is a nasogastric tube, or an NG tube. This is a relatively rigid tube which makes this somewhat uncomfortable. Complications include worsening gastric reflux and pressure necrosis. So again, this isn't a great long-term option. Another option is a percutaneous endoscopic gastrostomy, or a PEG tube. So this involves placing a feeding tube directly into the stomach through the overlying skin with the aid of an endoscope. So this can be placed either in the GI suite or potentially at the bedside with the right equipment. An open gastrostomy accomplishes the same goal, but this requires a larger incision and has to be done in the OR. Now, regardless of how you place it, a gastrostomy tube, open gastrostomy or G-tube, or a PEG tube, that percutaneous gastrostomy tube, either of these is going to be a standard long-term solution for feeding a patient who's unable to obtain nutrition orally. But the downside to a G-tube is that a confused or mentally altered patient can pull out the tube. You may have to replace it very quickly because that wound is going to close up very quickly. The last option worth mentioning is total parenteral nutrition, or TPN, which involves providing nutrition to the patient without using the gut. So instead, the nutrition is fed directly into the vein. Now, this is less than ideal. A guiding principle to use in all patients is that if the gut works, you should use it. You should also know that TPN is associated with an increased risk of bile stasis and acalculous cholecystitis. And then the venous line used to deliver TPN is a potential site for infection and sepsis, including fungal infections. That is one handsome patient, if I do say so myself. Now we'll move on to some specific disorders of the esophagus, starting with achalasia. Achalasia is a neuromuscular disorder of the esophagus. Achalasia consists of impaired peristalsis and decreased lower esophageal sphincter relaxation because of intramural neuron dysfunction. Now, the cause of this inflammatory degeneration of the neurons isn't really known, but it most commonly affects people 25 to 60 years of age. Now, there are other diseases that look similar to achalasia. These secondary causes, also called pseudoachalasia, include Chagas disease, neoplasm, and scleroderma. Now, the patient may present with gradually progressive dysphagia of solids and liquids, along with regurgitation, cough, aspiration, heartburn, and weight loss from poor intake. The diagnostic studies include manometry, which shows increased lower esophageal sphincter pressure, incomplete relaxation of the LES, and decreased peristalsis. You can also see the classic bird's beak on a barium swallow. Here's a representative image of a barium swallow in a patient with achalasia. And then here the GI structures are added onto the barium swallow. And then you can picture the bird's beak where the tapering of the lower esophageal sphincter is. So you have that decreased lower esophageal sphincter relaxation. So if you hear bird's beak, think achalasia. The treatment goal for achalasia is to lower the lower esophageal sphincter pressure. So this can be accomplished mechanically by two procedures: pneumatic dilation and myotomy, which means to dilate the esophagus with a balloon and then cut the muscle so that it stays dilated, or for those at high procedural risk, botulinum toxin injection, or less commonly, medications such as nitrates and dihydropyridine calcium channel blockers can be used. So each type of treatment has risk of certain complications. The procedural therapies can result in reflux or perforation. The medications can have simultaneous cardiac effects. And as an aside, since neoplasm is a cause of secondary achalasia, an EGD is needed to rule out malignancy in any patient with signs and symptoms consistent with achalasia. Another neuromuscular disorder of the esophagus of unknown etiology is diffuse esophageal spasm, also called distal esophageal spasm, or DES. So DES leads to disordered and non-peristaltic contractions of the lower esophagus. The patient presents with chest pain and esophageal dysphagia for liquids and solids. The barium swallow often shows a corkscrew pattern, but keep in mind that while this is suggestive of DES, it's neither sensitive nor specific. Manometry will show non-peristaltic, uncoordinated esophageal contractions, and then endoscopy will likely also be done to rule out structural disorders given the presence of esophageal dysphagia. First-line treatments for the dysphagia and chest pain associated with DES are calcium channel blockers and tricyclic antidepressants. Nitrates may relieve the pain from DES since they lead to relaxation of the muscle, but they can also relax the lower esophageal sphincter, which makes reflux symptoms worse. But don't be fooled in a patient with chest pain. If a patient comes to the ER with chest pain that's relieved by nitrates, that doesn't prove that the pain is cardiac. It could also be from esophageal spasm, but you definitely need to rule out cardiac causes. Next is Zenker Diverticulum, which is an outpatching in the upper posterior esophagus caused by muscle weakness involving the cricopharyngeus muscle, which leads to motor dysfunction. Diverticula can actually occur along the entire length of the esophagus. The Zenker Diverticulum, which we're talking about here, is found immediately above the upper esophageal sphincter. A traction diverticulum is found near the midpoint of the esophagus, and an epiphrenic diverticulum is found immediately above the lower esophageal sphincter. The patient with a Zenker diverticulum may present with bad breath due to retained food and other debris in the outpouching, and they may regurgitate this food several days after eating it. They can also have occasional dysphagia. The radiologic test of choice is the barium swallow, which shows the outpouching. So here you see the proximal esophagus, and then just above the cricopharyngeus muscle, there's this big diverticulum posteriorly. So while with most esophageal orders, the diagnostic test of choice is an EGD, here it's a barium swallow. And actually, EGD is potentially dangerous in patients with Zenker diverticulum because if you accidentally intubate the diverticulum by mistake, you might perforate it. The best treatment option is surgical, cricopharyngeal myotomy and diverticulectomy by way of an external neck incision. But less invasive techniques have been successful and could be used in patients at higher risk for surgery. Now let's discuss gastroesophageal reflux disease, also called GERD or simply acid reflux. This occurs most frequently when the lower esophageal sphincter transiently and intermittently relaxes, allowing the stomach contents and all that acid to reflux back into the esophagus. The risk factors for acid reflux include obesity, hiatal hernia, pregnancy, and scleroderma. The patient may present with burning chest pain of heartburn that occurs 30 to 90 minutes after eating. Other symptoms could include sour taste in the mouth, regurgitation, nausea, or cough. So this could mimic an MI with chest pain, or it could mimic asthma with a cough. So keep GERD in your differential. GERD symptoms can be worsened by consumption of alcohol or fatty foods, with tobacco use, or after lying down. Typically, the diagnosis of acid reflux is made clinically. Now, endoscopy is useful for evaluating patients who have failed treatment or patients who have red flag symptoms such as bleeding, weight loss, dysphagia, odynophagia, or protracted vomiting. You may also do an endoscopy to assess for complications such as erosive esophagitis or Barrett's esophagus. If the endoscopy is normal, ambulatory pH monitoring can be useful to verify acid reflux, and manometry can assess for other causes of dysphagia like neuromuscular dysfunction. Radiologic evaluation is not usually necessary, but a chest X-ray may be part of the workup to assess for neoplasm, or a barium swallow could show a peptic stricture. Complications of GERD include ulceration, which can cause the aforementioned bleeding, strictures, Barrett's esophagus, adenocarcinoma, reflux-induced asthma, and laryngeal disorders. Treatment of acid reflux should be tailored to the severity and frequency of the patient's symptoms. First, we typically try lifestyle modifications, such as elevation of the head of the bed, weight loss, and elimination of any GERD triggers like carbonated beverages, fatty or spicy foods, or caffeine. But there are also several classes of medications that can be useful. Antacids include things like calcium carbonate or aluminum hydroxide or milk of magnesia. These neutralize stomach acid fairly quickly, but calcium and aluminum can cause side effects of constipation and nausea, and milk of magnesia can cause diarrhea. And taking antacids too frequently can result in milk alkali syndrome. So antacids are best used for intermittent symptoms. H2 blockers like famotidine or ranitidine or cimetidine reversibly block H2 histamine receptors in the stomach, and that helps to inhibit gastric acid secretion. Now, H2 blockers are usually used in patients that don't respond to antacids, but they become less effective if they're used regularly for more than a couple of weeks. They also have a delayed onset of action, but they last longer than the antacids. So if your patient knows they're going to be going to a barbecue and they know they're not going to pass up the spicy ribs, you might recommend that they take an H2 blocker a couple of hours ahead of time. Side effects can include headaches, diarrhea, and rarely thrombocytopenia. And then cimetidine can cause gynecomastia and impotence. The next category is the proton pump inhibitors, or PPIs. So these are the big guns. These all end in prazole, like omeprazole or lansoprazole. These irreversibly inhibit the hydrogen-potassium ATPase pump, or the proton pump, found in the parietal cells of the stomach to block gastric acid secretion completely. These tend to be well tolerated, but they may increase the effects of certain medications like warfarin, benzodiazepines, phenytoin, digoxin, or carbamazepine in certain patients. These might be used in patients that are not responding to H2 blockers, but sometimes we just go directly to the PPIs because of their superior effectiveness and lower cost now that they're generic. Then refractory GERD can be treated with Nissen fundoplication, where the surgeon wraps the fundus of the stomach around the distal esophagus. That's the traditional treatment for a hiatal hernia. Next, let's discuss esophageal cancer. There are two major types of esophageal cancer: squamous cell carcinoma, which is more common worldwide, and adenocarcinoma, which is more common in the US, but less common worldwide. The major risk factors for squamous cell carcinoma include alcohol and tobacco use. The risk factors for adenocarcinoma include obesity, tobacco use again, and Barrett's esophagus, which is a precursor to esophageal adenocarcinoma. So Barrett's esophagus is metaplasia of the distal esophagus secondary to chronic reflux. Specifically, the stratified squamous epithelial cells take on a shape that resembles intestinal columnar epithelial cells in response to the chronic inflammation and injury from acid reflux. And these metaplastic cells are at an increased risk of then undergoing malignant transformation and becoming esophageal cancer. Patients with esophageal cancer may present with progressive dysphagia. So initially they may just have dysphagia to solids, and then they progress to having dysphagia to both solids and liquids. They can also have weight loss, odynophagia, reflux, and possibly GI bleeding. A barium swallow would show narrowing of the esophagus and an abnormal mass, but then the test of choice is going to be an EGD, which is used to identify the mass and then perform biopsies. And a biopsy is needed to make the diagnosis. And then other studies like MRI or CT or PET scans can be used to determine the extension of the tumor and look for any metastases. The treatment includes surgical resection, especially total esophagectomy for early stage disease. Patients with more advanced disease may need radiation or chemotherapy, or this can be done as neoadjuvant therapy. But by the time this is diagnosed, the cancer has often already begun to spread locally and to metastasize, so esophageal cancer carries a very poor prognosis. The last esophageal pathologies I want to mention are Mallory-Weiss syndrome and Boerhaave syndrome. So Mallory-Weiss syndrome is a longitudinal mucosal laceration in the distal esophagus and proximal stomach. So this is a very minor mucosal injury. It's just a tear in the mucosal layer only. Boerhaave syndrome is esophageal perforation or rupture, usually in the distal esophagus. So this is a tear through all the layers of the esophagus, and this is a life-threatening injury. Now it's time for the end of session quiz. So I want you to pause the video and work through those questions, then we'll go over the answers together. First question, what's the most appropriate diagnostic test for a patient with esophageal dysphagia to solids? You'd most likely start with an upper endoscopy. Although keep in mind the general rule that if the patient is at high risk of perforation with an endoscopy, you should start with a barium swallow. Next, how does the treatment for diffuse esophageal spasm differ from the treatment for achalasia? So DES is usually treated medically with nifedipine, nitrates, or tricyclic antidepressants. Achalasia more commonly needs some type of intervention, such as esophageal dilation, botulinum toxin injections, or myotomy. You also need to rule out esophageal cancer with endoscopy in a patient with achalasia. And the last question, what esophageal disorder matches each of the following descriptions? Chest pain, uncoordinated contractions, and a corkscrew pattern on barium swallow is diffuse esophageal spasm, or DES. Inability to relax the lower esophageal sphincter and the bird's beak on barium swallow is achalasia. And then bad breath and regurgitation of food that was eaten days ago is a Zenker Diverticulum. And that's it for now. I'll see you next time.
Let's go over the 3-question warm-up. First question, what are the diagnostic criteria for rheumatic fever? So first of all, you have to have serologic evidence of group A strep infection, plus either 2 major criteria or 1 major criterion and 2 minor criteria. So the main ones I want you to know are the major criteria, the Jones criteria. So the J is for joints, that's a migratory polyarthritis. Then we write the O as a heart for pancarditis, endocarditis, myocarditis, and pericarditis. Then the N is for nodules or subcutaneous nodules. The E is for erythema marginatum, and the S is Sydenham's chorea. Then the mnemonic for the minor criteria is PEACE, P-E-A-C-E. So the P is for previous rheumatic fever. E is for ECG with PR prolongation. A is arthralgias. C is for CRP and ESR elevation. And then the last E is for elevated temperature. Next, what are the 4 potassium-sparing diuretics? So you have spironolactone, eplerenone, amiloride, and triamterene. And which of those causes gynecomastia and inhibits androgens? That's spironolactone. Both spironolactone and eplerenone are aldosterone antagonists, but spironolactone is the one with the anti-androgenic effects. And the last question, what heart disease fits each of the following descriptions? So ST segment elevation in leads corresponding to perfusion of multiple arteries, that would suggest acute pericarditis. Remember, you're not going to have this global myocardial ischemia. This is really just acute pericarditis. The next one says hypotension plus distant heart sounds plus distended neck veins. That's Beck's triad, which we associate with cardiac tamponade. And then chest pain that lessens when the patient leans forward. That's acute pericarditis again. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 2 video on the stomach. I am a typical medical student, and I have been invited by DIT to tell the truth about evil Dr. McGinnis. Because of his evilness, I have to hide my appearance and change my voice. Dr. Lewis, on the other hand, is smart and handsome and kind to animals. If I could, I would have his baby. I mean, yeah, I'm a female at a reproductive age. I can do that, right? So, as a recap, Dr. Lewis is good and deserves a raise. Dr. McGinnis is bad, and I want to throw open my mouth a little bit every time I see him.
Thank you, random witness protected student. Very brave. Okay, on to the lecture. So today we're talking about the stomach, and we're going to start off with the hiatal hernia. Now there's actually different types of hiatal hernias. There's what's called the sliding hiatal hernia, and then there's also the paraesophageal hiatal hernia. Now the sliding hernia is the more common type, where the gastroesophageal junction and the stomach are displaced through the diaphragm. So it's just an upward herniation of the stomach itself and that gastroesophageal junction. Now the paraesophageal hernia is where the stomach, not the lower esophageal sphincter, protrudes through the diaphragm. Now that gastroesophageal junction actually remains in the normal location. Now the problem with the paraesophageal hernia is that it can cause incarceration of that area, and then ischemia can then happen. That can lead to permanent damage, scarring of the stomach, and even worse. So that is a much more worrisome type of hernia. Now the sliding hernia, really not as serious, but it will increase GERD-like symptoms. Now patients are likely asymptomatic with most of these hernias, especially the sliding one, but when they do, as we just said, they often are going to have GERD symptoms. Now a barium swallow is going to allow you to diagnose this the quickest. On barium swallow, the abnormal anatomy will be fairly easy to recognize. So what about treatment? Well, a sliding hiatal hernia really can just be treated with proton pump inhibitors. Decrease the acid. If you can control the GERD symptoms, then really nothing else needs to be done. Now for the paraesophageal hernia, they actually might need surgical repair, especially if they're symptomatic. You do want to avoid that incarceration situation. Let's move on to gastritis. So gastritis is characterized as inflammation of the gastric mucosa. Now the most common causes include infection with Helicobacter pylori, NSAID use, especially chronic NSAID use, alcohol use, smoking, severe illnesses, autoimmune disease, Crohn's disease, and even just radiation therapy. Now, patients are going to complain of a lot of epigastric pain. They're going to have tenderness in the area as well, nausea, vomiting, a loss of appetite, early satiety, and then weight loss as well. So how do we diagnose gastritis? Well, often the diagnosis is made when a gastroenterologist directly looks at the stomach with a scope during an EGD. But that doesn't always reveal the underlying cause. Now, since H. pylori is such a common cause, we often look for that first. Now, a urea breath test or an antral biopsy can be performed to detect H. pylori itself. You can also test for serum H. pylori antibodies, but this will test if a patient has ever been exposed to H. pylori. It doesn't necessarily mean that they have an active infection. And you can also test for H. pylori antigen in the stool. So multiple ways to look for H. pylori: urea breath test, antral biopsy, serum antibodies, or stool antigen. So now that we know that we have gastritis, how are we going to treat it? Well, stop any offending medications, especially the NSAIDs. That's a very common cause there. Next, we have the H2 blockers, things like ranitidine, or you can also use the proton pump inhibitors such as omeprazole. Those are going to be most commonly used. Now, if the patient tests positive for H. pylori, then that's going to need to be treated as well. So this is often referred to as the triple therapy. So it's going to include one of those proton pump inhibitors and then 2 antibiotics. Most commonly, we're using amoxicillin and clarithromycin together for about 2 weeks. Now, metronidazole can be substituted for the amoxicillin in a penicillin allergic patient. Now, another related topic is going to be pernicious anemia. So in pernicious anemia, autoantibodies are going to destroy parietal cells in the stomach, and that's going to lead to low levels of intrinsic factor, which then is going to potentially lead to vitamin B12 malabsorption and megaloblastic anemia. So your parietal cells are destroyed, they can't make that intrinsic factor, and then there's no binding to vitamin B12, and vitamin B12 can't be absorbed. So where does that vitamin B12 get absorbed normally? Well, it's going to be in the terminal ileum. And there's actually 2 different causes of pernicious anemia. One is the absence of that intrinsic factor that we just talked about, and then the other is an absence of the terminal ileum. So if you surgically remove the terminal ileum, then you can have that B12 deficiency in that scenario as well. Let's move on to peptic ulcer disease. So this is a defect or an erosion of the gastric or duodenal mucosa. Patients will present similarly to gastritis. They're going to have things like GERD symptoms. They're going to have that epigastric pain, nausea, vomiting. They might also have some bleeding in that vomitus as well. H. pylori is the cause in most gastric ulcers and almost all of the causes for duodenal ulcers. So if you do an EGD and you see a duodenal ulcer, you can almost presume that this is going to be due to H. pylori. Now let's look at some of the differences between gastric and duodenal ulcers. There are some differences here. Now gastric ulcers tend to be in older patients, patients with H. pylori infection and NSAID users as well. That gastric ulcer again is less common than our duodenal counterparts. It's seen in only 25% of cases. The timing of the pain occurs soon after eating. So remember that part right there, soon after eating with gastric ulcers. Now the gastric acid level is going to be normal, maybe potentially low, and the gastrin level might actually be high. Now, the effective eating might worsen symptoms of the gastric ulcer and may cause nausea and vomiting. So these patients with gastric ulcers identify that, and then they tend to be thinner because they're not going to want to eat because it hurts to eat. So let's talk about duodenal ulcers next. So these tend to be in younger patients. Again, almost all of these are going to be due to H. pylori infections, even more so than our gastric patients. Duodenal ulcers are again more common, 75% of the cases here. The timing of the pain is different here. The timing is about 2 to 5 hours after eating. So a classic scenario that you'll see maybe on your test, someone complaining of epigastric pain while sleeping. So they eat maybe at 7 or 8 at night, and then at midnight they wake up in the middle of the night with that epigastric gastric pain. Now, eating actually helps to improve that pain initially, but then that pain then again later worsens. Now, there are a couple of other types of ulcers that you probably need to know about. The first one is called the curling ulcer. So this is an acute duodenal ulcer that is associated with severe burns. It's thought that a severe burn can lead to reduced plasma volume, which can then lead to ischemia and cell necrosis of the duodenal mucosa. Another type of ulcer is the Cushing ulcer. So this is a gastric ulcer that is associated with patients with elevated intracranial pressure. So because of that increased ICP, there's a stimulation of the vagal nuclei. So this leads to an increase in gastric acid secretion. Now, in refractory cases of peptic ulcer disease, a gastrin level should be checked to detect Zollinger-Ellison syndrome. So this is due to increased gastrin. So if you have a patient with recurrent ulcers despite therapy and treatment, check for that Zollinger-Ellison syndrome by checking the serum gastrin level. And we'll talk about that in more detail in another video. So how are we going to diagnose an ulcer? What are some of the different things that you might see with ulcerations when you're trying to diagnose these? So an abdominal x-ray might detect perforation. Now there's only a handful of abdominal pathologies that you can actually see or somehow identify with an abdominal x-ray. And one of those is free air under the diaphragm or free air in the abdomen, which means there's a perforation somewhere. So most of the time you'll see a line or a sliver of black just below the diaphragm, and you notice that it looks a lot like lung. Well, that's just air, and it's not supposed to be in the abdomen. Now, another way to help diagnose a peptic ulcer is with a barium study. So a barium study can demonstrate collections of barium in an actual ulceration, in that pit or erosion. Now, after most of that barium kind of passes through, residual barium actually persists in that ulcer in a higher concentration. Now, the most effective way to diagnose an ulcer is with that EGD, or the esophagogastroduodenoscopy, and that's why we say EGD, because it's a long word. During the scope, you can actually see that ulcer, and an EGD is used to perform a biopsy, and it can detect active bleeding as well. Now, many times for patients younger than 40 years of age for peptic ulcer disease, you can potentially be doing this in a non-invasive fashion. Older patients, however, or those with a previous ulcer should have an EGD performed. Now, one of the reasons you need to do this for that EGD is to rule out cancer. So anytime you see a peptic ulcer, especially in someone over the age of 40, when you're doing that EGD, you get a biopsy, usually about 4 quadrants all around that ulcer to make sure that there's no malignancy around that ulcer that is causing the ulcer in the first place, because malignancies of the stomach can actually look a lot like ulcers or cause them. So how do we treat these ulcers now? Well, active bleeding has to be ruled out with that, potentially with a CBC. That EGD is also important in patients with concerning symptoms. Stool guaiac can identify bleeding as well. So you might have maybe a very low-grade bleeding of your ulcer that is not changing your hemoglobin or hematocrit, but you may be able to detect that on a stool guaiac. Electrocauterization can be performed if there's active, worrisome bleeding during that EGD. Now next we need to decrease the acid in the stomach to help that area heal. So we try to decrease that gastric acid levels with proton pump inhibitors, again kind of like with our gastritis, and our H2 antagonists as well. Now we can go a little bit further there. We can protect the mucosa with a couple things. Sucralfate is one, bismuth subsalicylate, or misoprostol, which is a prostaglandin drug. So if you have maybe an NSAID-induced ulcer, or if someone needs to be on chronic NSAID use for who knows how long, then maybe something like misoprostol is considered first line, because NSAIDs inhibit prostaglandins, and by giving that misoprostol, that actually takes care of the prostaglandin reduction. Now, one of the biggest treatments here is, again, elimination of H. pylori infection. Recall that most peptic ulcers are due to H. pylori. We use a triple therapy again to eradicate H. pylori. This is just like gastritis caused by H. pylori. And again, it's going to consist of a proton pump inhibitor plus amoxicillin plus clarithromycin. Now, if a patient is, again, allergic to penicillin, then you can use metronidazole in place of that amoxicillin. Surgery might be required to repair acute perforations. If you have a persistent or non-neoplastic refractory case, that might require a parietal cell vagotomy or an antrectomy. So if you have a terrible ulcer situation, you can actually take out the gastric antrum. That's one way that you can help cure refractory peptic ulcer disease. You're decreasing the acid production there. The vagotomy works kind of similar. It's going to actually eliminate the parasympathetic stimulation to the stomach, and the result is, again, a big decrease in acid suppression. But both of these are rarely done anymore because proton pump inhibitors and our H2 blockers are actually pretty good at suppressing acid secretion. Let's move on to gastric cancer. So the two types of gastric cancer that you should probably know about is adenocarcinoma, which is the most common one, and then squamous cell carcinoma. Now there are a few subtypes of gastric cancer, but the most famous one is Linitis plastica. So Linitis plastica involves all the layers of the stomach. It's a really bad one, and that Linitis plastica means leather bottle, and that is talking about the appearance of the stomach. It looks very thick. You get decreased stomach elasticity, and unfortunately it comes with a very poor prognosis. So what are the risk factors for gastric cancer? It's going to include things like H. pylori infection. It's one of the few instances where we have an infection that increases cancer rates. Also family history, tobacco use, alcohol use, high consumption of preserved foods like nitrosamines, and then males are more often to get this than females. So what are you going to see in a patient who's coming in with gastric cancer? Well, it can be a little nonspecific, but look for things like weight loss, anorexia, early satiety again, vomiting, dysphagia, epigastric pain. Now you can get what's the enlarged left supraclavicular lymph node. What was that called? That's Wernicke's node. Or you can get the more interesting one, the periumbilical node. Remember, that's called Sister Mary Joseph node. And then what about some labs? You know, you might not see much that's very specific, but do remember CEA. So you might see an increased CEA. Not, again, a very good screening lab because it's not very specific, but it is elevated in about 50% of cases. There's another one called CA19-9, and this is elevated in about 20% of cases. Now, what are you going to see on radiology? Well, a barium swallow again might show a mass or maybe a thickened leather bottle stomach. You can get that Linitis plastica. But again, EGD is going to be our most commonly used study to perform a biopsy to visualize those ulcers and masses in real time. So now how do we treat this? Well, this is going to vary from case to case, but there are some general rules that you can follow here. A subtotal gastrectomy is performed for lesions in the distal third of the stomach, and then you're unfortunately going to have to do a total gastrectomy for lesions in the middle or upper stomach, or if you also have invasive lesions as well. And most patients are going to have an adjuvant chemotherapy and radiation therapy as well. So what about prognosis? Well, in early detection, you actually have a pretty good cure rate, about 70%. Unfortunately, not many people are going to detect this very early on. So you end up with actually an overall pretty poor prognosis for gastric cancer because that later detection is going to drop that survival rate, that 5-year survival rate, to less than 15%. All right, so now let's move on to surgical therapy for obesity. So let's talk about some surgical therapy. Obesity is a big problem in our country. About 1/3 of the population of the United States is considered obese. Another third is considered overweight. And surgical correction for obesity, or sometimes referred to as bariatric surgery, very, very popular. So a Roux-en-Y procedure is where a small gastric pouch is created and then connected to the small bowel. Now the mechanism of weight loss is through malabsorption and restriction, meaning the patient just physically can't eat as much because it makes them ill. Now, bariatric surgery has been shown to provide sustained weight loss, sometimes 30, sometimes even 50% of weight, depending on how big the person was. And patients will have reduction or cure of things like diabetes. They'll have improvement in dyslipidemia, reduction or cure of hypertension, improvement in sleep apnea, and of course, reduced mortality. Now, prior to bariatric surgery, the patient must be referred to a lot of different things. Psychiatry for evaluation of frequent overeating to cope with stress or emotional distress, or to evaluate for a current eating disorder or uncontrolled psychiatric disorder. Depression and suicide might actually decrease in the first year after surgery. These patients have to be on a very restricted diet. It's actually a huge lifestyle change. It can be very abrupt for some people. Complications to these surgeries might include some really impressive nutritional deficiencies. Things like iron deficiency, B12, folate, thiamine, vitamin D. And they can also get some GERD symptoms, especially when they overeat. Patients can get something called dumping syndrome, where food is not processed very well in the stomach, just kind of going on through. It's dumped directly into the intestine downstream, and you get a lot of bloating, a lot of swelling, and a lot of cramping as well. All right, guys, that brings us to the end of the video part. It's time for that end of session quiz. Let's go through those questions together. First question, how do the symptoms of a gastric ulcer differ from the symptoms of a duodenal ulcer based on the timing of pain and the effect of eating upon the severity of pain? So let's start with the gastric ulcer. So the timing of pain is going to be soon after eating, might lead to some nausea and vomiting, might keep you from eating because it hurts. And then for that duodenal ulcer, the pain is going to be typically maybe 2 to 5 hours postprandial. And then for the effect of eating, initially that eating is actually going to improve the pain, and then later again it's going to worsen. Next question. What is the most effective treatment of a duodenal ulcer not due to ZE syndrome? Well, 90+% of these ulcers are going to be due to H. pylori. So you're going to do that triple therapy. Remember, it's going to be a proton pump inhibitor plus amoxicillin plus clarithromycin. Next, what causes pernicious anemia? So remember, pernicious anemia is caused by autoantibodies that destroy gastric parietal cells. So without those parietal cells, there's a deficiency of intrinsic factor. And remember, intrinsic factor is needed for vitamin B12 to be absorbed in the terminal ileum. And then if that all happens, you end up with a megaloblastic anemia. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time. It's time for another warm-up. Let's get going. Which medications are used in the treatment of granulomatosis with polyangiitis? So that's also referred to as Wegener granulomatosis. So this is treated with steroids and an immunosuppressant, classically cyclophosphamide. So remember, steroids plus cyclophosphamide. Next, how can the flushing reaction of niacin be prevented? Well, you can potentially treat this with aspirin. So pre-treat with aspirin. So have the patient take an aspirin maybe about half an hour or so before the niacin. Consider using an extended release formulation. So these seem to have less associations with flushing. So that's an extended release niacin. Another strategy is to have the patient take the niacin at bedtime with the hope that they'll just sleep through the reaction. And then with long-term use of niacin, that flushing might actually improve over time. So you might just need some time to get through it. Next, a patient presents with dysphagia, and the barium swallow shows a corkscrew pattern of the esophagus. What is the most likely diagnosis? Well, this is diffuse esophageal spasm. So this is where the esophagus kind of produces an uncoordinated contraction, and this will look like a corkscrew on the barium swallow. All right, that's it for the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here. In this video, we're going to be discussing GI bleeding, or as the hospital administrators and billing experts like to call it, gastrointestinal hemorrhage. This is a very clinically important topic, and you're very likely going to see questions on the evaluation and treatment of a patient with a GI bleed. This is at least a 4-star and possibly a 5-star topic. It's convenient to divide GI bleeds into upper GI bleeding and lower GI bleeding. Upper GI bleeds is bleeding that originates in the esophagus, the stomach, or the duodenum. What anatomic structure marks the boundary between the duodenum and the jejunum? That's the suspensory ligament of the duodenum, or the ligament of Treitz. So any bleeding proximal to the ligament of Treitz is an upper GI bleed. Any bleeding distal to that is considered a lower GI bleed. So that's bleeding from the jejunum, the ileum, the colon, the rectum, or the anal canal. Let's think about what causes upper versus lower GI bleeding. Upper GI bleeding can be caused by esophagitis, esophageal varices, especially in patients with cirrhosis, Mallory-Weiss tears, which are those longitudinal tears in the esophageal mucosa from retching or vomiting, usually seen in alcoholics. Mallory-Weiss tears are pretty uncommon finding overall. Then move on into the stomach, and you can see GI bleeding from peptic ulcer disease, either the stomach or the duodenum, though gastric ulcers are more common and more likely to bleed. Gastritis also can cause bleeding, and gastric cancers or duodenal cancer, though small bowel tumors are relatively uncommon. This list is organized anatomically rather than by frequency. The most common causes of upper GI bleeding is probably a peptic ulcer, followed by esophagitis, and then esophageal varices. Now, it's a little harder to determine what the most common cause of a lower GI bleed is, because you can commonly see minor bleeding from very common things like hemorrhoids, which may not even be reported to the doctor. And there has been some disagreement over the years about whether diverticular bleeding is more common than vascular malformations like angiodysplasia. The most common causes of lower GI bleeding include vascular malformations like angiodysplasias or AVMs, mesenteric ischemia, where there's an embolism or atherosclerosis of the mesenteric arteries leading to bowel ischemia and necrosis, Meckel's diverticulum, which is a diverticulum in the ileum that can contain acid-secreting gastric mucosa, and the ileum is not designed for handling that acid, so the gastric acid wears away at the tissue and causes bleeding. Colon cancer is certainly an important cause of lower GI bleeding, and so is diverticular disease like diverticulosis or diverticulitis, ulcerative colitis, though not as commonly, Crohn's disease as well. And finally, hemorrhoids. The other thing about upper versus lower GI bleeding is that they will often present quite differently, and certainly on step 2, they're going to give you a classic, straightforward presentation. If the patient is vomiting blood, that's called hematemesis, and it's an upper GI bleed. But if the blood has been sitting in the stomach for a while, the gastric acid has oxidized the iron, and it turns dark and kind of chunky. We call that coffee ground emesis because it looks like coffee grounds. This is a type of hematemesis. So again, coffee ground emesis also suggests upper GI bleeding, but it indicates limited bleeding, while bright red hematemesis suggests ongoing bleeding. If the patient has an upper GI bleed but doesn't vomit up blood, where does that blood go? It's got to go down through the GI tract and eventually into the stool. And as that blood is oxidized and digested, what is left over will turn the stool black and tarry and smell really bad. We call that melena. So melena is classically a sign of an upper GI bleed, but you can imagine that with a bleed in the proximal small bowel, there's still enough time for that to break down and cause melena. So, if the patient passes fresh, bright red blood in the stool, we call that hematochezia, not cheesia, and that generally suggests a lower GI bleed, usually a rapid bleed or a heavy bleed. Usually we see bright red blood, we think hemorrhage from the sigmoid colon or below, but if you're bleeding significantly enough, that blood can actually function as a laxative and it will pass through the GI tract very quickly. So you could see bright red blood from an upper GI bleed. You can't always assume that a rectal bleed is lower GI bleeding. It could be an upper GI bleed. Another sign to be on the lookout for in a patient with a GI bleed is hemodynamic instability, either hypotension or tachycardia or both. If you suspect GI bleeding and the patient is tachycardic or hypotensive, you need to start IV fluids right away, because even if you don't see much blood, there could be lots of blood that just hasn't made it through the GI tract yet. If they lose substantial amounts of blood, they'll even become anemic. But remember, you can't tell volume status by a patient's H&H. A patient with an acute hemorrhage could be grossly hypovolemic, but with a normal H&H because they are losing both red cells and plasma. So, how do we manage a patient with a GI bleed? Say you have a patient with hematemesis or melena, so right off the bat you're thinking upper GI bleed. The next question in the study guide says, what are the steps in managing an acute upper GI bleed? The first step is to assess the hemodynamic stability. Do not overlook that. You need to look at the vital signs and check orthostatic vitals, but if the patient is unstable, tachycardic, hypotensive, you must address that first before you scope the patient, before you do anything else. You need to start 2 large bore IVs, and if the patient is unstable, you need to give IV fluids. Most of these patients will be admitted to the ICU for close monitoring, and make sure the patient is NPO, nothing by mouth. And you order blood type and screen in anticipation of possibly needing to start transfusion. A lot of experts are saying that low-risk patients you don't need to transfuse unless the hemoglobin is less than 7, but you want to go ahead and type and cross so that blood's ready. Because again, when you start giving IV fluids and expand that intravascular volume, those red cells may drop or get diluted out, and the hemoglobin may appear much lower. So you're going to go and check a CBC to look at the H&H and also to check for thrombocytopenia. You're also going to check a PT and a PTT and consider giving FFP if the PTT or PTT are elevated. You can also check a BUN or creatinine because the BUN-creatinine ratio may be 20 or higher if the patient is hypovolemic. While you're stabilizing the patient, if you're not sure whether it's an upper GI bleed or a lower GI bleed, you could consider a nasogastric lavage. If the patient is vomiting blood, you know it's an upper GI bleed, but if you say the patient is not vomiting, it's just melena. We said that melena is usually an upper GI bleed, but it could be a high lower GI bleed. Nasogastric lavage means you put an NG tube or a nasogastric tube into the patient's nose, down their throat, down the esophagus, into the stomach, and you flush some saline and then suck that saline out and see if it's bloody. And if it looks bloody or it looks like coffee grounds, you want to do guaiac testing on the aspirate. It could just be red jello or coffee grounds. Make sure it's really blood. Nasogastric lavage can also help determine whether there's ongoing bleeding or if this is an isolated bleed from 2 days ago. And now you're just seeing that melena as some evidence of that. But nasogastric lavage is somewhat controversial because it has not been shown to improve outcomes. So it isn't something that every patient needs, but if you need to confirm the diagnosis of an upper GI bleed or confirm active ongoing bleeding, it is a worthwhile test, especially on your exam. For a known upper GI bleed, we treat empirically with IV proton pump inhibitors like omeprazole, because the most common causes of upper GI bleeding are things like gastric ulcers and esophagitis or gastritis, and you want to shut down that gastric acid production. And if you have an alcoholic or a patient with cirrhosis who is vomiting blood, what other cause of bleeding is high on your differential? Esophageal varices. So in that case, where you have a strong suspicion of variceal bleeding, you're going to give the somatostatin analog octreotide, which will reduce splanchnic blood flow and shut down blood flow to the GI tract. The most important step will be to call the gastroenterologist to do the EGD. And the nice thing about upper GI bleeds is that you can visualize almost the entire upper GI tract with the EGD. You can make the diagnosis, take biopsies, cauterize any bleeding, ligate any bleeding varices, or whatever else needs to be done. So again, the most important first step is to assess the hemodynamic stability, and then, when the patient is stable, do the EGD. Those are the two most important things. The other stuff is important too, but at the bottom line is these patients need a scope. Management of acute lower GI bleeding is a little less straightforward for a couple of reasons. For one thing, we said that hematochezia is usually a sign of lower GI bleeding, but not always. 10 to 15% of the time, hematochezia is caused by upper GI bleeding, especially brisk bleeding. But the good news is that most of the time, patients with lower GI bleeding are hemodynamically stable. So with a lower GI bleed, you still need to assess hemodynamic stability. Order your type-in screen and check the same labs. And if the patient is unstable, in addition to IV fluid resuscitation, an NG lavage can help you rule out an upper GI bleed. And you can do an EGD to rule out an upper GI bleed as well, once the patient has been stabilized. But then you need to take a look at the lower GI tract and start doing a colonoscopy. But that requires a good bowel prep. So you can't just go straight from the ER to the GI lab. You may have to admit the patient and wait a few hours while they chug some Go Lightly and clean out their colon. And another reason that lower GI bleeds are potentially tricky is that while an EGD allows you to inspect as far down as the duodenum, a colonoscopy will only let you look as far as the terminal ileum. That leaves around 20 feet of small bowel that you just can't see with a scope. Now fortunately, lots of things we mentioned as causes of GI bleeding are found in the colon: diverticulosis, ulcerative colitis, and other forms of colitis like ischemic colitis, angiodysplasia, and obviously colon cancer, though colon cancer is more likely to cause slow occult bleeding than massive acute bleeding. So you stabilize the patient and do bowel prep, and then you do a colonoscopy. And the colonoscopy doesn't find the source of bleeding, what options do we have? You can do an angiography, which might help you visualize a bleeding AVM, either in the small bowel or the colon. But if the AVM is bleeding intermittently, you might get unlucky and miss it on the angiogram. So you can do a radionucleotide scan, which is sometimes called a tagged RBC scan. This is where you transfuse RBCs that are radio-labeled with technetium, and then you do a nuclear imaging study to see if there are a bunch of these tagged red cells bunched up in the abdomen. So this might help you localize a small bowel bleed to a particular quadrant, but that's about it. But for tagged red cell scan is helpful for intermittent bleeding. There's also a kind of technetium scan that is used to locate a Meckel diverticulum, which we call a Meckel scan. The technetium is bound to a substance that localizes to acid-secreting gastric mucosa. So here you see a bunch in the stomach and a bunch being excreted in the bladder, and then the arrow is pointing at the focus in the intestine, which is a Meckel diverticulum. And one last option is capsule endoscopy, which is when a tiny camera that's been built into a capsule like a pill, and then the patient swallows it, and it takes pictures a few times a second and sends those pictures wirelessly to a receiver. So once it's finished, you can watch it like a movie. That won't tell you precisely where the small bowel lesion is located, but it can be useful. So again, the big things are to stabilize the patient and rule out a massive upper GI bleed, and then do the colonoscopy. That's it for GI bleeding, so go ahead, work through the end of session quiz, and then we'll go over the answers with you. First question. A 35-year-old man is brought to the emergency department for hematemesis. He vomited blood prior to arrival, then he vomited blood in the triage area, and later he filled an emesis bag with blood. He is drunk and tachycardic. What is the next step in the management of this patient? IV fluid resuscitation. He is tachycardic and it's signaling hypovolemic shock. So the first thing you do is stabilize him. Then you can work up the bleeding. Next question, what is the most common cause of upper GI bleeding? The most common cause is peptic ulcer, and bleeding from gastric ulcer is slightly more common than bleeding from duodenal ulcers. Second most common cause is probably esophagitis, and the third is probably esophageal varices. Next question, a patient comes to the emergency department with hematochezia. What additional physical exam finding would strongly suggest upper GI hemorrhage? What tests could be used to rule out upper GI hemorrhage? In a patient with hematochezia or rectal bleeding, you may be going to think lower GI bleed, but the main finding on exam that would make you think about upper GI bleeding would be hemodynamic instability. Most of the time, lower GI bleeds aren't bad enough to make the patient hemodynamically unstable, and the test you could use to rule out an upper GI bleed would be a nasogastric lavage or an EGD. Last question. How is volume status assessed in a patient with a GI bleed? Same as with a trauma patient. Heart rate, blood pressure, and urine output. That's it for GI bleeding, guys. We'll see you soon.
It's time for another warm-up. Let's get going. First question here, what is the difference between a Mallory-Weiss tear and a Boerhaave tear? So a Mallory-Weiss tear is a superficial tear of the esophageal mucosa, whereas a Boerhaave tear is a full thickness esophageal rupture. So Boerhaave tears are more serious. In fact, these are life-threatening. Next, what is the classic ECG appearance of atrial flutter? So with atrial flutter, you kind of see what's called a sawtooth pattern of the P waves. Next, what is the most appropriate initial treatment for Kawasaki disease? So the treatment is IVIG and high-dose aspirin. So this is one of those few times where you do give aspirin to children. So IVIG plus high-dose aspirin, and this is to prevent the development of coronary artery aneurysms, the feared complication of Kawasaki disease. All right, that's it for the warm-up. Let's get to that video now.
In this video, we're moving from the upper GI tract to the lower GI tract, starting with the small intestine. Now, the small intestine is a major site of absorption of nutrients, so we're going to talk about some diseases of malabsorption. And when you're not absorbing things properly, you get diarrhea, so we're going to talk about diarrhea. But first, let's talk about bowel obstruction, which in a way is the extreme opposite of diarrhea. Small bowel obstruction is potentially a very serious condition. Bowel obstruction is where the bowel is mechanically blocked so that the contents can't keep moving downstream. Now, this is different from an ileus, which is where peristalsis stops, such as after a laparotomy. Bowel obstruction is something blocking or obstructing the bowel either from the inside or from the outside. Now, in your study guide, it says, what are the most common causes of small bowel obstruction? And you can remember these as the ABCs. A is for adhesions following prior surgery. So adhesions are bands of fibrous tissue, like scar tissue. And that's by far the most common cause of bowel obstruction. Up to 70% of bowel obstruction is due to adhesions. B is for bulge, or an incarcerated hernia. And then C is for cancer, especially metastatic tumors, either to the peritoneum or to the small bowel itself. Metastatic colon cancer and metastatic ovarian cancer are particularly notorious for this. But you can also sometimes see primary small bowel tumors that cause some obstruction. Now, overall, tumors cause about 15% of small bowel obstructions. Incarcerated hernias cause about 10%. So everything else we're talking about is small potatoes, relatively speaking. So you've got things like bowel wall inflammation from Crohn's disease, or from appendicitis or diverticulitis, bowel wall hematomas from trauma, strictures from Crohn's disease again, or from prior radiation that can cause some strictures, or strictures from prior surgery, like a surgical anastomosis that scarred down and caused a stricture. You can also have what's called a gallstone ileus, which is where a fistula forms between the gallbladder and the duodenum so that a giant gallstone can pass into the small intestine, and then you get this intermittent obstruction that keeps coming back. And it's called a gallstone ileus, but it's not really an ileus, it's really a bowel obstruction. You can also see a rare thing that's kind of similar called a bezoar, which is an undigested mass of fiber or hair or pills or whatever that sort of sits in the bowel and causes intermittent obstruction. You can also see bowel obstruction from an intussusception, where the gut telescopes on itself, or bowel obstruction from a volvulus, where the bowel twists upon itself. But the volvulus more commonly affects the large intestine than the small intestine. But again, the main causes of small bowel obstruction are adhesions, bulge or hernia, and cancer. So those are definitely the big three to remember, A, B, C. Now let's look at a patient profile which is going to highlight the clinical presentation of small bowel obstruction for you. A 66-year-old woman comes to the physician with 1 day of nausea, vomiting, diffuse abdominal pain, and abdominal distension. She's had no bowel movements or flatus in 2 days. And that's the classic presentation: nausea, vomiting, abdominal pain, abdominal distension, and usually they're not going to be passing any stool or any gas. It's not super specific, but be sure you can recognize that. There's no fever, but she's tachycardic and her mucous membranes are dry. So these patients are often very dehydrated because they're not absorbing fluids and they're sequestering a lot of fluid in the gut. So look for tachycardia, orthostatic hypotension, dry mucous membranes, maybe some tenting of the skin. Her bowel sounds are high-pitched and hyperactive. Now that's the classic description of bowel sounds early on in a small bowel obstruction. Hyperactive, high-pitched, tinkly bowel sounds. Now later on, the bowel sounds may become hypoactive, but the classic description is this high-pitched, tinkly bowel sounds. The abdomen is distended and diffusely tender, and an X-ray of the abdomen shows distended loops of bowel and multiple air fluid levels. So here's a supine X-ray, and you can see that the intestines are really dilated and distended, so we have those distended loops of bowel. And then this is an upright X-ray, and you can still see these distended loops of bowel, but gravity's pulling the fluid down and the gas rises to the top, so then you see all these air fluid levels. And that's what these black arrows are pointing to. Lots of air fluid levels in this image. So the question is, how do we manage a patient with a small bowel obstruction? Well, number one, bowel rest. These patients need to be NPO, nothing by mouth. And because the patient's already likely dehydrated, they need IV fluids, and you need to correct any electrolyte derangements, especially if they've been vomiting a lot. You may need to place an NG tube, a nasogastric tube, and then connect that tube to low intermittent wall suction to help decompress the GI tract and relieve some of the abdominal distension and relieve some of the vomiting. Now, if you're dealing with a partial small bowel obstruction, you may be able to admit the patient and just observe. We generally avoid giving a lot of pain medications if possible, because pain medications can mask clinical worsening of the obstruction. And usually that decompression with an NG tube is going to help more than pain meds. Then the last bullet is surgery, laparotomy and lysis of adhesions. You're going to go to the OR if the patient's worsening, or if there's a complete bowel obstruction, or if there's strangulation and bowel necrosis, then you have to operate. You certainly won't be asked to make that call on step 2. It's a very complex decision that even experienced surgeons agonize over. Should I operate, or should I just wait and see if this resolves on its own? So again, the big points are to be able to recognize the high-pitched bowel sounds or absent bowel sounds, recognize the air fluid levels on X-ray, and then know that if you're going to make the patient NPO, you're going to start IV fluids, you're going to drop the NG tube, and then you're going to get in there and operate if the patient's not getting better in a hurry. Now we're ready to talk about some diseases that cause malabsorption. Malabsorption can present in a lot of different ways depending on what isn't being absorbed. Malabsorption can cause weight loss from not absorbing calories. It can cause edema from protein malabsorption. It can cause diarrhea because the nutrients that remain in the gut represent an osmotic load that pulls water into the colon. And it can cause steatorrhea if fat isn't being absorbed. And then if vitamins and other nutrients aren't being absorbed, that can result in glossitis from B vitamin deficiencies, or it can result in dermatitis from niacin deficiency and also zinc deficiency. Now, with malabsorptive diseases, the location of the GI tract pathology determines what is or is not going to be absorbed. For example, ethanol is absorbed in the stomach. B12 is absorbed in the terminal ileum. But remember, you also have to have intrinsic factor. And intrinsic factor is made by the parietal cells of the stomach. So those two facts are probably worth knowing. But you can remember most everything else is going to be absorbed in the duodenum and the jejunum. Sugars, fatty acids, amino acids, vitamins, minerals, pretty much all are going to be absorbed in the duodenum and the jejunum. So let's talk about some of the specific malabsorption disorders. We're going to start with Whipple disease. Whipple disease is actually a type of infection of the small bowel by a bacteria called Trophæma whipplei, and it mainly affects white men. Now, the most important clinical features are abdominal pain, diarrhea, weight loss, and joint pain. So that joint pain is kind of unexpected. It stands out a little bit. So remember joint pain or arthralgias with Whipple disease. Whipple disease can also cause neurological problems like dementia and cerebellar ataxia. Now, the main way to make the diagnosis is to do an endoscopy and get biopsies of the duodenum or the jejunum. And you're going to see blunting of the villi. And then down in the lamina propria, you're going to see lots of fat droplets. You can see the fat droplets here. And then lots of these swollen macrophages. And these are classically called foamy macrophages. And then when you do a periodic acid shift stain or a PAS stain, all these macrophages are going to really show up bright pink because the macrophages are packed full of the Trophæma whipplei organisms, which you can see. There's also a PCR test that you can perform, but the biopsy and the PAS stain is really considered the gold standard for diagnosing Whipple disease. Now, the treatment is to give IV ceftriaxone followed by 12 months of TMP-SMX. So you have to continue treatment that long to prevent relapse. Next, I want to talk about two unrelated diseases that students sometimes get confused: tropical sprue and celiac sprue. The word sprue comes from an old Dutch name for a disease that caused diarrhea and ulcers in the mouth. And then they later described this chronic diarrheal illness among people who lived in certain tropical regions, and they called it tropical sprue. Now, we don't know exactly what causes tropical sprue, but we think there might be an infectious cause. So this only affects people who live in tropical areas. So it's very rare in the U.S., but you might see it in individuals who lived in the tropics previously, places like Haiti, the Dominican Republic, Puerto Rico, Cuba. It's also very common in India and certain parts of Southeast Asia. So these patients have fat malabsorption, and this leads to steatorrhea and chronic diarrhea. They also have B12 and folate malabsorption, and that leads to megaloblastic anemia. But they usually do not get the neurological symptoms we typically associate with B12 deficiency. These patients can also have carbohydrate malabsorption, they can have protein malabsorption, and that leads to abdominal distension and pedal edema. Now, tropical sprue is basically a diagnosis of exclusion. There's no single definitive test, but the big clues in your test, your exam, are going to be steatorrhea and megaloblastic anemia in a patient who lives in an endemic area, lives in the tropics. The biopsy is going to show blunting of the villi and inflammatory cells in the lamina propria, but that's very nonspecific. Then for the treatment of tropical sprue, there are two big things to remember: tetracycline and folic acid supplements for 3 to 6 months. And then if there's B12 deficiency, you're going to give B12 shots as well.
Now contrast that with celiac disease, which is sometimes called celiac sprue or non-tropical sprue, because this is a chronic diarrheal illness that is not seen in patients from the tropics. Instead, it's mostly seen in whites of Northern European ancestry. Celiac disease is caused by sensitivity to a protein found in wheat, barley, and certain other grains called gluten, specifically a sensitivity to the component of gluten called gliadin. So sometimes this disease is called gluten-sensitive enteropathy. Now, there are several genetic factors involved, and what happens is these individuals consume gluten in their food, and the gluten activates T cells and causes chronic inflammatory changes to the intestinal mucosa, and that leads to malabsorption. Now, clinical manifestations typically include bulky, foul-smelling diarrhea and steatorrhea, and potentially some weight loss. Iron deficiency anemia and osteopenia are fairly common as well. One other classic manifestation you should be familiar with is called dermatitis herpetiformis, meaning it resembles herpes. So dermatitis herpetiformis consists of these itchy, reddish papules and vesicles that are kind of grouped together, usually found on the elbows and the knees. Now, this is a pretty mild case. They can sometimes have lots of lesions, which can be fairly angry looking. To make the diagnosis, there are two main things to remember: serologic testing and biopsy. So the first test in a patient with suspected celiac disease should be an IgA anti-tissue transglutaminase antibody. There's a similar serologic test for anti-endomysial antibodies, but the older anti-gliadin antibodies aren't recommended as a test anymore. It just doesn't have very good positive predictive value. And the antibodies should be measured while the patient is eating a gluten-rich diet, because if they're on a gluten-free diet, the test may come back negative. And then the second test would be to do an EGD and take biopsies of the duodenum, which will show blunting of the villi, just like we've seen in some of these other diseases. So this is normal small bowel, and you can see these huge prominent villi. And then this is a biopsy from a patient with celiac disease, and you can see how smooth the mucosal surface is. Those villi have just been obliterated. Now, lots of things can cause blunting of the villi, but this biopsy plus a positive serology is pretty much diagnostic for celiac disease. And the other thing that's helpful to prove the diagnosis of celiac disease is that the patients get better when they follow a strict gluten-free diet. The serology often normalizes, the biopsy normalizes, their symptoms get better, the diarrhea resolves. It's not an easy diet to follow, but that's the main treatment. And then you can treat the dermatitis herpetiformis with dapsone. That works very rapidly for the skin manifestation, much more rapidly than cutting gluten out of the diet.
Let's talk now about some of the diagnostic tests that might be helpful if you have a patient with chronic diarrhea and you want to work them up for some malabsorptive disease. Besides doing your good history and physical and some basic labs, it can be really helpful to do some testing on the stool itself. So let's talk through some of the stool studies you might see on your exam. You can test the stool for occult blood and also for fecal leukocytes, or fecal white blood cells. And if positive, that's going to suggest an inflammatory process, like inflammatory bowel disease or some type of infection. Now, we're going to cover inflammatory bowel diseases and also gastroenteritis and infections in some other videos. You can also test the stool for fat. We've mentioned steatorrhea several times. You can either do a Sudan stain, which is a qualitative test to identify whether or not there's fat in the stool, basically by looking at the stool under the microscope with a stain that stains fat globules. There's also a quantitative fecal fat test, or they have to collect their stool for 72 hours, and then you can measure the fat content. Now, this is a more accurate test, but the Sudan stain is much simpler to do. Now, if there's fat in the stool, that doesn't prove that they definitely have an intestinal disease. For instance, a patient with pancreatic insufficiency might not be producing any lipase, so that means they're not going to be able to digest fat, so they might wind up with steatorrhea and fat in their stool. So to rule out pancreatic insufficiency, we can test for carbohydrate malabsorption with a D-xylose test. So this is where you have the patient drink 25 grams of D-xylose, then you measure D-xylose in their blood, and also D-xylose can be measured in the urine. So if the patient has something like celiac disease where they just can't absorb any carbohydrates because they've blunted all their villi, that D-xylose is not going to be found in the blood or in the urine. But if the D-xylose test is normal in a patient who also has steatorrhea, that's going to suggest pancreatic insufficiency. Another test for a specific type of carbohydrate malabsorption would be a lactose breath hydrogen test. So think about patients with lactose intolerance. They're deficient in the enzyme lactase, which is the enzyme that allows you to break down lactose in dairy products into glucose and galactose. So when these patients consume dairy products, they can't break down their lactose, so they get diarrhea and they get bloating and they get abdominal pain. Lactose intolerance is kind of a low-grade malabsorptive disease that only bothers patients when they eat dairy products. So to test for this, you can do a lactose breath hydrogen test, where you give them a test dose of lactose to drink, then you measure the amount of hydrogen in their breath. So if they're not able to digest lactose because they're deficient in lactase, the bacteria in the gut start to digest the lactose for them, and that generates a lot of hydrogen and a lot of methane, and you can measure that in the patient's breath. So a high breath hydrogen test suggests lactase deficiency and lactose intolerance. There's also a lactose absorption test where you measure the blood glucose after you give the patient this oral lactose load to drink. So if they have lactase and they're able to break down the lactose, the blood glucose is going to rise. But if they have lactase deficiency, the blood glucose won't rise. They're going to get all those GI symptoms. There's also a stool pH test for lactase deficiency, but that's just not very reliable. Now, while we're talking about lactose intolerance, how do we treat lactose intolerance? Basically by avoiding dairy products, or possibly by taking commercial lactase products that you either take by mouth or you can add to the milk before you drink it. Now, when you have lactose malabsorption or other types of carbohydrate malabsorption, like from celiac disease, those unabsorbed carbohydrates exert an osmotic pressure that draws fluid into the stool, and the diarrhea tends to be watery. And so we call this an osmotic diarrhea. This is why when you give lactulose to a patient with cirrhosis who has hepatic encephalopathy, they're going to get diarrhea. That lactulose is causing an osmotic diarrhea. Milk of magnesia and polyethylene glycol or Miralax work basically the same way. You're putting solute into the bowel lumen that leads to retention of water in the stool. Now, you can contrast osmotic diarrhea with secretory diarrhea, which is where the bowel is actively secreting water into the stool. So, in osmotic diarrhea or malabsorptive diarrhea, when the patient stops eating and stops drinking, the diarrhea stops and the stool volume decreases, right? But in secretory diarrhea, they have this high volume stool output even when they're fasting. So secretory diarrhea can be caused by things like carcinoid syndrome or VIPomas, and certain infections can do it too, like cholera or enterotoxigenic E. coli. So how can you tell osmotic diarrhea from secretory diarrhea? Well, the clinical history of large volume diarrhea that continues even though they're fasting is a pretty good clue for secretory diarrhea. But another way is to measure the stool electrolytes like sodium and potassium and then calculate what we call the stool osmotic gap. To calculate the stool osmotic gap, you take the stool osmolality, which is about 290, and then you subtract 2 times the stool sodium plus the stool potassium. Now, why do you multiply by 2? To account for the anions, chloride or whatever, that's accompanying the sodium and potassium. So normally the osmotic gap is around 50 to 100 milliosmoles per kilogram. So if the stool sodium is 30 and the stool potassium is 75, the stool osmotic gap would be 290 minus 2 times 30 plus 70, which comes out to 80. So that's your stool osmotic gap, and that's normal. Now, if the stool sodium is 20 and the stool potassium is 50, the osmotic gap is 290 minus 2 times 70, which is 150. So that means there's a big gap between the actual stool osmolality and the calculated osmolality, which means that there's some other osmol in the stool, like lactulose or milk of magnesia or carbohydrates or whatever. So when the stool osmotic gap is high, higher than 125, that's an osmotic diarrhea. The gap is high because there are extra osmoles in the stool besides the sodium and potassium. Now, what if the stool sodium is 50 and the stool potassium is 80? That means that the stool osmotic gap is 290 minus 2 times 130, which leaves you with 30. So the stool osmotic gap is low, or less than 50. That means you have a secretory diarrhea. Now, there are very few osmoles in the stool other than the sodium and potassium. Sodium and potassium are being actively secreted, and the water is just following the electrolyte secretion. So be sure you know this formula, know how to use it, and interpret the results. Maybe I shouldn't have eaten that third chili dog. Let's pause and work through the intersession quiz. I'll be right back. All right, first question. What's the most likely diagnosis in each of the following patients? A Caucasian patient with foul-smelling chronic diarrhea and iron deficiency anemia should make you think about celiac disease. Recent immigrant from the Dominican Republic with foul-smelling chronic diarrhea and macrocytic anemia, or specifically megaloblastic anemia, should make you think about tropical sprue. Chronic diarrhea and also arthralgias and ataxia, think about Whipple disease. Remember, malabsorption plus joint pain and neurological disease should always make you think about Whipple disease. Chronic diarrhea with those itchy grouped vesicles on the elbows and the knees, that's celiac disease. Remember, those vesicles are called dermatitis herpetiformis. Next, what's the treatment for Whipple disease? We said ceftriaxone for about 2 weeks, followed by 12 months of TMP-SMX. Next, what's the most important risk factor for small bowel obstruction? Well, what was the number one cause of small bowel obstruction? Adhesions. Remember your ABCs. So the most important risk factor is going to be prior abdominal surgery. Next, what radiographic findings suggest small bowel obstruction? Dilated loops of bowel and air fluid levels on your upright film. And then the last question, a patient with chronic diarrhea has a positive Sudan stain and a normal D-xylose test. What's the most likely cause of malabsorption? Well, the positive Sudan stain tells you there's fat in the stool. Then that normal D-xylose test tells you that carbohydrate absorption is normal. So that means the patient does not have blunting of the villi and distorted intestinal wall architecture. So the most likely cause of this would be pancreatic insufficiency. That's it for now. I'll see you next time.
Let's go over the warm-up. First question, what's the next step in the evaluation of a patient with a pulsatile abdominal mass and an abdominal bruit? So you ought to be thinking about a AAA. So the next step is to check an abdominal ultrasound. Next, what's the treatment for ventricular fibrillation? Well, it's immediate defibrillation. So you shock the patient, then you start CPR for 2 minutes, and then if they're still in VFib, you shock again, and you do 2 more minutes of CPR, and then you give epinephrine. And then you keep shocking every 2 minutes and keep giving epinephrine every 3 to 5 minutes. And after that first dose of epinephrine, you can give amiodarone. And the last question, how do SVR and heart rate in a patient with anaphylactic shock compare to the SVR and heart rate in a patient with neurogenic shock? So both anaphylactic shock and neurogenic shock are caused by massive vasodilation and low SVR. But what about heart rate? Well, the heart rate is usually low with neurogenic shock because neurogenic shock is caused by autonomic dysfunction, which leads to bradycardia. But for most other kinds of shock, including anaphylactic shock, the body compensates for hypotension by raising the heart rate, trying to raise the cardiac output. Now let's move on to the lecture.
Hello everyone and welcome to our Step 2 video on gastroenteritis. Today we're talking about the runs, anal hot chocolate, and my personal favorite, trouser chili. So yes, we're talking about diarrhea today, and we're going to start with our coverage of viral gastroenteritis. So viral gastroenteritis, very common problem that we see in the outpatient setting all of the time, and most of the time, these are self-limited viral infections of the GI tract. Now, the most common cause of viral gastroenteritis in adults is norovirus. Other common causes include things like rotavirus, adenovirus, and astrovirus. Now, rotavirus is probably the most common cause of diarrhea in children worldwide, especially severe diarrhea. But immunization against rotavirus is actually significantly reducing the number of cases in the United States, but still very common. However, determining the precise virus is usually not that useful in most cases because these are self-limited infections that will resolve on their own. So, what are the symptoms of viral gastroenteritis? Well, patients are going to have nonspecific stuff. Nausea, vomiting, diarrhea, abdominal pain. Sometimes you'll get that kind of cramping that goes along with that diarrhea. Myalgias, and then low-grade fever. Now, rarely will patients report blood or significant mucus in their stool. That's going to be more associated with bacterial gastroenteritis, and we're going to cover that in a minute. Now for labs, most everything should be normal. The serum WBC count is often normal. Stool cultures don't really grow anything out. There shouldn't be any fecal white blood cells, or maybe just not very many of them. You can do things like viral cultures on occasion, especially if you're looking for rotavirus during the winter months. But a lot of times, you're not going to be doing any testing at all on these patients because, again, these are relatively mild illnesses. Now for treatment, the most important aspect will be to maintain hydration. As long as someone's able to drink and maybe eat a little bit and maintain their hydration status, most of the time these viral gastroenteritis problems aren't that big of a deal. Antidiarrheal agents are available, but in the vast majority of cases, they're not needed. The same is true for the antiemetics. Sometimes they can be helpful, especially if someone's puking a lot in that acute case of viral gastroenteritis, but again, usually not needed. So, viral gastroenteritis, pretty simple, but I would like to point out just a few details that might come up on test questions. So let's talk a little bit more detail on rotavirus. Again, very common in children. Patients can have profuse diarrhea, and it can actually lead to significant dehydration. Now, often the diarrhea is this kind of bright green or yellow color in appearance, very foul smelling as well, but still no blood in the stool. Now, rotavirus can occur throughout the year, but we tend to see big spikes in the winter months. Rotavirus is one of the few viruses that we can actually identify. You can identify that rotavirus with an ELISA test or with PCR. Now, another common virus is the norovirus. Remember, that's the most common in adults. Vomiting tends to be more prominent and more likely to be the sole presenting symptom. And again, these infections will occur a little bit more often in the winter months, and some even call this norovirus the winter vomiting disease. Okay, so now let's move on to the more interesting stuff, the bacterial gastroenteritis. So this type of gastroenteritis will have similarities to the viral gastroenteritis, but in general the symptoms are going to be a bit more severe. Many of the bacterial causes will present similarly because they're still causing the same diarrhea, but now we're starting to see things that are going to lead to blood and mucus in that stool, but not all of them. So it's not so much knowing that they cause diarrhea, it's knowing the differences in their sources, and then a few of these are going to have very specific signs and symptoms and treatment. So let's go through this in alphabetical order through pathology. So first we have Bacillus cereus, and the source here is going to be fried rice. So if you get a question about reheating rice or rice at a buffet, then think of Bacillus cereus. Now the onset of symptoms is relatively quick. Patients will have symptoms within just hours of eating, and the disease fortunately is self-limited, and the treatment is going to be just maintaining hydration. Relatively mild disease. Next one is going to be Campylobacter. So this is actually a pretty common test question. You'll find this in poultry. It's the second most common foodborne bacterial GI infection. We'll talk about the most common one in just a minute. So with Campylobacter, you can get bloody diarrhea, but not always. Often the diarrhea will still be watery. You do get some abdominal pain, some fever, and there is a rare association with Guillain-Barré syndrome, which will develop about 2 to 3 weeks after the initial illness. It's also associated with reactive arthritis, so be aware of that. Now, most of the time, mild illness will only need to be treated with just hydration. In severe disease, you're going to use something like a fluoroquinolone, like levofloxacin or ciprofloxacin, or if there's a lot of resistance in your community, you can use a macrolide like azithromycin. Moving on to Clostridium botulinum. So botulinum is found in honey and in home canned food. So if you get a question about getting sick after breaking into some canned peaches, then you want to think about botulinum toxin. Now in this case, the patient is ingesting preformed botulinum toxin. They get sick relatively quickly. Now patients will have nausea and vomiting, diarrhea, and what makes botulinum so interesting is that it can cause flaccid paralysis. So this is a bilateral symmetric descending weakness that starts with bilateral cranial neuropathies. Now there's one type of botulinum called infant botulism. So honey is a natural source of clostridial spores, and then those spores will colonize the host GI tract and then release toxin produced in vivo. So that's why you never give honey to an infant under the age of 1. So patients under 1 can't fight off that GI colonization. Now for treatment, patients will need to be monitored very closely. They might even need to be intubated if that weakness is very severe. Botulinum antitoxin is often given as a treatment along with penicillin G. Moving on to Clostridium difficile or C. diff. So you take maybe for another reason some broad spectrum antibiotic that kills off maybe some of the normal flora in the gut, and then you get another bacteria like Clostridium difficile to move into the area. So we call this a super infection. Now the symptoms are going to include watery diarrhea, but sometimes you will get bloody diarrhea as well, and this can be very serious. Patients can develop what's called pseudomembranous colitis. The bacteria causes edema and necrosis of the gut wall, and that's going to look like a membrane, but it's actually just a pseudomembrane. Now for treatment, you want to think of 2 things. The one we use most often is metronidazole, so that's number 1 first line. But the other one is vancomycin. And there's actually a distinction here because a lot of times when we're using vancomycin for our MRSA, very serious infections, we use that IV. But in this situation, we're actually going to give it orally. So vancomycin is actually not absorbed systemically. It stays in the gut, in the GI tract, and it's going to kill this C. diff bacteria while it's in there. So this is really the only time you're ever going to use vancomycin orally for any type of infection. You may be asked which antibiotics most commonly cause C. diff colitis. Well, almost any antibiotic can cause C. diff colitis, but clindamycin is a more common cause that you'll see on your test questions. Next is E. coli, and we'll talk about the 2 most common forms. There's the enterotoxigenic form of E. coli, and that leads to traveler's diarrhea. So this is transmitted through contaminated food and water and is found more often in foreign countries. You hear about this potentially going to Mexico and getting what's called Montezuma's revenge. Now it can be pretty impressive. The symptoms will include a lot of watery diarrhea. You can get some vomiting and some fever. It's pretty terrible. And again, it's self-limited though, and then hydration is about all you need to worry about. Now that's not the case with our other E. coli. This is called enterohemorrhagic E. coli, and the famous one is the O157H7, and it's usually found in undercooked ground beef, and it's due to indirect fecal contamination. So this occurs in processing plants while the beef is being all cut up. If some of the feces from the animal mixes into the meat, then you have the potential for contamination. Now patients usually present with bloody diarrhea. They can become seriously ill. They will have vomiting, fever, abdominal pain, and patients can also get a very serious condition called HUS. So what is HUS? Well, that's hemolytic uremic syndrome. And hemolytic uremic syndrome is characterized by thrombocytopenia, hemolytic anemia, and acute renal failure. So those are the major criteria for HUS. It's even in the name: hemolytic anemia, thrombocytopenia, and acute renal failure. Remember those. And that can lead to death. Now, treatment is going to be hydration and supportive care. So this is such a severe disease. What about antibiotics? Well, antibiotics may actually worsen the symptoms because of toxin release. So treatment options are limited. But remember, ground beef, undercooked ground beef is going to be the buzz word for that. Moving on to Staph aureus. So this is found in room temperature food. Think about chicken, dairy, eggs, or salad that's been sitting out too long at a picnic. And when you're ingesting Staph aureus, it's not the Staph aureus, the bacteria itself, so much that's making you sick. It's the toxins that are produced by Staph aureus, and that causes the very early symptoms. So you get vomiting within just several hours of eating. So it's a very quick reaction. And then you get diarrhea later. Again, this is going to be self-limited. Hydration, there's not a lot that you have to worry about here. That toxin is going to move its way out. So the most important factor to remember here is that rapid onset of symptoms with Staph aureus. Next, we have Salmonella. So this is the most common foodborne bacterial GI infection, and it's associated with raw meat, poultry, but you also see outbreaks linked to fresh produce as well. So patients will get nausea, abdominal pain, and here you can actually get bloody diarrhea. So this is one of those bloody diarrhea scenarios. Patients will also have fever and vomiting. Treatment includes hydration, and the disease is usually self-limited. So you can treat patients who are immunocompromised, and you're going to treat them with fluoroquinolones. But in general, we usually don't use a lot of antibiotics with Salmonella, which seems a little counterintuitive since this is a bloody diarrhea situation. If a patient is severely ill, or again, immunocompromised, then we do use those fluoroquinolones. You can use something like ciprofloxacin or levofloxacin. Now, one thing that we should probably mention right here that we haven't talked about yet is what causes bloody diarrhea in all these scenarios. So when you get infection that enters into the mucosal wall of the bowel, that's when you get the bloody diarrhea and the fever. So if the bacteria or the parasite or whatever stays in the lumen, you can have a lot of localized symptoms, a lot of watery diarrhea. But once you get that invasion of those entities into the mucosal wall, that's when you see a lot of your blood. That's when you're going to see sicker patients. Let's move on to Shigella. So here's another great example of that invasion into the mucosal wall. So this is food or waterborne. Shigella is associated with overcrowding. So this would include areas that don't have the best drainage or plumbing. And this is often referred to as bacterial dysentery. So when you hear the word dysentery being used, think of Shigella. Though there is an amoebic dysentery, and we'll talk about that in just a little bit. Now, symptoms will include fever, nausea, vomiting, severe bloody diarrhea, and abdominal pain. And again, you can have risk of that hemolytic uremic syndrome as well with Shigella. Now, hydration is very important again, but unlike Salmonella, we do use antibiotics for Shigella. First line are going to be the fluoroquinolones again, like ciprofloxacin. You could also use trimethoprim sulfamethoxazole. Moving on to Vibrio cholera. So this is described as rice water diarrhea, and it's usually associated with seafood. In general, all of the Vibrio species are associated with seafood. Now, patients will have copious watery diarrhea, and you'll get dehydrated very quickly. So even though it's not causing that severe bloody diarrhea that we see in some of our other infections, this can still kill you. You can lose so much water so quickly and have severe electrolyte imbalances that are going to occur that this can lead to death. Hydration is critical for survival. Now, you can use things like tetracycline or doxycycline to decrease the disease length, but overall hydration is the key. Now, there's another Vibrio species called Parahemolyticus, which presents pretty similar to our Vibrio cholera. The source, again, is seafood, so think of oysters. So if you hear about oysters, think of those Vibrio species again. Hydration is the key because this is self-limited. And then next we have Yersinia. So Yersinia, think of pork and produce contamination. You can also think of puppy feces or pet feces. So if you hear about a puppy in a question stem in contaminated food, think of Yersinia. Now, patients will have the typical diarrheal symptoms. One mildly unique aspect is about 20% of these patients will have a really bad pharyngitis as well. Now, patients can also get abdominal pain that can even mimic appendicitis. So you can get some right or left lower quadrant pain that's pretty significant, and we call this pseudoappendicitis. Now, treatment again is going to be self-limited and hydration. All right, so we've moved through all the bacterial causes. Now let's move on to the parasitic and protozoan GI infections. The first one we're going to talk about is Giardia lamblia, a very common infection. It's found in surface water, so usually limited to wilderness or other foreign countries. So the scenario that we see on tests is going to be someone who's camping and they're drinking from a stream. So that can be Giardia lamblia. That's not the only thing that can be from streams, but that's pretty common scenario that you're going to want to remember. Now patients will have greasy, very foul-smelling diarrhea, abdominal pain, a lot of bloating, a lot of malaise. Now, cysts and trophozoites might be seen in the stool sample, and this can really mess up your GI tract for a long time. Even after treatment, you're going to have chronic diarrhea and really foul-smelling stuff for a long time. And then the treatment here is going to be metronidazole. You might remember the mnemonic, get on the metro, and that G in that mnemonic is going to stand for Giardia. Moving on to Entamoeba histolytica. E. histolytica, again, this is from water, so you can get this from drinking from streams as well. So think of streams being associated with E. histolytica and also Giardia. Poor sanitation is another association. This is what is called amoebic dysentery. So what was our bacterial dysentery? Remember, that was Shigella. So now we're talking about amoebic dysentery, and that's going to be E. histolytica. Now, patients present with mild to severe bloody diarrhea, and this can invade the mucosa of the bowel wall. Patients will have abdominal pain. Again, cysts and trophozoites are going to be seen on the stool samples for diagnosis. If you get a more severe version of E. histolytica, it can actually lead to liver abscesses. So if you get a patient who comes in with right upper quadrant pain, you see an abscess in the liver, and they're having diarrhea, you want to think of E. histolytica infection. So how do we treat this? Again, we're using metronidazole. You could also use paromomycin. So the entamoeba is the E in the get on the metro mnemonic. Moving on to cryptosporidium. So this is a food or waterborne disease. You'll see this most often in immunocompromised patients. So if you hear of an HIV or an AIDS patient with severe diarrhea, the first thing I want you to think of is cryptosporidium. Now patients will have watery diarrhea, abdominal pain and malaise, and acid fast stain of the stool is going to show parasites. And the treatment here is going to be nitazoxamide. Next, we have trichinella. So this is from undercooked pork. Patients are going to have fever, malaise, periorbital edema, and eosinophilia. That's one of the unique aspects here. And this is a worm, so we're going to use our bendazole. So remember that worms are bendy, so you're going to use bendazoles for those. So think of albendazole, mebendazole as your primary treatment. You can get some CNS and some cardiac symptoms as well with this one. Next, let's move on to Tinea solium. So this is another worm, and it's associated with undercooked pork again. So patients will have maybe mild diarrhea, but the interesting thing is CNS symptoms. Now the terminology can get a little bit tricky here. If an adult is just carrying the adult tapeworm only in the gut, then we call this teniasis. Now, if a patient ingests the eggs of Tinea solium, then eventually those cysts can be formed in the muscles and in the brain. Now, when the cysts are only found in the muscles, then we call this cysticercosis. Now, if those cysts are also infecting the brain, then we're going to call that neurocysticercosis. And that's obviously a more serious scenario. So a little bit of terminology there. Try to remember that. So you can use praziquantel if you just have a gut infection, but if you do get cysts into the CNS, that's a more serious infection, we're going to want to use things like albendazole, and then you can also add on corticosteroids on top of that as well. So we just covered a ton of detail on individual pathogens, but the presentation is often the same initially for all these infections. Patients are having GI symptoms. So what's the next best step when a patient presents with acute diarrhea? So let's kind of go through an algorithm here that you might need to know for your test. So first, every patient with gastroenteritis will benefit from rehydration therapy. So that's consistent among all patients. Next, we need to divide our patients into severe or non-severe illness. So patients with severe illness are going to include patients with hypovolemia, bloody stools, fever, if you have more than 6 unformed stools per day, if the duration of the whole illness is more than a week, or if you have severe abdominal pain, older age, or if you're an immunocompromised patient. If you have non-severe symptoms, you don't have any of that stuff, then you can just continue symptomatic therapy and likely you're going to get better on your own. So what are you going to do with all these severe patients? Well, first, you're going to order some studies, and this is going to include fecal leukocytes. You're also going to get a stool culture. Maybe you're going to get the ova and parasite panel if that patient is going to be immunocompromised or if they're at high risk of a waterborne illness like something like Giardia or E. histolytica. Maybe they've been camping for the last week. And then you would consider testing for C. diff in a patient who is recently on antibiotics. So we're ordering some tests on our severe patients. Now, while we're waiting for our studies to come back, we need to decide which patients need immediate empiric antibiotics. There are some situations where you don't wait for the cultures to come back. If a patient has bloody diarrhea, if they have fever, severe dehydration, or is immunocompromised, then you're going to likely want to start empiric antibiotics. And what are you going to do? You're going to do a fluoroquinolone for 3 to 5 days. That's going to be what's recommended. So the scenario where you wouldn't give empiric antibiotics in a severe symptom patient would be probably a patient who's had diarrhea for over a week, but they're really not doing too badly. Then you want to just kind of wait for those studies to come back. Otherwise, you're going to give that patient empiric antibiotics because they're pretty sick. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through that together. First question, what infectious agent most likely corresponds to the following statement? So let's go through all of these high yield statements again. So food poisoning as a result of mayonnaise sitting out too long. Think of Staph aureus, think of salmonella. Next, we have rice water stools. So if you hear rice water, you need to immediately think of Vibrio cholera, but you might also think about enterotoxigenic E. coli. They can kind of mimic each other a little bit. Next, we have diarrhea transmitted from pet feces. Think of Yersinia enterocolitica. Next, we have food poisoning resulting from reheated rice, or maybe rice at a buffet. Remember, that's going to be Bacillus cereus. Next, we have most common cause of traveler's diarrhea. Remember, that's going to be that watery enterotoxigenic E. coli. Next, we have diarrhea after a course of antibiotics. Remember, that's that superinfection caused by Clostridium difficile. Next, we have diarrhea in recent ingestion of water from a stream. So remember our two big ones, that's going to be Giardia lamblia, but if you don't have that option, think about E. histolytica. Next, we have mild intestinal infection that can become neurocysticercosis. So remember, that's the worm, so that's that Tinea solium. Next, we have food poisoning from undercooked hamburger or ground beef. That's going to be your enterohemorrhagic E. coli, very, very serious. Diarrhea from seafood. I want you to think of your Vibrio species. So think of Vibrio cholera or Vibrio parahemolyticus. Next, we have bloody diarrhea from poultry. I want you to think of Salmonella. You can think of Staph aureus or Campylobacter. Next, we have bloody diarrhea and liver abscesses. So that's going to be your amoebic dysentery from Entamoeba histolytica. Diarrhea in an AIDS patient, so anyone who's immunocompromised severely, think of Cryptosporidium. Dehydrated child with greenish diarrhea in the winter months, that should make you think of rotavirus. Next question, what is the treatment for each of the following diarrheal illnesses? So first one, we have E. histolytica. Remember, you're going to use metronidazole. Next, we have Giardia lamblia. Same thing, metronidazole. If you can remember, you might get on the metro. Next, we have salmonella. So salmonella, you're probably not going to use very much. That's a little bit of a trick question. But if you have an immunocompromised patient or a very severely ill patient, they're going to use a fluoroquinolone. Next, we have Shigella. Shigella, you're almost always going to treat, and that's going to be with a fluoroquinolone, typically something like ciprofloxacin. An alternative could be trimethoprim sulfamethoxazole as well. And then for Campylobacter, you can use a fluoroquinolone or you can use azithromycin. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go through this short 3-question warm-up. First question, which type of vasculitis is characterized by weak pulses in the upper extremities? That ought to make you think about Takayasu arteritis. Remember, we sometimes call that pulseless disease. Next, a patient presents with dysphagia, and the barium swallow shows a bird's beak sign in the distal esophagus. So what's the most likely diagnosis? That's achalasia. And the last one, what's the most likely cause of chest pain in a patient with sudden tearing chest pain radiates to the back? Think about aortic dissection. All right, let's move on to the lecture.
Hello everyone and welcome to our video on irritable bowel syndrome and inflammatory bowel disease. Let's get going. So first, let's start with irritable bowel syndrome, or IBS. So this is an idiopathic disorder characterized by chronic abdominal pain or discomfort and altered bowel habits. And about twice as many women as men have IBS, and there is definitely a stress component to this. So symptoms include abdominal pain, some diarrhea and or constipation, bloating, nausea, maybe some mild abdominal tenderness. And there's also other non-GI related symptoms that have been identified with IBS, including things like urinary symptoms. Sometimes patients will have frequency or urgency, and then also symptoms of things like fibromyalgia. Now, the most common diagnostic criteria that you should know about are the Rome criteria. So the current guidelines are called the Rome 3 diagnostic criteria. So what are these? So patients have to experience symptoms of recurrent abdominal pain or discomfort at least 3 days per month for the past 3 months. Plus, they have to have at least 2 or more of the following symptoms. So first one is it's going to improve following a bowel movement. So they're having pain, they have the bowel movement, the pain goes away. Another one is change in frequency of stool. And then the next one is change in the form of the stool. So patients have to have abdominal pain or discomfort and then 2 or more of these other symptoms. So as you can see, there can actually be many different presentations of IBS, and they even have subtypes like IBS with diarrhea predominant, or with constipation predominant, or both, or neither. And that's why diagnosing IBS is a bit tricky. Now, the main thing with IBS is ruling out other pathologies. I tell my patients this is a diagnosis of exclusion. Now, because of that, you should be aware of certain characteristics which are not associated with IBS. They include anorexia, weight loss, malnutrition, progressively worsening pain, pain that prevents sleep, and rectal bleeding. So if you see any of these, your patient has something going on instead of, or at least additional to their IBS. Also, there are certain lab findings that are inconsistent with IBS, things like electrolyte disturbances, anemia, or increased inflammatory markers, things like SED rates. Anytime you see any of those abnormal labs, you probably are not dealing with IBS. Now, in which case, patients will need a colonoscopy or other imaging studies such as abdominal x-rays, abdominal CTs, or barium studies to rule out other GI causes. Now, it's very easy to get bogged down in the details of treatment options for IBS. There are a million of them. Now, here are some of the considerations to know about. So the first step is reassurance from the doctor that although this might be uncomfortable or unpleasant, it isn't going to shorten their lifespan, usually doesn't lead to significant disability. It doesn't carry any higher risk of malignancy either. But they should be validated that it is a chronic problem, and the goal isn't necessarily to cure it, but instead to improve their symptoms and quality of life. Now, they should eat a high-fiber diet. They should avoid gas-producing foods. Avoidance of lactose and gluten has been suggested, but they're still controversial. Psychotherapy might be helpful due to a correlation of IBS with stress and anxiety. So now let's talk about some of the pharmacologic treatments for IBS. Now, for the constipation predominant types, we start with a trial of psyllium, very easily gotten there. If that doesn't work, then polyethylene glycol, which is an osmotic laxative, can also be helpful. Now, beyond that, we do have some relatively newer medications, lubiprostone and linaclotide. They're now being used more and more often. Again, you can only use these medications with the constipation predominant IBS. Now, what about the diarrhea predominant type? Well, we prescribe things like antidiarrheals, so like loperamide, that's just over-the-counter Imodium. There's a newer medication called eloxadoline, which combines a mu opioid agonist with a delta opioid antagonist, and it's showing some more promise as well. And then finally, for the abdominal pain and bloating for either type of IBS, there are antispasmodics. Dicyclamine and hyoscyamin are the most commonly used meds. Antidepressants like the SSRIs might be helpful as well with the pain component of IBS. Now, this isn't the comprehensive list of treatments for IBS, but the more testable of those options. All right, so now let's move on to inflammatory bowel disease, or IBD. Now, don't get IBS and IBD confused. Patients frequently mix these two up. Although the initials are similar, they are very different types of processes. IBS is a functional disorder. The structure of the bowel is pretty much normal in that situation. In IBD, this is an inflammatory disease. So this is where we're going to actually see structural abnormalities. Now, there are two main types of inflammatory bowel diseases, Crohn's disease and ulcerative colitis. Let's compare the two. 2. So first we're going to start off with Crohn's disease. So Crohn's, I want you to think of inflammation everywhere. And this inflammation is transmural inflammation, so inflammation through the full thickness of the gut wall. And other reason to think about Crohn's disease causing inflammation everywhere is that it can take place anywhere throughout the gut, anywhere from the mouth to the anus. Now primarily it's going to be in the small intestine and the large intestines, and most commonly you're going to find this inflammation in the terminal ileum. But even though the inflammation can occur anywhere in the GI tract, it could be just a little here, maybe a little there. It skips around, so we call these skip lesions. So you might have a lesion in the terminal ileum, and then in the sigmoid colon, and then the rectum is spared, and then you see more lesions in the perianal region. So these are skip lesions, remember that. And that sparing of the rectum is actually a pretty classic finding. About half of Crohn's patients who have disease in the colon have absolutely nothing in the rectum. So what is causing this inflammation? Well, we're not certain what the fundamental cause of Crohn's disease is, but there does appear to be a relationship between Crohn's disease and intestinal flora. The body is getting thrown into this cycle of inflammation by the presence of certain bacteria in the gut. Now, because you have this transmural inflammation, the lumen of the gut can potentially be narrowed as the wall of the gut becomes thicker. And one of the ways we identify Crohn's disease is with a barium swallow. So with a barium swallow, you're going to see that oral contrast highlight a normal diameter lumen, and then an area where the lumen is strictured and narrow. And that's called a string sign, because the contrast at this point just kind of looks like a string. Now, another appearance on a barium study is the cobblestone pattern. The cobblestone appearance is produced by barium being dispersed between the edematous inflamed mucosa. Now, clinically, Crohn's can cause lots of problems like stricturing that we just talked about, diarrhea, malabsorption, weight loss. Basically, the inflammation is preventing the enterocytes from functioning normally. Patients may have some heme-positive stools, but they rarely will have grossly bloody stools. Now, Crohn's disease can also cause fissures and fistulas. Now, what kind of fistulas are we talking about? Well, these are abnormal connections between the small intestine and any other structure. It could be an enterocolonic fistula, so that's the fistula between a small intestine and the colon. You can have an enterovesicular fistula, which is a fistula between the small intestine and the bladder. You can have an enterovaginal fistula, you can imagine what that is, and you can have an enterocutaneous fistula, so coming to the skin. Now, in addition to these various GI problems with Crohn's disease, it also causes systemic problems. So it can be associated with arthritis and joint problems. Remember that IBD-induced arthritis is one of the HLA-B27 disorders. So it can also cause things like immunologic disorders. It can even cause dermatological problems, specifically something called erythema nodosum. So those are those kind of red, painful subcutaneous nodules on the shins. So it also increases the risk of colon cancer. Now, not as much as ulcerative colitis, which we'll talk about in just a little bit, but it does increase that risk of colon cancer to some extent. So how do we treat this? Well, for mild disease, there's 5 ASA agents. So ASA is amino salicylic acid. So mesalamine is a 5-amino salicylic acid, and that 5-ASA is very similar to aspirin and the NSAIDs. So it's going to inhibit cyclooxygenase. So it will decrease production of prostaglandins and leukotrienes, and by doing so, it will reduce inflammation. Now, 5-ASA is specifically designed to work in your gut, so it reduces that inflammation locally in the lumen of the gut. The next medicine is sulfasalazine. So sulfasalazine is that same 5-ASA that we just talked about, and it's bound to something called sulfapyridine. So it's a combination drug. So this drug remains bound until it reaches the intestinal flora in the colon, and then both of those drugs get activated there. So sulfasalazine is particularly helpful for Crohn's disease and ulcerative colitis. Now, what other drugs can you use for Crohn's disease? You can use other anti-inflammatories, azathioprine or mercaptopurine or methotrexate, so those can be used, any of those three. Azathioprine tends to be used more commonly. You can also use the anti-TNF agents, things like infliximab, adalimumab, specifically if the patient has an arthritic component to their Crohn's disease. You might be more inclined to go with an anti-TNF agent in that situation. And then good old-fashioned steroids can be helpful for flare-ups, with or without antibiotics as well for acute exacerbations. All right, so that's Crohn's disease. Let's move on and contrast that to ulcerative colitis. So one big thing to keep straight in your mind is that while Crohn's disease gives you that inflammation everywhere scenario, with ulcerative colitis, the inflammation is limited to the colon, period. So it's called ulcerative colitis. So that's pretty easy to remember. It starts in the distal colon and then works its way proximally. So that's the hallmark of ulcerative colitis. And unlike Crohn's, ulcerative colitis does not skip around. It's continuous. It always affects the rectum. There's no skip lesions, no rectal sparing. Now with ulcerative colitis, the inflammation is limited to the mucosa and the submucosa. So Crohn's disease was that transmural, that full thickness inflammation, but UC is mucosal inflammation primarily. Now the underlying problem is an autoimmune disorder rather than a reaction to intestinal bacteria. Now if you did a barium enema, you would see that the haustra of your colon are obliterated and you get what's called the lead pipe appearance of the colon. Microscopically, instead of granulomas, you're going to see crypt abscesses, you're going to see ulcerations, and you're going to see bleeding. Now, complications associated with ulcerative colitis include diarrhea again, especially bloody diarrhea because the rectum is more involved here. You can see malnutrition. You can also have an increased risk of colon cancer, but again, this is much higher of a risk than what we see with Crohn's. Extraintestinal manifestations are a little less common overall in UC, but patients are at an increased risk of primary sclerosing cholangitis, which is scarring and inflammation of the biliary tract. Patients may get a skin condition called pyoderma gangrenosum as well. And again, because of the HLA-B27 association, patients can have sacroiliitis and uveitis. So how do we treat it? Well, you can use one of those salicylate preparations like sulfasalazine that we talked about before, which is the sulfa antibiotic bound to that salicylate, and then when it gets to the colon, the colonic bacteria breaks it apart, and then both become active. Then the other anti-inflammatories can be useful, like 6-mercaptopurine, infliximab, some of the other TNF-alpha inhibitors as well. And then in very severe cases, you can actually remove the colon. And after that procedure, the patient is cured. So you wouldn't want to do that with Crohn's disease because Crohn's disease is just going to come back in a different area. But with ulcerative colitis, only the colon is affected. So if you do a colectomy, that's going to become a curative process. All right, that's it for the video part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through them together. All right, first question. Which form of inflammatory bowel disease causes perianal fissures and fistulas? Remember we talked about that with Crohn's disease. Next question. What are the Rome criteria for irritable bowel syndrome? So patients have to experience symptoms of recurrent abdominal pain or discomfort at least 3 days per month for the past 3 months. Plus they have to have 2 of the following. So symptoms have to improve following a bowel movement, or they have to have a change in frequency of stool or a change in form in stool. So abdominal pain or discomfort, and then 2 more of those other symptoms. Next. Which of the inflammatory bowel diseases is associated with an increased risk of colon cancer? Well, the answer is both of them, but remember that ulcerative colitis is associated with a greater risk of colon cancer when compared to Crohn's disease. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's take a look at the 3-question warm-up. First question, what are the indications for surgical repair of a AAA? So first of all, you're going to repair a AAA that's symptomatic. You're going to repair it if the diameter of the aneurysm is greater than 5.5 centimeters in men or greater than 5.0 centimeters in women. You're going to repair it if it's rapidly enlarging, if it enlarges more than 0.5 centimeters over a 6-month period. And then obviously you'll attempt to repair an aneurysm that is ruptured. Next, where is each of the following types of esophageal diverticulum located? Zenker Diverticulum is located immediately above the upper esophageal sphincter. A traction diverticulum is near the midpoint of the esophagus, and an epiphrenic diverticulum is immediately above the lower esophageal sphincter. And the last question, which type of esophageal cancer is most prevalent in the U.S.? That's adenocarcinoma. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 2 video on large intestine part 1. Dude, put on a shirt. I don't care if Twilight is your favorite movie. Just because it's Casual Friday doesn't mean you can walk around half naked. And stop howling! You're not a werewolf. Man, McGinnis does this every Friday. Well, I guess it's better than My Little Pony Tuesdays. You don't want to know what he wears on those days. Oh! Okay, let's get this over with so I can go wash my eyes. All right, so today we're going to talk about the large intestine, and the first thing we're going to talk about is the ileus. So let's cover the ileus first. So an ileus is a disruption of the normal propulsive ability of the bowel, which is due to decreased peristalsis. Now, it can be caused by a lot of things like infection, ischemia, recent surgery, and that's by far the most common reason for an ileus. Diabetes can actually cause this, or opioid use. But remember, the post-operative ileus, by far the most common cause. Now, a post-op ileus will typically last less than 5 days, and it kind of comes in stages. The small bowel usually recovers first, usually within about 24 hours after that surgery. The stomach is next, somewhere between 48 and 72 hours. Then the large bowel is the slowest to wake up. Sometimes takes 2 to 5 days for that large bowel to wake up. Now, abdominal surgeries obviously are going to be the more likely cause here in this post-op ileus. Now, the patient often complains kind of vague abdominal pain. They are going to have some nausea, some vomiting, some bloating, no bowel movements, obviously, and maybe that inability to tolerate meals. And then on exam, patients will have maybe some decreased bowel sounds for sure, maybe some tenderness, but no rebound tenderness. Now, on radiology, the abdominal x-ray may show mild distension of the affected bowel, air fluid levels. A barium enema can be done. That can help rule out true obstruction. And then for the treatment, there aren't any studies that recommend one definitive treatment for post-op ileus. Now, attempts should be made to decrease or stop opioid use because that's going to make it worse. Patients should receive IV fluids. In most cases, the patient should stop oral feeds. But there are actually a few studies out there that are recommending very, very slow, small feeds, kind of to attempt to stimulate the gut. Now, an NG tube can be placed in patients with severe vomiting, but not always. Serial abdominal exams and imaging should be performed to monitor for worsening conditions, but most often you're really just waiting around until the patient poops. Now let's move on to volvulus. So a sigmoid volvulus occurs when an air-filled loop of sigmoid colon kind of twists about its mesentery. Now you can think of a twisting kind of water hose, which is a perfect example when thinking about a volvulus. Now when the rotation gets more severe, then the patient can have obstruction of the intestinal lumen and then even impairment of the blood supply to the bowel. Now, it tends to occur in elderly patients, but it can also occur in children in association with abnormal colonic motility diseases. Now, patients will present with slowly progressive abdominal pain, nausea, and constipation. Vomiting generally doesn't start for several days. The abdominal x-ray may show a double bubble, which is air proximal and distal to the volvulus. Now, this would indicate more of a mid-gut volvulus rather than a sigmoid volvulus. Also, the double bubble is not really specific to the volvulus. It can also be associated with duodenal atresia, a duodenal web, or an annular pancreas. Also, in a barium enema, you might see what's called the bird's beak of the distal volvulus. Now, you remember there's a bird's beak in the esophagus as well. That was achalasia. Well, this is seen in a volvulus further down. And though that double bubble and the bird's beak are really cool to see, the diagnosis is probably most often made with a CT scan again. So how do we treat our volvulus? Well, a lot of times it's just self-limited and it's going to resolve on its own, hopefully. Now, in patients where it doesn't, and if they don't have signs of gangrene or perforation, you can actually perform a flexible sigmoidoscopy. So this will generally detorse that twisted segment. Now, if you see signs of bowel necrosis or if the sigmoidoscopy is unsuccessful, then you can proceed with laparotomy right then. Now, unfortunately, recurrent volvulus occurs in about 50 to 60% of patients. So therefore, many advise that even after a successful detorsion, so you do everything right with that sigmoidoscopy, that even then, most patients should then still have a laparotomy afterwards and then have a sigmoid resection performed. All right, let's move on to intestinal ischemia. So let's cover this one. This actually has a little bit of a tricky terminology here. Students get tripped up on this all the time. The difference between mesenteric ischemia and ischemic colitis. Well, they are used interchangeably often. Now, generally speaking, mesenteric ischemia is referring to ischemia of the small intestine, and then ischemic colitis is referring to ischemia of the large intestine. Now, I think where the confusion also arises is that there's an overlap of supplying arteries. The superior mesenteric artery supplies the small intestine, and the superior and the inferior mesenteric artery are going to supply the large intestine primarily. Now, damage and even a necrosis of the bowel can occur from inadequate blood supply. And that inadequate blood supply occurs more often in watershed areas where there are fewer collateral arteries. Now, the most common and famous area is going to be that splenic flexure. Now, the decrease in blood flow can result from splanchnic vasoconstriction. It can also be caused by acute arterial occlusion, venous thrombosis, hypoperfusion of the mesenteric vasculature in general. Now, there's also a chronic form of mesenteric ischemia, and that's going to be due to atherosclerosis. Now, intestinal ischemia occurs more often in our elderly patients. And the patients are going to present with abdominal pain that is out of proportion to their exam. So they are writhing in pain, but their exam is really relatively normal. Now, the severity can vary depending on the degree of ischemia, though. And patients with more chronic diseases might just complain of pain after eating. Now, labs are probably going to be nonspecific most of the time, but elevation in WBC count will be associated with more severe disease. Now, plain film x-rays might show dilated loops of bowel again, a bowel wall thickening. Diagnosis is usually made by a CT angiogram this time. Now, treatment will depend on the underlying pathology. If the patient has had venous thrombosis, then they might need chronic anticoagulation. If this is due to an arterial embolization, then surgical laparotomy with an embolectomy is the first-line treatment. If this is a non-occlusive mesenteric ischemia caused by vasoconstriction, then you want to remove any drugs that are causing a potential future vasoconstriction. If there is bowel necrosis, then surgical resection might be needed regardless of the cause. Let's move on to appendicitis. So appendicitis is inflammation of the appendix. So this is one of the most common causes of the acute abdomen. Now, the cause is due to obstruction of the appendix, and this can be due to fecaliths, calculi, lymphoid hyperplasia, especially in kiddos, infection, and tumors. Now, patients will present initially with kind of periumbilical pain, maybe even left-sided pain, and that pain is going to usually migrate to the right lower quadrant. Now, patients will have nausea and vomiting. Fever will actually present a little bit later in the course, usually. Now, remember the famous McBurney point. So it's 2/3 of the distance from the umbilicus to the right anterior superior iliac spine. Now, patients with perforation or very severe disease will have rebound tenderness, indicating inflammation of that peritoneum. Now, the psoas sign is right lower quadrant pain on passive hip extension. Rosving side is going to be the right lower quadrant pain with left lower quadrant palpation. You press over here, you feel it over there. Now, actually, no one's using the obturator sign. It has terrible sensitivity, so you actually stop memorizing that one. Now, on labs, patients will have an elevated white blood cell count with left shift, so meaning there's going to be more bands or immature neutrophils. Now, a higher WBC count will also be associated with perforation. Usually a WBC count greater than about 17,000, going to make you really think that perforation might be going on. Now, a CT scan with IV and oral contrast is most commonly used for a definitive diagnosis. Patients will have an enlarged appendix. You can also see appendiceal wall thickening. Periappendiceal fat stranding is another thing you'll hear, and you might also see the appendicolith as well. And then ultrasound, you're not going to use that quite as often in adults. You're going to use it more often in children. In adults, it's a lot less sensitive. So how do we treat our appendicitis? Well, as always, make sure that you have IV fluids going, you're correcting any electrolyte abnormalities. Next, you're going to need to give perioperative antibiotics. So if it's a non-perforated appendicitis, then you can give a single dose of cefoxitin, or the combination of the ampicillin sulbactam, or the combo of cefazolin plus metronidazole. Now, it changes if this is a perforated appendicitis. So if they have a perforated appendicitis, then you're going to give more broad spectrum antibiotics. You would give piperacillin tazobactam, you would give the ticarcillin clavulanate, or again, the combo of a third generation cephalosporin, something like a ceftriaxone plus metronidazole. And then, of course, you're going to have to take out that appendix. So this can be done open or laparoscopically. Now let's move on to carcinoid tumors. So carcinoid tumors are neuroendocrine tumors that secrete serotonin generally, and a lot of other things too. They most commonly arise from the lungs, from the ileum, from the rectum, and the appendix. Now, the most common tumor of the appendix is a carcinoid tumor. But that's not the most common place to find a carcinoid tumor in the GI tract. The most common place is in the ileum. So carcinoid tumor, more common in the ileum. Now, patients can have very interesting presentations, and they can actually be asymptomatic, especially for the first part, especially if they arise in the gut and have not metastasized anywhere. Because if you have this GI carcinoid tumor, it's secreting that serotonin, as we said before. That serotonin will actually travel to the liver first and be metabolized, making it inert. Now, patients might still have abdominal pain. However, if the carcinoid originated in the lungs or metastasized out of the gut, then you can get what's called carcinoid syndrome. So this is due to the large quantities of serotonin, and those symptoms will include things like flushing and diarrhea, bronchospasm, and even restrictive cardiomyopathy. And that cardiomyopathy doesn't really make much sense in my mind, but it's due to serotonin-induced fibrosis of the valvular endocardium. And there's an old mnemonic that we've used for quite a while now. It's BFDR. And B stands for bronchospasm, F is for flushing, D is for diarrhea, and R is for that right-sided valvular disease and murmurs. So how are you going to diagnose a carcinoid tumor? Well, you might just have to get lucky if the patient is asymptomatic. Maybe you find it on a CT scan while you're looking for something else, or maybe you find it on a screening colonoscopy. But what if you do have a patient with maybe unexplained flushing and diarrhea, and maybe at that point, hey, maybe this could be a carcinoid tumor? What then? Well, you can measure the 24-hour urinary excretion of 5-hydroxyindole acetic acid. So that's 5-HIAA. So what is that? Well, that's actually the end product of serotonin metabolism. So you can measure that, and you can make an assumption there that they have way too much serotonin in the body. If it's high, then you can actually localize the tumor later with a CT scan. So next, how do we treat those carcinoid tumors? Well, if it's a non-metastatic tumor, then generally you're just going to remove it at that point. Now, what about if they have that carcinoid syndrome? Well, we usually give something called octreotide or depolanreotide, which are somatostatin analogs. So remember, somatostatin is a powerful hormone in the body. It acts to inhibit many of the hormones of the anterior pituitary, and it's also going to affect the gut. It tends to suppress many of the gut hormones and decrease GI motility. Patients may also need things like bronchodilators, like beta-2 agonists if they're getting a lot of bronchospasm, and then they can also use anti-diarrhea meds like loperamide. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through those answers together. First question, what is the classic characteristics of acute mesenteric ischemia? So remember, it's pain out of proportion to the exam, which means that they are complaining of a lot of severe pain, but that exam isn't that impressive. There's no rebound, there's no rigidity, maybe even no tenderness on palpation. Next, what is the most common cause of ileus? So remember, in ileus, the most common is going to be abdominal surgery. So in most cases, if you continue with bowel rest and IV hydration, that ileus should resolve within 2 to 5 days. Next question, what unique image can you see on a plain film of a patient with volvulus? So remember, it's that double bubble. So you'll see an air bubble on either side of the twisted part of the bowel. Next, a 24-year-old man has severe right lower quadrant pain that started earlier that day. A CT scan revealed an enlarged and inflamed appendix. He does not have rebound tenderness and is otherwise stable. What is the next best step in the management of this patient? So this patient has appendicitis, so this patient will need to have an appendectomy, but before that he will need pre-operative antibiotics. And since he's not having a lot of rebound, it's probably not perforated, the choices here are probably going to be a single dose of cefoxitin. You could also give them the ampicillin sulbactam combo, or the combo of cefazolin plus metronidazole. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
OMG, those shoes are so cute. Can I try them on? So there's this 20-year-old guy with a lung tumor who was admitted last night. Total hottie. Anyway, on rounds today, Dr. Wilkerson was pimping us on the differential diagnosis, and I was like, bronchial carcinoid, right? And Wilkerson was all like, Miss Taylor, carcinoid tumors account for only 1 to 2% of all lung malignancies in adults. And I was all like, but bronchial carcinoids are more common in late adolescence. And this patient has symptoms of wheezing, flushing, and diarrhea, which suggest hypersecretion of serotonin. And he was all like, but bronchial carcinoid tumors rarely cause classic carcinoid symptoms. But when we checked his labs, his urine 5-HIAA was super high. Booyah! In your face, old man! These shoes totally look cuter on you than me. Don't you think they make my feet look fat? Shut up! But seriously.
Let's go over the warm-up. First question, which vasculitis is characterized by necrotizing granulomas of the lung and necrotizing glomerulonephritis? Well, that's granulomatosis with polyangiitis, or Wegener's granulomatosis. Next, what is indicated by a fall in systolic blood pressure of more than 10 millimeters mercury with inspiration? Well, this is the definition of pulsus paradoxus, which can be seen with cardiac tamponade, and it's also seen with hyperinflation disorders like COPD and asthma. And the last question, what's the clinical definition of hypertension? So in a normal patient without comorbidities, you have to have a blood pressure greater than 140/90 on 3 separate occasions, at least 2 weeks apart. Now let's get started with the lecture.
Hello everyone and welcome to our Step 2 video on the large intestine part 2. Yes, the stunning end. I hope nothing rears up. I don't want to butt up against anything. What could we see when we reach the bottom? Probably just some poop. Maybe some blood. Ooh, maybe some pus. Is it too late to do a foot lecture? All right, let's go. So first we're going to talk about diverticulosis. So a diverticulum is an outpouching of the colonic mucosa and submucosa that then herniates through the muscular layer. Now before I go too much further here, let's make one minor semantic point. If you have one of these, it's called a diverticulum. If you have more than one, then we call it diverticula, not diverticuli, which you'll hear a lot of people say, but the actual plural form is diverticula. Now, we call the condition of many diverticula diverticulosis. Then, if those diverticula get inflamed and infected, then we call that diverticulitis, which we'll talk about next. And don't worry, I'll probably mess up all those words here in a little bit. So, diverticulosis is the presence of these outpouchings, these diverticula. And not only can they become infected, but they can also erode into blood vessels in the colon and actually cause bleeding as well. Now, risk factors include diets low in fiber, high in fat and red meat. Obesity is another risk factor, and older age. Now, it was thought for a long time that seeds and nuts were associated with diverticulosis, diverticulitis, and even diverticular bleeding, but new studies have actually disproven this. Now, most patients with diverticulosis don't even know that they have it because most of the time these are asymptomatic. But if there are symptoms, you're going to see things like occasional cramping, bloating, flatulence, irregular defecation, probable or possible painless rectal bleeding if there's erosion into those vessels again. Now, diverticular disease is the most common cause of acute lower GI bleeding in patients over the age of 40. Now, sometimes with diverticulosis, you might have a vague abdominal discomfort, maybe in the left lower quadrant, and that might actually be relieved with defecation. Now, what do we see on radiology? Well, diverticular disease most frequently occurs in the sigmoid colon, which you see in this image here. Over on the right side of the image, which is the patient's left, you'll see these irregular outpouchings filled with contrast in the sigmoid and descending colon. Now, you can also see the diverticula on colonoscopy. Now, these are routinely seen, incidentally, on just a routine screening colonoscopy. Now, there's not much to do for diverticulosis. We do advise a high-fiber, low-fat diet. Patients with diverticulosis no longer have to avoid seeds or nuts. If there is significant bleeding, maybe you can locate that bleed during a colonoscopy. Then you can actually cauterize or even attempt to sclerose that vessel right then and there. Now, if you can't find it, then you can perform angiography, and then embolization can be attempted. Now, if the bleeding cannot be stopped and it's significant, then maybe even surgical resection might be necessary at that point. So now let's move on to diverticulitis. So this is now an infection or an inflammation of a diverticulum that can lead to things like necrosis or even perforation. Now, we see this much more often in older patients. The mean age is about 63 years. Now, left lower quadrant pain is the classic presentation for diverticulitis, and because of that inflammation, most patients are going to be constipated. The gut doesn't like to maintain normal peristalsis when inflammation is present. Rectal bleeding is actually not that common in diverticulitis. So, an older patient coming in with fever, left lower quadrant pain, constipation should make you think of diverticulitis every time. Now, the lab work might show elevated white blood cell count, maybe with the left shift, but it could be also normal as well. Then on radiology, if there's been a perforation, then there might be free air under the diaphragm. So this is an upright chest x-ray image that shows free air under the diaphragm. So anytime you see this, you know there has to be a perforation of the bowel somewhere. Now this is why we always try to get an upright chest x-ray along with our abdominal x-rays, specifically to look for that free air underneath the diaphragm, which again is evidence of that perforation. Now, most of the time, diverticulitis will be diagnosed by CT scan, so you can do an oral and IV. Contrast with that one, that CT may show localized bowel wall thickening and the presence of those diverticula. Now, colonoscopy might be used to diagnose diverticulosis, but it has no role in the diagnosis of diverticulitis because of the risk of perforation. So how do we treat this? Well, mild cases without perforation can be treated as an outpatient. And this is going to be with bowel rest and antibiotics. So if they're reliable and you can trust them not to eat, you can just tell the patient to stay on liquids for the next several days, usually at least 3. But you also give oral antibiotics. And so which antibiotics are we using here? Well, think about the gut flora. You're trying to wipe out some of the gram negatives and even your anaerobes as well. So it's going to be pretty similar to the antibiotic regimen that we use for appendicitis, but these are oral. So first line is going to be a fluoroquinolone. Something like ciprofloxacin is reasonable. And you're going to combine that with something like metronidazole. Now, if you don't want to give that, you could also do a amoxicillin plus clavulanate combo. Now let's talk about the inpatient treatment of diverticulitis. So when is inpatient admission for diverticulitis indicated? So think about patients who are elderly, immunocompromised patients, patients with significant comorbidities, those with high fever, significant leukocytosis, or patients who are unable to maintain hydration. Otherwise, it can be treated on an outpatient basis. So what are these steps in the inpatient management of diverticulitis? So for those you do admit, you're going to definitely put them on IV fluids. You're going to give them broad spectrum empiric antibiotics. Now you can do the ampicillin plus sulbactam, you could do piperacillin plus tazobactam, or the ticarcillin clavulanate combo. Now, if there are signs of peritonitis, abscess, perforation of the bowel, obstruction, then you need to send them immediately for emergency surgical exploration, and that's usually going to be through a midline incision. And then in terms of complications of diverticulitis, what can happen to you? Well, you can get an abscess. Anytime you have infection in there, you can get an abscess. You can get a fistula, or you could even get really sick and get septic. Let's move on to hemorrhoids. So hemorrhoids are dilations of the rectal veins, which can be the internal or the external rectal veins. So this is normal vasculature. It's just an exaggerated dilation of that same vasculature that's going to cause the problems. Now, internal hemorrhoids arise from the superior rectal veins, which are above the pectinate line. They are painless, important to remember that, and because they're painless, they're a lot easier to treat, those internal hemorrhoids. Now, on the other hand, external hemorrhoids arise from the inferior rectal veins. They're going to be below the pectinate line, and these are going to be much more painful, especially if they're thrombosed. Now, patients will complain of burning and itching in the rectal area. Patients will also have painless, bright red blood that is usually only present on the toilet paper and not mixed in with the stool. Now, for workups and radiology, sigmoidoscopy or colonoscopy can be used to rule out other causes of bleeding, especially in an older patient. You want to make sure that bleeding isn't from something like cancer. An anoscope can be performed in the office to also visualize hemorrhoids as well. So how do we treat these hemorrhoids? Well, first you can do a warm bath. Sometimes these are referred to as sitz baths. You can do a high fiber diet. You can avoid prolonged straining, which might actually exacerbate those hemorrhoids. In the office setting or under conscious sedation, you can put a rubber band around an internal hemorrhoid to cut off the blood supply, and then the hemorrhoid will fall off, and that's a painless procedure. Surgical excision is another option, but that usually comes with significant post-op pain, so we use that as a last resort. Moving on to anal fissures. So rectal conditions here are much more painful. You're going to get a lot of bleeding tears with these as well. And this is a tear of the posterior wall of the anus secondary to trauma during defecation or anal intercourse. So if you're trying to pass something too large to the anus, then that's what's going to really cause this anal fissure. Now, the problem with anal fissures is once you have an anal fissure, it often causes spasm of the rectal sphincter. So whenever you're trying to pass anything through there, you're going to get that. So even if you're passing small stools, it can be very painful because of this irritation, that spasm of the rectal sphincter. So how are you going to treat them? Well, we use stool softeners and adequate hydration. The goal here is to make stools soft and easier to pass. Topical nitroglycerin will help alleviate that spasm. So those are going to be your two first-line agents for anal fissures, stool softeners, and then topical nitroglycerin. Now, another intervention, if the stool softeners and all the nitroglycerin and all this stuff doesn't work, is botulinum toxin injection. That's going to relax the sphincter muscle itself. Now, this acts to, again, prevent that spasm so you don't have so much pain, and it can heal a little bit easier too. And then last line therapy would be a partial sphincterotomy, which may be performed for recurrent fissuring if it just never gets better. The problem with this sphincterotomy is that it carries about a 10 to 30% risk of incontinence, fecal incontinence, so no one likes that. So we try to avoid that if possible. Let's move on to another unfortunate thing, anal rectal abscesses. So this is infection of either an anal crypt or hemorrhoid or hair follicle, and that leads to a larger abscess formation. For the history and physical, significant for a lot of throbbing rectal pain, very, very painful, fever, tenderness on a digital rectal exam. And then how do we treat this? This is really just an abscess, so you have to give antibiotics generally, and you have to drain. Always have to drain out abscesses. Rectal fistula, which is sometimes referred to as fistula in ano. So don't confuse the fistula in ano with an anal fissure. Two very different things. So what is the rectal fistula or the fistula in ano? So it's a formation of a tract, and this can be between the rectum and adjacent structures from an unknown cause, or maybe secondary to inflammation like bowel disease or inflammatory bowel disease like Crohn's disease. So this is an abnormal tract from the rectum, usually to the skin. So it's just another kind of little hole in the skin where you're going to look and you might see stool coming out or just fluid. Sometimes you'll see pus coming out because they do tend to get infected pretty easily. Now, patients will present with mild pain during defecation. It will be much more painful if the area is actually infected. On exam, you're going to see, again, just a little site draining pus or maybe clear fluid. And the treatment is going to be a fistulotomy. So basically, it's going to you're going to go through, you're going to open at that tract all the way back to its origin, and then you just have to wait for it to heal in naturally. Now, with Crohn's disease, if that's the cause here, antibiotics and immunosuppressants usually help as well. Moving on to another unfortunate thing, pilonidal disease. So pilonidal disease, that's the presence of one or more cutaneous sinus tracts in the superior midline gluteal cleft. Now, the obstruction of that sinus tract by hair or debris can actually lead to cysts and abscess formation, so these can also be very painful. They can be asymptomatic though, but obstruction, again, with those sinuses can lead to that pain. Small cysts can progress actually to larger abscesses as well. So these would also need to be incisioned and drained, and after you do that IND, then you're actually going to pack that with sterile packing that needs to be changed pretty frequently as well. Surgical closure of these sinus tracts may prevent recurrence as well. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Let's go through that together. First question here, what are the risk factors for diverticulosis? So you got to think about a low fiber, high fat diet, obesity, older age. Next question, what is the treatment for mild diverticulitis? Remember, it's going to be bowel rest for probably around 3 days, and you can't just do a liquid diet there. And then broad spectrum antibiotics for gram-negative and anaerobic coverage. So most commonly we're going to use metronidazole plus a fluoroquinolone, something like ciprofloxacin. Next, what is the next step in the management of a patient younger than 50 years with minimal bright red blood per rectum? For example, blood that is only seen on the toilet paper after wiping. Well, most likely this is going to be due to hemorrhoids. So the next step is going to be an anoscope, and that's going to confirm the diagnosis. Next, what is the most likely cause of acute pain and swelling of the midline sacrococcygeal skin and subcutaneous tissue? So remember, that midline thing is going to usually be a pilonidal cyst. All right, guys, that brings us to the end of this lecture. I hope you learned something. I'll see you next time.
Straighten up, you pathetic pains in my butt! You! What are the two types of hemorrhoids?
Internal and external, sir.
Very good! How are these two types differentiated?
The location?
More specifically, their position with respect to the what?
The dentate line?
Yes! The dentate or pectinate line, which divides the upper 2/3 and the lower third of the anal canal. Which of these two are more painful?
External, sir, as they are innervated by cutaneous nerves. internal hemorrhoids are innervated by visceral nerves and therefore lack pain receptors, sir.
Very good. Now, if only there were some sort of cream to get rid of you! Now get out of my sight!
Oh, yeah.
It's time for another warm-up. Let's get going. Which vasculitis is characterized by necrotizing immune complex inflammation of the visceral/renal vessels? So this is the characteristic of polyarteritis nodosa. Next, what causes a short systolic murmur at the cardiac apex that decreases with squatting and is sometimes associated with benign chest pain that lasts only a few seconds? So this is mitral valve prolapse, and it commonly also has this kind of mid-systolic click. Now, squatting is going to increase preload, which decreases the murmur in MVP. And then MVP is also associated with benign chest pain, anxiety, palpitations, and/or hyperventilation. Next, what is the most common cause of hypertension in young women? And the answer there is going to be oral contraceptives. All right, guys, that brings us to the end of our warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here. In this video, we're going to be finishing the GI tract by discussing colorectal cancer, which is the third most common cancer in the US and the second most common cause of cancer death overall. So this is really common. Colon cancer is a 4-star or 5-star topic, and you can expect to at least have one question on colorectal cancer, especially screening. You need to know who to screen, when to screen, but we'll get to that later. Let's start with risk factors for colon cancer. When we say colon cancer, we're talking about adenocarcinoma of the colon. So the number one risk factor for developing adenocarcinoma of the colon is the presence of adenomatous colon polyps. There are different types of colon polyps, including hyperplastic polyps, which are not precancerous, and adenomatous polyps, which can be precancerous. There are various histological subtypes of adenomatous polyps, like tubular adenomas, tubulovillous adenomas, and villous adenomas. But the key thing to know is that hyperplastic polyps are not precancerous. If you find a polyp on a colonoscopy and the biopsy comes back as hyperplastic, you don't change the patient's colon cancer screening schedule. There are a couple of hereditary syndromes that increase your risk of colon cancer. We'll talk about those in just a second. Having a family history of colon cancer is a big risk factor, even those without the polyposis syndromes. And having previous colon cancer is a risk factor for developing another colon cancer. Ulcerative colitis and Crohn's disease are both risk factors, though it's more common to have colon cancer in ulcerative colitis than in Crohn's. Being African American is a risk factor. Blacks have a higher risk of colon cancer than any other ethnic group in the United States, and it tends to occur at a younger age. A low-fiber, high-fat diet, alcohol, smoking, and diabetes are all risk factors, and we see plenty of that in the United States. The next item in the study guide covers those hereditary colon cancer syndromes. One of the most important syndromes is called familial adenomatous polyposis, or FAP, which is when you have hundreds of polyps in the colon. On this gross specimen, you can see the surface of the colon looks like a shag carpet made of polyps. And with all these hundreds and hundreds of polyps, it's pretty certain that at least one of them is going to turn into cancer. These patients can also have polyps in the stomach or the duodenum, and they can grow tumors in lots of other places. Some of these patients grow osteomas or bone tumors, others fibromas, lipomas, and other soft tissue tumors, or medulloblastomas. We used to say that patients with familial colon cancer plus a brain tumor had Turcotte syndrome, and patients with familial colon cancer and bone tumors had Gardner syndrome. But both of those terms have kind of fallen out of favor because they usually are just subsets of FAP. So FAP patients have hundreds of polyps like a shag carpet, and the underlying problem is a mutation in the tumor suppressor gene called adenomatous polyposis coli gene, or the APC gene. So if there's a family history of FAP, you can test the patient for this mutation. If the patient has it, you start doing colonoscopies at a really young age, like 10, and see if they start growing polyps. And the treatment for this is to do a prophylactic subtotal colectomy. And hopefully you can wait until the person's out of high school to do the colectomy, because it's hard to go through high school with a colostomy bag. Try to get them through high school if you can. There's another hereditary colon cancer syndrome called hereditary non-polyposis colon cancer, or HNPCC. sometimes called Lynch syndrome. This one is interesting because it does not cause a lot of colon polyps. It is a non-polyposis colon cancer. These cancers arise from normal appearing mucosa, and these patients tend to get colon cancer at the early age, like 40s to 50s, and the colon cancer tends to form in the proximal colon, the right colon, which is unusual because most adenomas and most cancers arise in the distal third of the colon. I'll also mention Peutz-Jeghers syndrome, which doesn't cause colon cancer, but it does cause hamartoma polyps in the GI tract, and a hamartoma is a benign tumor made of normal tissue, but it's disorganized mass of that tissue. The big clue for Peutz-Jeghers syndrome is it causes pigmented lesions of the lips and the oral mucosa. Be sure you can recognize that because it's a big giveaway on the test. Before we talk about the signs and symptoms of colorectal cancer, I want to talk about colorectal cancer screening, which, like I said, is very high yield for your exam. It's relatively easy to find and treat colon cancer long before it becomes symptomatic, and you need to know the screening. So let's take a look at number 6 in your study guide. What are the current recommendations for colon cancer screening in an individual at average risk? So this isn't for patients with a strong family history or patients with FAP. This is for average risk adults. We start screening at age 50. Definitely know that. You're going to discuss with the patient and pick one of these 3 options for screening. The first and best option is colonoscopy. That's the main one for you to remember for the exam. And how often do you do that colonoscopy? Every 10 years for the average risk patient. Sometimes patients will refuse a colonoscopy, and they could choose to do a flexible sigmoidoscopy, which needs to be done every 5 years. Besides being done more frequently, the other big downside to flex sigs is that the patient only goes to the splenic flexure, but about 50% of colon cancers are located proximal to the splenic flexure, so the flex sig is going to miss a lot of colon cancers. A flex sig is usually better than nothing, but in general the colonoscopy is a better way to go. The colonoscopy is also done under conscious sedation, which is way less uncomfortable than a flex sig, which is done without sedation. In practice, you'll find very few people offering flex sigmoidoscopy. A third option would be to do a fecal occult blood testing annually with stool guaiac. This isn't simply collecting a sample during a rectal exam. You have to collect samples from 3 consecutive stools, and you send the guaiac cards home with the patient and have them collect the 3 consecutive samples. Next bullet talks about CT colonography, which is sometimes called a virtual colonoscopy by the public, but some groups list this as an acceptable screening if you do it every 5 years, but other guidelines do not include CT colonography because it hasn't been proven to reduce mortality, and it hasn't been proven to prevent cancers. But it seems to be just as good at detecting cancers as conventional optical colonoscopy. And if you find a lesion on CT colonography, guess what you're going to do next? A real colonoscopy. Then the last bullet says screening should stop when a patient's life expectancy is less than 5 years or at 75, whichever comes first. So for patients that never develop any polyps, that means they should receive one at 50, 60, 70, but usually not after 75. Mind, this is for screening, not if they have symptoms. If they do have polyps on colonoscopy, which is pretty common, you don't wait 10 years to repeat the colonoscopy. It's usually 3 to 5 years depending on how many polyps and what type they are. You don't need to know the details, but just be aware that once you find polyps, you're going to screen a little more frequently. Without going too far down the rabbit hole of crazy details, there's one other special case that you should be familiar with. We're talking about screening in average risk patients, but what about patients who have above average risk because of a strong family history of colon cancer? Not because of some identifiable hereditary syndrome, but say you have a patient whose mother had colon cancer. That's an increased risk, right? Well, the recommendation is that the patient should begin colon cancer screening at either the age of 40, which is 10 years earlier than the average population, or start screening 10 years before the patient is at the age which the first degree relative was diagnosed, whichever comes first. So if you give a patient who is 35 years old and they tell you their mother was diagnosed with colon cancer at 48, when should you screen that patient for colon cancer? Well, you either start at 40 or at 10 years before the age where the relative was diagnosed, whichever comes first. So in this example, the patient's mother was 48, which 10 years before would be 38. Lots of people with early colon cancer are asymptomatic, and fortunately we're able to find those cancers through screening and then treat them. But most cancers are actually diagnosed after symptoms have begun. What are the signs and symptoms to make you think of colon cancer? A big one is GI bleeding. A left-sided colon cancer in the sigmoid or in the rectum might cause hematochezia, where you see red blood in the stool. A right-sided cancer might be more likely to start causing melena, that black, tarry, sticky stool from partially digested blood. Or maybe just iron deficiency anemia. Iron deficiency from occult bleeding is a classic presentation of colon cancer, which is why colonoscopy is almost always part of the workup for iron deficiency, especially in patients over the age of 50. Another symptom might be a change in your stool caliber, especially left-sided cancers. Since the stool is already formed, a left-sided colon cancer can cause pencil-thin stools or even stools that come out flat like a ribbon. And rarely, the patient may have symptoms of bowel obstruction like constipation, abdominal distension, or nausea and vomiting. Another finding that you should be aware of is something called apple core lesion, which you see on barium enema, because the cancer is narrowing the lumen of the colon. Barium enemas are kind of a thing of the past. We used to do them for screening or for diagnostic purposes in patients with pencil-thin stools or iron deficiency. But nowadays, if you suspect colon cancer, you're going to do a colonoscopy, not a barium enema.
I don't always have occult blood in my stool, but when I do, I prefer a colonoscopy. Stay cancer-free, my friends.
What's the next step when you find colon cancer on colonoscopy? You need to stage that cancer with a CT of the chest, the abdomen, and the pelvis to look for evidence of metastasis. You don't need to memorize any of this to staging of any cancers really for step 2, but it's useful to know that regional lymph nodes are involved. That's stage 3. And if there's mets beyond the lymph nodes, that's stage 4. And what organ is most likely the site of distant colon cancer mets? That's the liver. Blood flow from the colon drains to the liver via the hepatic portal vein. So the most common site of colon cancer mets is the liver, followed by the lungs. Another thing to mention is the tumor marker CEA, which is elevated in 70% of patients. We don't use this to make the diagnosis, but you can check the CEA levels at the time of diagnosis and then check it later on to monitor the response to treatment and to monitor the cancer recurrence. But keep in mind that CEA is not specific for colon cancer. It can also be elevated in stomach cancers and pancreatic cancers. So you've done your colonoscopy, the biopsy came back with cancer, and then you did your CT of the staging and you measured the pre-treatment CEA. So what's the next step? After you've staged the cancer, you need to treat it, and the main treatment is surgery. You do a partial colectomy to take out the colon cancer plus a regional lymph node dissection. You need at least 12 nodes to come out. And if the lymph nodes are negative for cancer, what stage is that? That's either stage 1 or stage 2, depending on the depth of the lesion. But with stage 1 or stage 2 colon cancer, you don't need to do anything else. But if the cancer has metastasized to the lymph nodes, that's at least stage 3 colon cancer, which means you need adjuvant chemotherapy after the surgery. And if there are distant mets, that's stage 4, which is generally not resectable cancer. That's why we do staging CT before surgery, so you don't end up doing surgery on someone who you know is going to be unresectable. That stage 4 colon cancer is going to be treated with palliative chemotherapy, although in select patients you can resect the primary cancer and the liver mets, not often, but occasionally. And I will doubt this will be an exam, but 5-fluorouracil is the most common chemo drug used in colon cancer and is part of various regimens for either palliative or adjuvant chemotherapy. The next item in your study guide talks about post-treatment surveillance. When you have a patient who has been treated for colorectal cancer, you need to monitor for cancer recurrence. You check a CEA every 3 to 6 months for at least 3 years. You check a CT of the chest and abdomen every year for at least 3 years, looking for mets. You would also check the CT pelvis if there was a rectal cancer. But for colon cancer, the sigmoid, colon, or higher, a CT of the chest and abdomen is sufficient. And you do a colonoscopy at 1 year following the surgery and following completion of adjuvant chemotherapy, and then repeat the colonoscopy every 3 to 5 years depending on whether or not you found any new polyps. Obviously, if you found recurrent cancer, you would reevaluate and treat that. So that's your surveillance after resection of colon cancer. That does it for colon cancer. Go ahead and answer your end of session quiz, and then we'll go back over the answers. First question, what's the most common histology of colon cancer? It's adenocarcinoma. Next, what cancer marker can be measured to monitor for recurrence of colon cancer? CEA. Next question, what gene is responsible for familial adenomatous polyposis, or FAP? That's the APC gene, adenomatous polyposis coli gene. Next, a 38-year-old man tells you that his father had colon cancer at 62. When should this man have his first screening colonoscopy? Remember, for the average risk patient, we start screening at age 50. But in an individual with family history of colon cancer in the first degree relative, we either start at age 40 or we start 10 years before the age that relative was diagnosed, whichever comes first. So in this question, we're going to start at the age of 40. Last question. For each of the following patients, what is the most appropriate next step? A 68-year-old man with iron deficiency anemia and guaiac negative stool. Regardless of the fact that the stool is guaiac negative, the patient needs a colonoscopy to rule out colon cancer, especially if he's due for screening. Colonoscopy reveals colon cancer in the sigmoid colon. We said that once you've made the diagnosis, the next step is to get a CT of the chest, abdomen, pelvis for staging. You check CEA too, but staging CT is the most important next step. Patient undergoes partial colectomy for the colon cancer. Lymph nodes are positive for cancer. When the lymph nodes are positive, that's stage 3, and that's when you need to start adjuvant chemotherapy to try to kill off any of the micrometastasis that has been too small to see on the staging CT. Last one, patient undergoes partial colectomy for colon cancer. Lymph nodes are cancer-free. That means this is stage 1 or stage 2, and you don't need any further treatment. So at that point, you would just start the surveillance by doing follow-up H&P in 3 months with a CEA. That's it for colon cancer, guys. We'll see you at the next time.
Thwarted you again, evil colon cancer. For I am the APC gene, the famous tumor suppressor.
You think I didn't know you'd be here, APC gene? Well, I came prepared. I have begun mutating you, which you know will cause familial adenomatosis polyposis.
No, I will recommend prophylactic colectomy before the age of 25, which everyone knows is the general recommendation for FAP.
Not that. Anything but that.
Lewis, this is a dorky way to study.
Not dorky. Awesome. Now put your mask back on. Evil colon cancer!
Yes, APC gene. Weak syringe.
It's time for another warm-up. Let's get going. Which vasculitis is characteristic of young male smokers? Well, this should make you think of thromboangiitis obliterans, also referred to as Buerger disease. Next, what is the most likely cause of an active lower GI bleed in a patient over the age of 40? Think of diverticulosis. Next, what is the treatment for Whipple disease? Well, you're going to start off with 2 weeks of ceftriaxone, and then that's going to be followed by trimethoprim sulfamethoxazole, and you have to take that for an entire year. All right, guys, that brings us to the end of the warm-up. Let's get to that video.
Hey guys, Dr. Carmichael here. So far in the gastroenterology videos, we've traveled from the esophagus to the colon and the rectum. But now it's time to look back at some of the parts of the GI system that aren't part of the gut, the pancreas, the liver, and the biliary tract. And in this video, we're going to cover pancreatitis, which is at least a 4-star topic. Pancreatitis is inflammation of the pancreas, which can either cause acute or chronic inflammation. We're going to start with acute pancreatitis. There are a bunch of different things that actually cause acute pancreatitis. The 2 most common causes are gallstones and chronic alcohol use. Lock that in your brain forever, gallstones and alcohol. Those 2 things alone can cause about 75% of cases of acute pancreatitis. And be aware that it's definitely chronic overuse of alcohol that leads to acute pancreatitis, not simple binge drinking. But there are lots of other things that can lead to acute pancreatitis, and the mnemonic is conveniently enough, pancreatitis. Be sure to fill in the blanks in your study guide. The P is for hyperparathyroidism. reminds us that hypercalcemia can cause pancreatitis because when PTH is high, you get hypercalcemia. The A is for alcohol, the N is for neoplasm, like a pancreatic tumor that blocks the pancreatic duct or common bile duct and causes pancreatic juice to back up and start digesting the pancreatic tissue. The C is for cholelithiasis, which is just a fancy word for gallstones. So again, gallstones and alcohol are your two most common causes of pancreatitis. The R is for RX, drugs. There are a handful of drugs that you should remember as potential causes of pancreatitis, especially the NRTIs that we use for HIV, like didanosine, zalcitabine, and stavudine, and also the protease inhibitors ritonavir and sulfonamides. The E is for ERCP, endoscopic retrograde cholangiopancreatogram. ERCP is when you inject contrast into the pancreatic duct in order to visualize it. And that retrograde flow of the contrast is not exactly healthy for pancreas, and you're pushing things in the opposite direction of the way they should be going, and this can sometimes cause acute pancreatitis. The next A in pancreatitis is for abdominal surgery. The T is for hypertriglyceridemia, which is an important classic cause, definitely worth knowing. The I is for infection, to remind you that mumps can occasionally cause pancreatitis. Not that you'll see that much mumps, but you need to know it. The next T is for trauma, because abdominal trauma, like abdominal surgery, can potentially disrupt the normal anatomy and cause problems. The next I is for idiopathic, which is kind of a cop-out, but around 20% of cases are idiopathic, meaning we can't find a specific cause. So the third most common cause of pancreatitis is no identifiable cause. And then the S is for scorpion sting, which is extremely rare. In fact, the scorpions that usually cause this aren't even native to the United States. But I always like to ask pancreatitis patients if they've been stung by a scorpion, just in case. So make sure you know those, especially gallstones and alcohol, hypercalcemia, hypertriglyceridemia, ERCP, and the drugs. Those are the most testable ones. So what does acute pancreatitis look like? How does it present? Patients with acute pancreatitis generally have rapid onset of severe epigastric abdominal pain, which may radiate to the back and often gets worse with eating. Because of this, they often develop sitophobia, or fear of eating. They'll refuse to eat because the eating makes the pain worse, and the pain is bad. They also have severe nausea and vomiting. These patients are often very sick. They can sequester a lot of fluid in the pancreas and in the abdomen, which leads to intravascular volume depletion. So on exam, they may have tachycardia, hypotension, and shock, even multi-organ failure. On physical exam, they may have Colorectal, which is hemorrhage that results in periumbilical ecchymosis, or Gray-Turner sign, which is flank ecchymosis. One student did suggest that you remember that Gray-Turner sign was found on the flanks because you have to turn the patient to see it. Both Gray-Turner sign and Cullen sign are pretty rare, but we always look for them. Labs will show elevated lipase and amylase. Acute pancreatitis occurs because the pancreatic enzymes are leaking into the surrounding tissue, and they digest the pancreatic tissue and the surrounding tissue, and you get pancreatic necrosis. So the serum lipase and amylase will generally be elevated. Now, lots of things will raise serum amylase, including salivary gland pathology. Lipase is much more specific for pancreatitis, so lipase is really all you need, but you may see an elevated amylase too. It's worth mentioning that lipase and amylase can't tell you how severe the pancreatitis is. Patients with mildly elevated lipase may have severe pancreatitis, so don't use lipase and amylase as prognostic indicators. They're good for diagnosis, but they're not good for prognosis. So how can we tell how severe the pancreatitis is? Well, the next bullet point talks about the Ranson criteria, and we'll come back to that in just a second. The single best radiological study for acute pancreatitis is a CT scan, which is very sensitive. The pancreas may look enlarged and inflamed, or you may see a pancreatic pseudocyst. You may also need to check an ultrasound to look for gallstones because, again, gallstones are the most common cause of pancreatitis. If you happen to check an upright abdominal x-ray, you may see a dilated loop of bowel near the pancreas called a sentinel loop. You can also sometimes see an elevation of the diaphragm, and sometimes these patients will have a pleural effusion, which you can see on a chest x-ray. Let's backtrack and talk about the Ranson criteria. Ranson criteria are used to estimate the severity of acute pancreatitis. There are 2 groups of Ranson criteria with a total of 11 values to add up. The first 5 criteria are assessed at admission, and the last 6 are assessed within the first 48 hours. Each of these gets 1 point. So on admission, you can use the mnemonic GA Law, Georgia Law. That stands for glucose greater than 200, AST greater than 250, LDH greater than 350, age greater than 55, and a white blood count greater than 16,000. It's not terribly important to memorize the individual numbers, like an LDH greater than 350 or an AST greater than 250. Just remember what you're looking for. It will be pretty obvious on the exam if it's elevated or not. Those are the Ranson criteria at the time of admission. And then, during the first 48 hours, you can use the mnemonic Calvin and Hobbes. If you don't know who that is, reevaluate your life. Cal is for serum calcium less than 8. H in Hobbes is for hematocrit decrease greater than 10%. O is for a PaO2 less than 60. And the 2 B's are for base deficit greater than 4 and a BUN increase greater than 5. And the S in Hobbes is for fluid sequestration of greater than 6 liters. Basically, if you have to give the patient more than 6 liters of fluid in the first 48 hours of the hospital stay, that is a bad sign. So again, you give 1 point for each criterion, and if that's met, you add them up, and if the Ranson score is 0 to 2, the mortality is 0 to 3%. If the score is 3 to 5, it's 11 to 15%. And if the score is 6 to 11, the mortality is at least greater than 40%. Now, there have been some meta-analysis that suggest the Ranson score is a poor predictor of severity of acute pancreatitis, so lots of physicians don't even use it anymore. But this is one of those classic test questions, so you should know it. Let's talk about the management of acute pancreatitis. Remember, these patients are often very sick, often sick enough to end up in the ICU. You're generally going to treat them pretty aggressively. You're going to hydrate them aggressively with IV fluids. Remember, these patients are sequestering a lot of fluid, and they have to be in shock, so you fill up that vascular space with lots of fluid. You're going to make the patient NPO, nothing by mouth. You may put in an NG tube and apply some NG suction to help drain the gastric juices and help prevent further nausea. You're going to correct electrolyte abnormalities if that's a problem. You're going to use opioids for pain control. Classically, we use meperidine rather than morphine because morphine is known to cause a little more spasm of the sphincter of Oddi, but clinically, that doesn't necessarily lead to worsening of the pancreatitis. So for rounds, that would be a very common PIMP question. Why do we use meperidine? Less spasm of the sphincter of Oddi compared to morphine, but clinically, it makes very little difference. As I said, you're gonna make them NPO, but you need to feed them once the pancreas has cooled off some, and if they're not able to tolerate oral intake, you may want to put in a nasojejunal tube or an NJ tube and feed the patient, nasojejunal feeding or TPN. And you want to put it all the way down the jejunum so that you're getting it tube feeds well past the pancreas. Don't feed them into the stomach, feed them all the way to the jejunum where it won't stimulate the pancreas. Sometimes you can use TPN or total parenteral nutrition. It's better to use the gut when you can, but if they can't tolerate the tube feeds, TPN is a good substitute. If there are gallstones, we mentioned as a common cause of pancreatitis, after the pancreatitis has calmed down, you need to do a cholecystectomy because that will help reduce the recurrence of gallstones and therefore reduce the occurrence of pancreatitis. So take out the gallbladder if they have gallstones causing pancreatitis. I also want to mention some complications of acute pancreatitis. I've mentioned multi-organ failure is possible with pancreatitis. They could develop respiratory failure, renal failure, shock, sepsis, DIC. They could hemorrhage into the pancreas. So again, acute pancreatitis is serious, life-threatening condition. You need to treat these patients aggressively. They can get very sick very, very quickly. They can also develop pancreatic necrosis, a pancreatic abscess, a pancreatic pseudocyst, which we'll discuss later, and recurrent episodes of acute pancreatitis can lead to chronic pancreatitis. Chronic pancreatitis generally occurs when a patient has multiple episodes of acute pancreatitis that result in chronic inflammation and structural damage. They may have chronic pancreatic inflammation and then get acute exacerbations on top of that, so it would be acute exacerbation of chronic pancreatitis. Let's go through this series of questions about chronic pancreatitis in the study guide. Chronic pancreatitis is almost always due to alcoholism. Chronic pancreatitis won't be from didanosine or some other drug. If didanosine is causing pancreatitis, you're going to stop it. If you have gallstones that cause acute pancreatitis, you're going to do a cholecystectomy to prevent more gallstones. So usually, chronic pancreatitis is due to alcohol use or scorpion farming. The symptoms of chronic pancreatitis include recurrent epigastric pain, very similar to acute pancreatitis. The big difference is that in acute pancreatitis, the pain comes on really abruptly and suddenly, and in chronic pancreatitis, the pain becomes more of a chronic and recurrent pain. They can also have nausea and vomiting along with abdominal pain. The other big feature of chronic pancreatitis is fat malabsorption and steatorrhea. The pancreas isn't working, and they aren't digesting fats correctly, so you get fatty stools. The next question, what's the best lab test for diagnosing chronic pancreatitis? Lipase and amylase may be slightly elevated, but the best lab test is fecal elastase. You measure the level of enzyme elastase in a single stool sample, and it will be low in patients with chronic pancreatitis. Definitely know that. That's the most specific and most sensitive test for chronic pancreatitis. On X-ray or CT, you can often see calcifications within the pancreas from chronic inflammation, and the pancreas and pancreatic ducts may be enlarged. Often we'll do an MRCP, which is like an ERCP, but done with MRI technology instead of fluoroscopy and an endoscope. This is an MRCP of a patient with chronic pancreatitis, and this is a coronal slice, so it's oriented as if the patient was standing upright and facing you. You can see the pancreatic duct is all lit up, and it's dilated and somewhat irregular. To treat chronic pancreatitis, first off, the patient needs to stop drinking alcohol. If most chronic pancreatitis is caused by alcohol use, you want to stop alcohol use if you can get your patients to stop drinking. You want to recommend they stop smoking because smoking can contribute to this, and it's awful. We use opioids for analgesia. We need to use supplemental pancreatic enzymes because the pancreas isn't getting any of them out because it's burned out. You can't produce pancreatic enzymes anymore, so you may need to supplement those enzymes. They may need to be given vitamin supplements as well, especially their fat-soluble vitamins, A, D, E, and K. You may need to do some dietary modifications and have the patient start eating small, low-fat meals. And occasionally we do surgery to decompress that dilated pancreatic duct or resect the damaged part of the gland, but those are definitely second-line therapies for patients who fail conservative management. Complications of chronic pancreatitis can include pancreatic pseudocysts, which we're going to talk about next, obstruction of the bile ducts or even the duodenum, malnutrition from malabsorption, glucose intolerance and diabetes if the chronic pancreatitis goes on long enough, and even pancreatic cancer. So let's talk about pancreatic pseudocysts, which we said can develop as a complication of acute or chronic pancreatitis. First off, what is a pseudocyst, and what's the difference between a pseudocyst and a true cyst? A pseudocyst is a collection of fluid, basically pancreatic juice, that is contained by inflammatory tissue like granulation tissue or fibrous tissue. So this is not a true cyst. The wall of a true pancreatic cyst is epithelial tissue. This is a pseudocyst, it's a false cyst. Pancreatic pseudocysts are usually asymptomatic. This is usually just something you discover incidentally on a CT or an MRI, so if it isn't causing symptoms, why do we care? Well, there's several complications that can arise. The pseudocyst can rupture, or it can get infected and become an abscess, walled-off collection of pus that won't resolve until you drain it. You could develop a pseudoaneurysm, where the pseudocyst digests the adjacent tissue and it will erode into a blood vessel, and then it bleeds into the pseudocyst, and that can cause the cyst to expand rapidly, which can be very painful and very dangerous. So those are all complications of a pseudocyst that you need to be concerned about. The other concern is what looks like a pseudocyst on a CT or MRI could really be a cystic pancreatic neoplasm, which is potentially malignant. So, to distinguish a pseudocyst from a cystic neoplasm, you need to aspirate the fluid within the pseudocyst. You can have an interventional radiologist do a CT-guided percutaneous aspiration, where they go through the abdomen and put a needle into the cyst and drain the contents, or you can have a gastroenterologist do an endoscopic ultrasound and aspirate some of the fluid that way. But once you have some of the fluid sample, you can test it for amylase. In a pseudocyst, the fluid is going to be very high in amylase because this is basically pancreatic juice. Then, the treatment for pseudocysts, which may resolve on its own, so we can just watch them, but if there are complications, or if the pseudocyst is causing pain, or if it just isn't resolving over time, you may have to drain the pseudocyst. You can either drain them surgically, or percutaneously, or endoscopically, as we just discussed. Sometimes we aspirate them for diagnostic reasons, and sometimes we drain them for therapeutic reasons. So that's it for pancreatitis. Go ahead and answer your end of session quiz, and then we'll restart the video and go over the first questions. First question. What are the Ranson criteria for determining the prognosis of patients with acute pancreatitis? On admission, the mnemonic is Georgia law, GA law. Glucose greater than 200, AST greater than 250, LDH greater than 350, age greater than 55, and a white blood cell count greater than 16,000. And then, during the first 48 hours, the mnemonic is Calvin and Hobbes. Serum calcium less than 8, hematocrit decrease greater than 10, a PaO2 less than 60, a base deficit greater than 4, a BUN increase greater than 5, and fluid sequestration greater than 6 liters. Next question. What is the treatment for chronic pancreatitis? Stop alcohol consumption, stop smoking, pancreatic enzyme replacement, vitamin supplementation, dietary modification, low-fat diet, small meals, and pain control. And last question, what are the 2 most common causes of acute pancreatitis in the United States? The 2 most common causes are gallstones and chronic alcohol abuse. That's it for pancreatitis, guys. We'll see you at the next time.
It's time for another 3-question warm-up. Let's get going. A 25-year-old man presents with abdominal pain and watery diarrhea after meals. Examination shows fistulas between the bowel and the skin, as well as nodular lesions on his tibias. What is the most likely diagnosis? So this is very classic. A lot of things here that will make you think of Crohn's disease. Next, a South American immigrant has cardiomegaly and achalasia. Which organism is most likely responsible for this patient's disease? So remember about Chagas disease, it makes everything big, which is caused by Trypanosoma cruzi. Next, which heart sounds are considered benign when there is no evidence of disease? So if you have a split S1, no big deal. Split S2 on inspiration, again, no big deal. S3 sound in a patient younger than 40, and then an early quiet systolic murmur. So the key here is when there is no evidence of disease. If there is any evidence of disease with a systolic murmur, then you probably need to evaluate that further. That's it for the warm-up. Let's get to that next lecture.
Hey guys. Dr. Carmichael here, and in this video we're going to be discussing cancers of the pancreas, which include both adenocarcinoma, which is cancer of the exocrine pancreas, and also various cancers of the endocrine pancreas like insulinomas or gastronomas. Let's start with cancer of the exocrine pancreas. Generally, when people say pancreatic cancer, they're talking about exocrine pancreatic cancer, specifically adenocarcinoma. Question number 4 says, what are the major risk factors for adenocarcinoma of the pancreas? The risk factors include family history, chronic pancreatitis, diabetes will increase the risk of pancreatic cancer, and there are more important environmental factors such as tobacco use, a high-fat diet, obesity, and physical inactivity. The usual clinical presentation of pancreatic cancer is abdominal pain, weight loss, and jaundice. That's not terribly specific, but it's enough to point you to the biliary tree area. Most pancreatic cancers arise in the head of the pancreas because that's where the bulk of the pancreatic tissue is found. And as the cancer grows, it causes gradual gnawing epigastric pain, which may sometimes radiate to the back. They often develop anorexia, which leads to weight loss, and maybe some nausea and vomiting. And as that cancer in the head of the pancreas tends to obstruct the common bile duct, which leads to biliary obstruction and jaundice, the jaundice can be pretty severe and come on pretty suddenly. I've heard of a patient that was once seen right after New Year's. She was fine at Christmas, but by New Year's she was bright yellow, and she was dead by April. It moves that fast. On exam, you may be able to feel an abdominal mass, but remember that one of the risk factors for pancreatic cancer is obesity. And frankly, 2/3 of people in the United States are obese or overweight, so that may make it difficult to really feel a mass. You could also feel a palpable, non-tender gallbladder. This is also called a Courvoisier sign. You could feel the gallbladder, but it's not tender. The labs may show hyperbilirubinemia, high alk phos, which is consistent with biliary obstruction. The most important lab for pancreatic cancer is the tumor marker CA19-9. Be sure to know that. CEA may also be elevated, but it's not as specific as CA19-9. You need to know that one. If you have a patient with jaundice and abdominal pain, you'll probably get an abdominal ultrasound to look for gallstones or biliary tract obstruction. And that's not a bad test to start with, although a CT scan is usually going to be the next step. By the time the patient has symptoms, you can usually see a mass in the head of the pancreas, which is what you see here marked with the letter M. And then you can do a biopsy via endoscopic ultrasound, or ERCP, or even a percutaneous needle biopsy. Unfortunately, the treatment options are often pretty limited. Most of the time, by the time the cancer is diagnosed, it's in very advanced stages, and survival rates are pretty abysmal. 5-year survival is less than 2%. So if you have a patient diagnosed with pancreatic cancer, there's a less than 2% chance that he or she will still be alive in 5 years. It's a terrible prognosis, and unfortunately there is no good screening for it. We just don't find it until it's already progressed. The only real chance for cure is surgical resection, which is only an option if there's no metastatic disease. Since most of these cancers are located in the head of the pancreas, the usual approach is to perform a Whipple procedure. A Whipple procedure is where you remove the head of the pancreas and everything around it. The duodenum, the proximal jejunum, the common bile duct, the gallbladder, and the distal stomach. Because all of these structures share a common blood supply, and because there's such a strong potential for localized spread. But it's a huge surgery. Following a successful Whipple, 5-year survival goes from 2% to 20 to 30%. That's better, but even with the Whipple, that means 70 to 80% of people who have successful Whipples are still going to be dead within 5 years. So again, this is a very bad disease. And again, you only do a Whipple procedure if there's no metastatic disease on the CT. And then, after surgery, adjuvant chemotherapy or chemo plus radiation is beneficial. Because even though you can't see mets on the CT, doesn't mean there aren't microscopic mets out there. So adjuvant chemo is to kill those unseen mets. Now, for unresectable pancreatic cancer, which is the majority of patients, we do palliative therapy, which might include stenting of the biliary ducts to relieve jaundice or stenting of the duodenum to prevent duodenal obstruction. They might also need pancreatic enzyme replacement to help relieve things like steatorrhea or malabsorption. I also want to mention specific complication of pancreatic cancer, which is migratory thrombophlebitis called Trousseau syndrome. This is different from Trousseau's sign of hypocalcemia, when you tighten the blood pressure cuff and you get the carpal muscle spasm. Trousseau syndrome is migratory thrombophlebitis, which can be associated with lots of different cancers, but classically pancreatic cancer. And the crazy thing about that, Dr. Trousseau described Trousseau syndrome and made the association with pancreatic cancer. And then later he actually got this migratory thrombophlebitis and recognized his own symptoms, and sure enough he had pancreatic cancer, and then he died from it. That's always made me think about that first-year med student that thinks they have every disease and syndrome they read about. I guess sometimes you do. Now let's talk about tumors of the endocrine pancreas. What's the main hormone you think of that the pancreas produces? It's insulin, right? Well, the most common functional neuroendocrine tumor is not an insulinoma, it's actually a gastrinoma, which is weird because gastrin is normally secreted by the G cells of the stomach and the duodenum, not the pancreas. And by far the most common site of a gastrinoma is the duodenum, but the most common functional tumor of the endocrine pancreas is a gastrinoma. Gastrin is a hormone that stimulates parietal cells in the stomach to secrete gastric acid. So a gastrinoma, a gastrin-secreting tumor, leads to excessive secretion of gastric acid, resulting in peptic ulcers and often diarrhea, which we call Zollinger-Ellison syndrome. You should also be aware that gastrinomas are commonly seen in patients with multiple endocrine neoplasia type 1, and roughly 60% of gastrinomas are malignant. So in a patient with abdominal pain and diarrhea and recurrent peptic ulcers, you should suspect Zollinger-Ellison syndrome. What's the best initial lab test? It's a fasting gastrin level. A normal gastrin level is around 100 picograms per milliliter. So if the gastrin level is greater than 1,000, that's pretty much diagnostic. If the gastrin level isn't quite diagnostic, a second line test would be a secretin stimulation test, where you inject the hormone secretin and then remeasure the gastrin level. Normally, secretin is supposed to make the pancreas suppress gastrin secretion by the G cells, but in gastrinomas, secretin actually stimulates gastrin secretion. So if you do a secretin stimulation test in a patient with Zollinger-Ellison syndrome, you will actually see the serum gastrin levels rise dramatically. Then, after the diagnosis is made, the next step is to try to find the tumor with either CT or MRI or an octreotide scan. The fancy technical name is a somatostatin receptor scintigraphy, or SRS, but mostly you'll hear it called an octreotide scan. This may be the best test because these neuroendocrine tumors can be very small and difficult to locate with conventional radiography like CT or MRI. Octreotide is an analog of the hormone somatostatin, and an octreotide scan is where you inject some octreotide that's been radiolabeled, and then you let that tagged octreotide bind to the somatostatin receptors, which are located in the tumor cells. So here you see an octreotide scan in a patient with a neuroendocrine tumor in the tail of the pancreas, plus several mets in the liver. You can also make out some of the labeled octreotide in the bladder. Another good test is endoscopic ultrasound because you can do a FNA or fine needle aspiration at the same time. How do we treat gastrinoma? We give high-dose PPIs to suppress acid secretion, and sometimes we use octreotide to suppress gastrin secretion, although not all gastrinomas are sensitive to octreotide. And if possible, surgical resection can be curative if there aren't any mets and the tumor can be localized. But like I said, it's sometimes difficult to target these tumors. The rest of these are pretty straightforward and pretty uncommon, and kind of similar in how we approach them. And unlike gastrinomas, these are usually found in the pancreas, almost exclusively in the pancreas. An insulinoma is an insulin-secreting tumor that causes hypoglycemia. You produce a lot of insulin and the blood sugar drops. Besides hypoglycemia, the labs will show an elevated fasting insulin level and also an elevated C-peptide, which is part of the pro-insulin molecule that's cleaved off when insulin is made. So patients who are producing a lot of insulin will have a high C-peptide level. Like a gastrinoma, you want to locate the tumor if possible using either a CT ultrasound, but again, these are often difficult to locate. The best treatment is surgical resection if you can locate the tumor and if there are no mets. In non-resectable disease, you can use a drug called diazoxide, which can reduce insulin release and prevent hypoglycemia. We can also try octreotide, which shuts down production of insulin in addition to gastrin and other hormones. A glucagonoma is a glucagon-secreting alpha cell tumor that causes hyperglycemia. It's sort of the opposite of an insulinoma. These patients have elevated glucagon and it causes hyperglycemia. It may present as refractory diabetes. Another testable presentation is called necrolytic migratory erythema, which is a rash of erythematous plaques on the face, perineum, and extremities. The lesions start in the corners of the mouth and the corners of the eyes, and they grow and expand and migrate, and then they eventually coalesce. But if you see this painful pruritic migratory rash on the face and the perineum, which is kind of unusual configuration for a rash, think about necrolytic migratory erythema and a glucagonoma. Labs will show elevated glucagon levels, and then to locate the tumor, you can use a CT or an MRI or an octreotide scan. Treatment is octreotide to shut down glucagon production and prevent hyperglycemia, and possibly surgical resection, if it's technically possible. Unfortunately, glucagonomas are frequently malignant and are already widely metastatic at the time of diagnosis, and they can carry very poor prognosis. And finally, a VIPoma is a tumor of the islet cells that produces VIP, or vasoactive intestinal peptide. VIP is a gut hormone that does a lot of different things, but one function is the increased secretion of water and electrolytes in the GI tract and to promote gut motility. So these patients with high levels of VIP will present with high volume, watery diarrhea, even when they are fasting. So this is a secretory diarrhea. Labs will show high serum VIP levels and low stool osmotic gap, which goes along with secretory diarrhea. You can try to locate the tumor with CT, MRI, or an octreotide scan, and treatment involves hydrating and replacing electrolytes, especially potassium, because they lose a lot of fluid. Again, octreotide can help shut down hormone production, and surgery is sometimes an option, except that usually this tumor has already metastasized by the time it's diagnosed. That's it for pancreatic neoplasms. Now it's time for the end of session quiz. First question, what procedure is performed to treat an isolated cancerous tumor in the head of the pancreas? It's a Whipple procedure, aka a pancreaticoduodenectomy. Next, what are the most common signs and symptoms of pancreatic adenocarcinoma? Abdominal pain, jaundice, and weight loss. Next question, a 35-year-old woman presents with peptic ulcers, hypercalcemia, amenorrhea. What's the most likely diagnosis? This is a MEN1, multiple endocrine neoplasia type 1. The peptic ulcers are due to gastronoma. The hypercalcemia is due to the parathyroid tumor. The amenorrhea suggests a prolactinoma causing hypogonadism. Next question. What medications can be used to stop insulin production in a patient with an insulinoma? We can use two, diazoxide and octreotide. Last one. What is the most common presenting symptom of a VIPoma? Watery diarrhea. That's it for this video, guys. We'll see you at the next time.
It's time for another 3-question warm-up. Let's get going. What are the 2 most common foodborne bacterial GI infections in the United States? So you got to think about Campylobacter, and the other one is Salmonella. Next, which imaging study is used to diagnose a DVT, or deep venous thrombosis? So that's going to be a compressive venous ultrasonography. So that's where you try to compress the vein while you're watching it with the ultrasound. You won't be able to compress that vein completely if there's a clot present. Next, which class of antihypertensives is contraindicated in pregnancy? So you definitely want to think about the ACE inhibitors and the ARBs. Don't use those. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here, and in this video we're going to be discussing diseases of the gallbladder, starting with gallstones, and then 2 major complications of gallstones, cholecystitis and cholangitis, plus gallbladder cancer. The technical term for gallstones is cholelithiasis. Chole is from Greek for bile, and lithos is stone, so cholelithiasis is gallstones. First question in the study guide says, what are the major risk factors for cholelithiasis? The first few are sometimes lumped together as the 4 F's: fat, fertile, female, and over 40. Obesity and female sex are important risk factors, and so is pregnancy. Pregnancy changes the composition of the bile and also slows gallbladder emptying, both of which promote gallstone formation. So not only are you more likely to get gallstones while you're pregnant, but the more times you're pregnant, the higher your risk factor of eventually getting a gallstone is, which is important because being over 40 years old is a risk factor, and most pregnancies occur in women under 40. But the more times you're pregnant, the higher your risk of gallstones. Other risk factors include oral contraceptive use and estrogen replacement therapy, family history of gallstones, prolonged use of total peripheral nutrition or TPN, and rapid weight loss. And that's another one. And if you go on some crazy diet or have bariatric surgery, you lose too much weight too quickly, that can predispose you to gallstones. Gallstones are often asymptomatic. Having gallstones isn't necessarily a bad thing in and of itself. You might just find them incidentally on a CAT scan or an ultrasound. Or they may cause some dull, postprandial right upper quadrant abdominal pain, which is commonly called biliary colic. It tends to be worse after a fatty meal. You eat a fatty meal, your gut needs some bile to help digest and absorb those fats, so the gallbladder contracts. And it contracts down on those stones, and you get some pain. The patients can also have nausea, vomiting, and possibly some abdominal fullness. The physical exam is generally negative because there's no inflammation of the gallbladder itself. You don't expect to see right upper quadrant tenderness or palpable gallbladder with cholelithiasis alone. To make the diagnosis, you do a right upper quadrant ultrasound. That's the diagnostic test of choice. This big black oblong area is the lumen of the gallbladder. And then these white Hyperlucent areas are gallstones, and they're free floating. So they're sort of settling down in the most dependent part of the gallbladder. Why is ultrasound better than X-ray or CAT scan? Well, most gallstones are made of cholesterol, which is radiolucent. So they won't show up on an X-ray or CT, but you might see some so-called pigment stones, which are radiopaque because they are made of calcium and bile pigments like bilirubin. The treatment for uncomplicated symptomatic gallstones is basically a cholecystectomy. Asymptomatic gallstones are not an indication for surgery. There are a lot of people out there that have gallstones that are completely asymptomatic. So those gallstones that you found incidentally, you don't really need to do anything about those. They only need surgery if they're having symptoms. And the reason we perform surgery is to avoid the complications from gallstones, which can be very severe. Complications include things like acute cholecystitis, cholangitis, which we'll discuss next, and also acute pancreatitis. Remember, we said one of the most common causes of pancreatitis are gallstones and alcohol. Next, let's talk about acute cholecystitis, which is inflammation of the gallbladder. A cyst is a bladder, so cholecyst is the gallbladder. Cholecystitis is inflammation of the gallbladder. It's usually caused by gallstone that obstructs the cystic duct, and then you get inflammation and infection behind that obstruction. But you can also have acalculous cholecystitis, which is gallbladder inflammation not due to stones. This tends to occur in critically ill patients who develop gallbladder ischemia or necrosis, or they're on TPN. The clinical presentation includes severe right upper quadrant abdominal pain, which may radiate to the back or to the right shoulder. They may have fever, possibly nausea, vomiting, anorexia. Physical examination shows tenderness and guarding and something called a positive Murphy sign. Murphy sign is where you're palpating the right upper quadrant, and when you ask the patient to take a deep breath, the diaphragm pushes the liver and the gallbladder down so that the inflamed gallbladder is pushed against your hand. So when they inhale, they catch their breath and stop inspiration because of the pain from the gallbladder hitting your hand. That's a positive Murphy sign, which indicates acute cholecystitis until proven otherwise. So remember, Murphy sign and acute cholecystitis. The lab work is kind of nonspecific. Patients will often have leukocytosis with a left shift, but bilirubin and alk phos are usually not elevated. If they are elevated, it would make you think of cholangitis or biliary obstruction further down the biliary tree. To make a definitive diagnosis, you need an ultrasound of the gallbladder. So what ultrasound findings are diagnostic of acute cholecystitis? If you have the right clinical presentation, right upper quadrant pain and fever, with gallstones and thickening of the gallbladder wall, that's cholecystitis. Another diagnostic clue is a sonographic Murphy sign. This is the same as a Murphy sign, but instead of palpating with your hand, it's the ultrasound tech palpating with the ultrasound probe. And a sonographic Murphy sign may actually be somewhat more valuable than a physical exam Murphy sign because with the ultrasound, you can see exactly what you're touching when they have the pain. Now say you have a patient with fever, right upper quadrant pain, and you strongly suspect cholecystitis, but the ultrasound is equivocal. It's not 100% clear. Well, the next test that you might order is a HIDA scan. A HIDA scan will detect obstruction in the cystic duct because the gallbladder fails to fill normally during the scan. Let's skip down to the next question and talk about the HIDA scan in a little bit more detail. The other name is cholecystography. A HIDA scan is a nuclear medicine study using technetium-labeled hepatic aminodiacetic acid. HIDA stands for hepatic aminodiacetic acid. So this technetium-labeled HIDA is given IV, and then it gets taken up by the hepatocytes and excreted into the bile so that you can visualize the gallbladder. And inability to visualize the gallbladder with this test indicates cystic duct obstruction, usually from acute cholecystitis or an obstructing stone. This is a HIDA scan from a 35-year-old woman with Crohn's disease who is having abdominal pain. So they injected the HIDA and scanned her at 15 minutes. And you can make out the outline of the liver because the hepatocytes are taking up the HIDA. And then this dark spot is the gallbladder where all that HIDA is being dumped into the bile. So it's concentrating into the gallbladder. Then they scanned her again at 30 minutes. And here there's less HIDA in the liver and more in the gallbladder. And you can also start to see some of it coming out of the gallbladder and into the duodenum. Then at 45 minutes, there's more in the small bowel and very little in the liver at this point at all. And then at 60 minutes, they give her a shot of CCK, cholecystokinin, which makes the gallbladder contract. And they measure the amount of HIDA that is ejected into the small bowel at that point. So this is a normal HIDA scan because the cystic duct is not obstructed. So how do we treat acute cholecystitis? The shorter answer is a cholecystectomy. The conventional wisdom used to be to give the patient antibiotics for a few days and let the acute inflammation cool off for a day or two. Then, after 24 to 48 hours, you would do the cholecystectomy. But in the last 4 to 5 years, there have been studies showing that most patients, those who aren't actually acutely ill with organ failure, they do just as well when you do the cholecystectomy right away. Patients who are critically ill, who aren't stable enough for surgery, are usually treated with antibiotics plus biliary stenting to bypass the obstruction of the cystic duct and allow the gallbladder to drain. Another potential complication of cholelithiasis is acute cholangitis. Cholecystitis is infection of the gallbladder, but cholangitis is infection of the bile ducts. Angio means vessel, like angiography, is looking at blood vessels, so cholangio means bile ducts, and cholangitis is infection of the bile ducts. What happens is that there's bile duct obstruction, most commonly from gallstones that get out of the gallbladder and the cystic duct and get into the bile duct system. And then the biliary tree proximal to that obstruction can become infected. And besides gallstones, other potential causes of bile duct obstruction include biliary strictures and cancer, either bile duct cancer or possibly pancreatic cancer. These patients can present with a triad of fever, jaundice, and right upper quadrant pain. That's called Charcot's triad. Make sure you know that. If you see fever, jaundice, and right upper quadrant pain, that's cholangitis until proven otherwise, especially on your exam. Now in real life, patients may not present with all three. For instance, only 60 to 70% of these patients with cholangitis have jaundice, but for your exam, you need to know that triad. You can also take it one step further, which is called Reynolds pentad. A pentad is 5 things, right? So Reynolds pentad is Charcot's triad, fever, jaundice, and right upper quadrant pain, plus 2 more, mental status changes and hypotension or shock. Lab work will show leukocytosis, and usually the conjugated bilirubin and alk phos will be elevated because bile is backing up into the liver, which is called cholestasis. You may also see elevated AST and ALT, which would indicate some hepatocyte damage. You also want to check blood cultures, which may help you narrow down your antibiotic choices. These are bacteria from the GI tract, so we're talking about E. coli, Klebsiella, Enterococci, and possibly some anaerobes. If you suspect cholangitis from Charcot's triad plus the labs, the best test is probably an ERCP. An ultrasound may show some dilation of the bile ducts proximal to the obstruction, but an ERCP is going to give you a much better look and help you see exactly where that obstruction is. Plus, an ERCP will allow you to remove the stones or put in a biliary stent to relieve the obstruction. So the treatment is broad spectrum antibiotics, either something like piperacillin tazobactam or levofloxacin, initially until your cultures come back, plus endoscopic biliary drainage with an ERCP, and then eventually, once everything is cooled off in these patients, you need to do the cholecystectomy so they don't have any more stones. Finally, let's discuss gallbladder cancer, which is about 90% adenocarcinoma. It's not very common, but it has a very poor prognosis. Lots of gallbladder cancers aren't diagnosed until the cancer has already progressed, and even stage 1 cancers that you catch very early have about a 50% mortality at 5 years. Stage 4 cancers have about an 85% mortality at 1 year, and at 5 years the mortality is 98%. So this is a really aggressive cancer. The number 1 risk factor by far is gallstones. Chronic infection and biliary tract disease like gallbladder polyps or biliary cysts can also increase your risk, but gallstones is the biggest risk factor. Basically, all those recurrent episodes of irritation and inflammation increase the risk of malignant transformation. Most of these cancers are asymptomatic, but if the symptoms are present, they may include abdominal pain, jaundice, weight loss, and vomiting. You may feel a palpable gallbladder on the exam. Labs will show cholestasis with elevated bilirubin, alk phos, but the white blood cell count is typically not elevated because this isn't an infection. An ultrasound, either transabdominal ultrasound or an endoscopic ultrasound, will show a gallbladder mass or thickening of the gallbladder wall, possibly calcification of the gallbladder, which is called a porcelain gallbladder. A porcelain gallbladder is usually seen with chronic cholecystitis, but 10 to 30% of the time it may represent cancer. So whenever you see a porcelain gallbladder, you need to do the cholecystectomy, and then you can examine this tissue under a microscope to look for cancer. We don't really biopsy the gallbladder, we just take out the whole thing and examine the whole thing. The treatment is cholecystectomy, plus lymph node dissection and removal of the adjacent hepatic tissue in the gallbladder fossa. It depends on the tumor stage, which is determined by how much of the thickness of the gallbladder wall is invaded by the cancer. And the following surgery, you can give chemo and radiation to reduce recurrence, and if you aren't able to resect the cancer, you would definitely give radiation and chemo. Before we do the end of session quiz, let's do a quick whiteboard review. We've discussed 4 different diseases, so in this review, we're going to build the presentation. With cholelithiasis, the patient will have right upper quadrant pain, usually pain after meals, especially fatty meals. No fever, no jaundice, and labs will be normal. The best test is a transabdominal ultrasound, gallstones in the gallbladder, and the treatment, if symptomatic, is to do a cholecystectomy. For cholecystitis, this is where the stones have impacted into the cystic duct, and you have an infection in the gallbladder. So the patient will present with right upper quadrant pain, fever, no jaundice, and for other, I want you to remember a Murphy sign, where the patient stops inhaling when you press in the right upper quadrant because of the pain. On labs, white blood cell count will be elevated, but alk phos and bili should be normal. The best test is an ultrasound, which will show gallstones and thickening of the gallbladder wall. Another good test is the HIDA scan, and the treatment is cholecystectomy and antibiotics. With cholangitis, the patient has right upper quadrant pain, fever, and jaundice. What's the name of that triad? Charcot's triad. And for other, remember that if we add altered mental status and hypotension to Charcot's triad, we get Reynolds pentad. The labs will be elevated white blood cell count, alk phos, and bilirubin. The best test is probably an ERCP because it's both diagnostic and therapeutic. So our treatment includes endoscopic biliary drainage, antibiotics for 7 to 10 days, and ultimately a cholecystectomy. And finally, with gallbladder cancer, the patient may be asymptomatic, but if there are symptoms, look for right upper quadrant pain and jaundice, but no fever. Alk phos and bili will be elevated, but the white blood cell count will be normal. The best test is an ultrasound, probably endoscopic ultrasound, which is abbreviated EUS. And the treatment is usually an extended cholecystectomy with lymph node dissection and partial hepatic resection, followed by chemo and radiation. Now I want you to pause the video and work through your end of session quiz. All right, first question. What are the potential complications of cholelithiasis? We mentioned acute pancreatitis, acute cholecystitis, acute cholangitis, and gallbladder cancer. What patients are at high risk for acalculous cholecystitis? Patients on TPN or critically ill patients. Next question. What are Charcot's triad and Reynolds pentad? These are both findings of acute cholangitis. Charcot's triad is fever, right upper quadrant pain, and jaundice. Reynolds pentad is fever, right upper quadrant pain, and jaundice, plus mental status changes and hypotension. Last question. A 43-year-old woman presents to the ER with a complaint of right upper quadrant pain and fevers. What ultrasound findings would support the diagnosis of acute cholecystitis? You'd expect to see gallstones in the gallbladder, you'd look for thickening of the gallbladder wall, and you may see a sonographic Murphy sign. That's it for this lecture, guys. We'll see you at the next one.
It's time for another 3-question warm-up. Let's get going. What is the most common cause of traveler's diarrhea, or Montezuma's revenge? So this is going to be E. coli, specifically the enterotoxigenic E. coli. Next, What is the medical treatment for ulcerative colitis? So this can vary some, but I want you to remember 5-aminosalicylic acid. So that 5-ASA by itself is mesalamine. But if you conjugate it to sulfapyridine, that's called sulfasalazine. And we said that to become active, sulfasalazine has to be broken down by bacteria in the terminal ileum and in the colon. So if you have a small bowel disease, you're just going to go with mesalamine. But if you have large bowel disease, then you can use sulfasalazine, so that 5-ASA makes it all the way to the colon before it gets activated. And then for acute exacerbations, you might have to still give steroids. Next question. Which bacterial gastrointestinal infection is most likely associated with diarrhea and pseudoappendicitis? So remember, that's going to be Yersinia enterocolitica. That can cause that bacterial gastroenteritis in patients, a lot of pain as well. Think about food. So pork can be a reservoir of this. Puppy feces are also a common source of this contamination. Now, the patient can have diarrhea, and as you would expect with gastroenteritis, but they also can have some very unique features not common to all GI bacterial infections, like pharyngitis even, and a pseudoappendicitis. So pseudoappendicitis is abdominal pain that kind of mimics that appendicitis in general. All right, guys, that brings us to the end of the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here, and in this video we're going to discuss the biliary diseases that are higher up the biliary tree, actually within the liver itself, starting with primary biliary cholangitis, or PBC. This used to go by the name primary biliary cirrhosis, but the newer preferred name is primary biliary cholangitis. But I suppose you might see either name or even both names on your exam. We talked about acute cholangitis in the video on gallbladder, because acute cholangitis was due to infection of the biliary tree behind some obstruction like a gallstone. But this is primary biliary cholangitis, so it isn't secondary to a stone or obstruction. This is an autoimmune disease that attacks the epithelium of the bile ductules within the liver parenchyma, leading to inflammation and destruction of the bile ductules, not infection. So this is only affecting intrahepatic bile ductules. The result is that you get cholestasis, where the bilirubin and bile acids accumulate in the liver, and eventually that can result in cirrhosis. We'll talk about the features of cirrhosis in another video, but for now, just know that cirrhosis is a late manifestation of PBC, which is a big reason that they changed the name, because you can have early stage primary biliary cholangitis without evidence of cirrhosis or fibrosis of liver tissue. PBC is much more common in women than in men. About 95% of PBC patients are women, usually women between the ages of 30 and 65. So middle-aged women, PBC is frequently associated with autoimmune diseases like Sjogren's syndrome, Crest syndrome, and with rheumatoid arthritis. PBC is often found incidentally because of abnormal labs, so a lot of these patients are asymptomatic. If they have symptoms, fatigue and pruritus, which are the most common symptoms, the pruritus can be really severe. One common presentation is a woman who starts having pruritus during pregnancy, but it doesn't go away during postpartum. They scratch themselves so much they get excoriations. Patients might initially be referred to a dermatologist because of the pruritus. With the pruritus, they can have skin changes such as hyperpigmentation due to melanin deposition, xerosis or dry skin, and they may have dermatographism, where they get a wheal when you just barely scratch the skin, even lightly. You may take your pen and retract the writing part and make some little lines on their skin, and then look again in a couple minutes and see there is a wheal and flare reaction where you wrote on them. That's dermatographism. They can have xanthomas, which are cholesterol-filled plaques in the skin, or xanthelasma, which is xanthomas in the eyelids, near the corners of the eye. Cholesterol isn't being excreted, so that's why they get these cholesterol deposits. They may have hepatomegaly and may have some splenomegaly. They can have malabsorption and steatorrhea because of the reduced bile acid secretion. Bile acids are important for being able to absorb fats. Without bile acids, the fat gets passed on through the GI tract, which causes fatty stools and steatorrhea. And again, in late-stage disease, they can develop cirrhosis, jaundice, ascites, edema, and portal hypertension. Labs will show elevated alk phos and eventually elevated bilirubin. That is a clue for biliary disease. If you see elevated AST and ALT, think about parenchymal liver disease. With biliary disease, we typically see elevated alk phos and bilirubin. They can also have elevated cholesterol. The next bullet is really important. Patients with PBC have anti-mitochondrial antibodies. This is your screening test. In the right patient, like a middle-aged woman with liver disease, and you're thinking maybe has primary biliary cholangitis, the next step is to check the anti-mitochondrial antibody. This is the hallmark finding for PBC. They can also have a positive ANA. Again, this is an autoimmune disorder, so about 70% of patients will have an elevated ANA, but ANA is very nonspecific. The main treatment you need to know is ursodeoxycholic acid. It's a naturally occurring bile acid that changes the composition of bile. It delays disease progression and enhances survival. It doesn't reverse damage that's already done, but it may slow further damage. It's the only approved therapy for primary biliary cholangitis. So if you don't know anything else to treat primary biliary cholangitis, remember ursodeoxycholic acid. And then the definitive treatment for PBC is a liver transplant. Next is primary sclerosing cholangitis, or PSC. This is somewhat similar to primary biliary cholangitis, but there are some very important differences that I want to highlight. The names are just similar enough to cause some confusion, even more similar than they used to be. First of all, PSC causes progressive inflammation, fibrosis, and sclerosis of the intrahepatic and extrahepatic bile ducts, and that can lead to fibrosis and cirrhosis. So it's not just intrahepatic ducts like we saw with PBC. With PSC, primary sclerosing cholangitis, you can get intrahepatic duct destruction and extrahepatic duct destruction. Another important distinguishing factor is that while PBC is more common in women and PSC is more common in men, with an average age of diagnosis around 40, and PSC is very strongly associated with ulcerative colitis. What kind of diseases was PBC associated with? Autoimmune diseases like Sjogren's syndrome or Crest syndrome. The presentation of PSC is similar to that of PBC. The patients may be asymptomatic, or they may have fatigue and pruritus, which can lead to scratching and excoriations. They may have some jaundice and hepatomegaly on exam. The basic labs are similar to PBC. Elevated alk phos, possibly elevated bilirubin, but ANA is negative, and instead of anti-mitochondrial antibodies, PSC patients often have P-ANCA positive. You need to know that. If you do an ERCP on one of these patients, instead of the biliary tree having a nice, smooth, regular lumen, you see irregular areas of stricturing and areas of dilation that look like beads. This is often described as beads on a string appearance. So when you see that, or you hear beads on a string, think about primary sclerosing cholangitis. The bad news is that ursodeoxycholic acid really isn't a very good treatment option for these patients. It's never been proven to alter the course of the disease or clinical outcomes. Really, transplant is about the best thing we have to offer. And you may want to know that PSC is associated with an increased risk of cholangiocarcinoma, which is cancer of the bile ducts, the carcinoma of the cholangios. Now, if there is primary sclerosing cholangitis, there must be some secondary cause of sclerosing cholangitis. So what are they? Look at the next question in the study guide. Secondary sclerosing cholangitises can be caused by intraductal biliary stones, surgical trauma or blunt abdominal trauma to the biliary tree, leading to sclerosis and therefore cholangitis. Chemotherapy drugs can sometimes cause this. Recurrent pancreatitis can cause this, and autoimmune pancreatitis can cause this. And there's something called AIDS cholangiopathy, which can lead to sclerosing cholangitis. These aren't terribly high yield, but you need to be aware of them. Make sure you can tell the difference between PBC and PSC. Let's go over it one more time in the whiteboard review. To help us keep all these features of the two diseases straight, we're going to move the features listed down the middle into one of the two columns. So which of these diseases is primarily seen in men? That's PSC. About 70% of PSC patients are men. and about 95% of PBC patients are women. Then, we've listed some different diseases that are associated with the two conditions. The primary one I want you to remember is Sjogren's syndrome as being associated with PBC. You can also see CREST syndrome and rheumatoid arthritis. And then ulcerative colitis is strongly associated with PSC. Now, which of these two diseases affects the intrahepatic bile ducts? That's PBC. And then PSC can affect both the intrahepatic and the extrahepatic ducts. We said that the autoantibodies associated with PBC include AMA, anti-mitochondrial antibodies. That's the main one. And also an ANA may be positive. And then a P-ANCA can be positive in patients with PSC. We said that PSC can increase your risk of cholangiocarcinoma, carcinoma of the bile ducts. Which of these two disorders was associated with beads on a string finding on an ERCP? That's PSC. That sclerosing cholangitis causes stricturing of the bile ducts. And which of these two disorders is treatable with ursodeoxycholic acid? That's PBC. Make sure you know all these high-yield features of these two diseases. Next, we're going to talk about some disorders of the hepatic bilirubin transport which lead to hyperbilirubinemia. But first, let's review normal bilirubin transport. When red cells get old, they undergo hemolysis. They lyse and they release all of their hemoglobin into the blood. And then the heme molecule gets split off from the hemoglobin and converted into bilirubin. So now we have unconjugated bilirubin circulating in the blood. That bilirubin is taken up by the liver and conjugated by an enzyme called UDP glucuronal transferase, or UDP-GT. It attaches or conjugates bilirubin to glucuronic acid so that the bilirubin can dissolve in the bile. So in the bile, you expect to see conjugated bilirubin. And on a lab report, you'll see direct bilirubin and indirect bilirubin. Which is which? Is indirect bilirubin conjugated or unconjugated? It's unconjugated. Look for similar prefixes. Indirect is the same as unconjugated. Direct bilirubin is the same as conjugated bilirubin. In your study guide, we have a chart breaking down lots of different causes of hyperbilirubinemia. Some that we'll discuss and some we won't, but this is a useful way to organize these diseases in your mind. Let's start with the diseases where you have high unconjugated bilirubin. There are three big categories: increased bilirubin production, impaired bilirubin uptake and storage, and decreased UDP-GT activity. So what could cause increased bilirubin production? The first one is hemolytic anemia. You're breaking down red blood cells, so you have more heme to process, and that yields more bilirubin. The second bullet is hematoma breakdown. After an internal hemorrhage, as the hematoma is broken down, that unconjugated bilirubin ends up in the blood. The next big group is impaired bilirubin uptake and storage because of hepatocyte injury. This could be things like viral hepatitis or drugs. Certain drugs, like rifampin, can impair the uptake and storage of bilirubin. Then, our last group of disorders are the decreased UDP-GT activity, which include neonatal physiologic jaundice, which occurs because neonates don't have their UDP-GT fully ramped up until they're about 2 weeks old. And then there are disorders like Gilbert syndrome and Crigler-Najjar syndrome, type 1 and 2. We're going to talk about those shortly. But first, what kind of things cause high levels of conjugated bilirubin? You can have impaired transport of bilirubin, where the hepatocytes can conjugate the bilirubin, but they can't excrete it. This occurs in Dubin-Johnson syndrome and also in Rotor syndrome. These are both benign conditions, and they don't normally cause very much jaundice, and they aren't really that dangerous. The next group of diseases that cause biliary epithelial damage, this can be seen with various types of hepatitis, cirrhosis, and liver failure. Intrahepatic biliary obstruction is where you have obstruction of the biliary ducts inside the liver itself, such as with primary biliary cholangitis or primary sclerosing cholangitis, and certain drugs such as chlorpromazine and arsenic, which can cause this too. You can also have extrahepatic biliary obstruction either from pancreatic neoplasms, pancreatitis, cholangiocarcinoma, which is cancer of the bile ducts, Cholelithiasis, which is a gallstone that impacted in the bile duct system, and finally, biliary strictures, which can obstruct the biliary tract, but basically anything that prevents bile from flowing from the liver into the GI tract will cause the bile to back up and you can get conjugated bilirubin in the blood. Let's go back and discuss these two diseases of UDP gluconeoryl transferase deficiency. The first one is Gilbert syndrome. This is usually an autosomal recessive disorder that causes a mild deficiency of UDP gluconeoryl transferase. So these patients will have mild jaundices following fasting or exercise stress. Sometimes it's just an incidental lab finding. You just see this consistently slightly elevated indirect bilirubin and wonder what's going on. Most likely it's Gilbert syndrome. Labs will show slightly elevated indirect bilirubin, less than 3 milligrams per deciliter. Maybe the indirect bilirubin is 1.5 or 2, just a little bit elevated. You don't need to treat this. It's a benign condition. You don't need to work it up. You don't need to treat it. You just assume that it's Gilbert syndrome and you ignore it. You just make note of it, that if there's there every time they get LFTs for some reason, you know what the indirect bilirubin is going to be mildly elevated. The next one is Crigler-Najjar syndrome, and there's actually two types, type 1 and type 2. Type 1 is associated with an autosomal recessive disease with severe deficiency of UDP gluconeoryl transferase. They don't make the enzyme at all. So clinically, these patients present with persistent jaundice in the first 1 to 2 days after birth, plus CNS syndromes due to kernicterus. Labs will show markedly elevated indirect bilirubin, greater than 5. When the bilirubin gets above 20 or so, you'll start seeing symptoms of kernicterus. So bilirubin of 5 is not that big of a deal. Bilirubin of 20 is certainly a big deal, and unfortunately, Crigler-Najjar type 1 is usually fatal if it isn't treated. The first-line treatment is phototherapy. Basically, light converts bilirubin into an isomer that you can be excreted in your urine. So you can't conjugate the bilirubin excreted in the stool the normal way, but with phototherapy, you convert it into a form that can be excreted in the urine. So phototherapy is one treatment. Plasmapheresis is another treatment, where you can take the patient's serum out of the body, filter out the bilirubin, and put the plasma back in. Liver transplant is the definitive therapy, and usually this is to be done around adolescence. Then Crigler-Najjar type 2 is a mild disease that looks a lot like Gilbert disease, just with a different genetic defect. There's mildly decreased UDP gluconeoryl transferase, and you have mild elevation of indirect bilirubin. You can treat it by giving phenobarbital. You may remember that barbiturates like phenobarbital will induce cytochrome P450, and they will also induce production of UDP-GT. So that's it for biliary diseases. So go ahead and do your anesthetician quiz, then restart the video, and let's go over the answers. First question. What distinguishes primary biliary cholangitis from primary sclerosing cholangitis? PBC is seen in women. It's positive for AMA, anti-mitochondrial antibodies, and also an ANA. It's associated with autoimmune diseases. Then for PSC, is more commonly seen in men. It's positive for a P-ANCA. It's associated with ulcerative colitis. And an ERCP shows alternating strictures and dilation called beads on a string. Next, what is the treatment for primary biliary cholangitis? Remember, ursodeoxycholic acid. They may ultimately need a liver transplant. And last question, what is the common presentation of Gilbert syndrome? Mildly elevated unconjugated bilirubin and episodes of mild jaundice, especially after exercise or physiologic stress such as fasting. All right, guys, that's it for biliary diseases. I'll see you at the next one.
Let's go over the answers to the warm-up. First question, which vasculitis is classically seen in young Asian women? That's Takayasu arteritis, which affects the arteries branching from the aortic arch and can cause diminished pulses in the upper extremities. Next, which form of inflammatory bowel disease is associated with a lead pipe appearance on barium enema? That's ulcerative colitis. There's a loss of the haustral markings of the colon, making it appear smooth, kind of like a lead pipe. And the last one, a patient suffers a hypotensive episode and develops ischemic colitis. What area of the colon is most likely to be affected? Well, it's the splenic flexure, which is a watershed area, an area supplied by the distal arterial branches, making it particularly vulnerable to ischemia from hypotension. Now let's move on to the lecture.
Hey guys, Dr. Carmichael here, and welcome to our Step 2 video on viral hepatitis. Let's just jump right in because we have a lot to cover. Hepatitis is an inflammatory disease of the liver and is commonly caused by viral infections, but it can also be a result of chronic alcohol use or other toxins. So the term hepatitis is not very specific, but the most high-yield stuff will relate to viral hepatitis. Now the pattern of transmission will vary from virus to virus, and we'll go over that here in a little bit. History and physical, often patients are asymptomatic, so patients can have the disease and actually transmit it without knowing it. That's one of the problems with hepatitis B. It's very pervasive, and in certain communities you can pass it through sexual contact without even knowing you have it in the first place. When you do have symptoms, you can have malaise, arthralgia, fatigue, nausea, and vomiting. You may have right upper quadrant pain, jaundice, scleroicterus, tenderness of the hepatomegaly or splenomegaly, and lymphadenopathy. The most common lab abnormality is probably an elevated aminotransferases, like the ALT and the AST. Where there's active infection and inflammation in the liver, hepatocytes are going to die and spill out their contents, which leads to those elevated LFTs. Now, there's a rough way to tell the difference between an alcohol-induced hepatitis versus a viral-induced hepatitis. AST is going to be higher in your alcohol-induced hepatitis. And I try to remember that with the mnemonic AST, a Scotch and tonic. ALT and AST will be elevated almost equally in viral hepatitis. Patients with hepatitis also have an increased serum bilirubin and increased alk phos and increased bilirubin in the urine. Okay, so that's the general characteristics of viral hepatitis. Now let's go through each type because they can be very different. Hepatitis A is a single-stranded RNA virus. The transmission is through fecal-oral route. The virus is more prevalent in areas of lower socioeconomic status and areas with inadequate sanitation. The biggest risk factor in the U.S. is international travel to Mexico or South America, and the incubation time is about 30 days. This isn't just food poisoning. You get exposed, and then a month later, you start having symptoms. And those symptoms can include typical fatigue, vomiting, fever, and right upper quadrant pain, but Hep A very rarely results in fulminant hepatic failure. So how do you make the diagnosis? Anti-hepatitis A IgM antibodies are present during the illness. Anti-hepatitis A IgG antibody is present after resolution. But you can also get this with a vaccine as well. So that IgG is a late occurring antibody and IgM is indicating an early infection. And again, if you're getting your vaccine for hepatitis A, you're going to develop the IgG antibodies. Treatment is supportive care because this is a self-limiting disease. There is a hepatitis A vaccine, and we give one dose between the ages of 12 months and 18 years, and then a booster at 6 to 12 months after the first injection. Next is hepatitis E. I know I'm not going in order, but I like covering E next because it's very similar to hepatitis A. It's also transmitted by the fecal-oral route. One way to remember is that A and E are at the end of our hepatitis alphabet, and they are transmitted by the top and the bottom end of our bodies, orally and fecally. Contaminated water supplies are a common source of hepatitis E. It will cause the same symptoms as the other viral hepatitis, but it is more likely to proceed to fulminant hepatic failure when compared to hepatitis A. Another issue is that hepatitis E is more likely to lead to fulminant hepatic failure in pregnant women, which can result in death. We're not really sure why that happens. The diagnosis is made by detection of the virus by PCR in the serum or stool by detecting Hep E IgM antibodies. Treatment for hepatitis E is supportive, just like hepatitis A. There is a hepatitis E vaccine that has been developed, but it hasn't been made commercially available. The next one is hepatitis D. It's also called the Delta virus. It's also a defective pathogen. So the D stands for Hep D, Delta virus, and defective. Hepatitis D can only infect individuals that are already infected with hepatitis B. There is no way to get hepatitis D by itself. Hep B is needed to help Hep D to be able to complete virion assembly and secretion. The transmission is usually through blood, though it can be transmitted sexually. The symptoms are again similar to those of other viruses. However, Hep D, when combined with Hep B, can result in a very severe and protracted hepatitis. In fact, hepatitis D has the highest mortality rate of any of the hepatitis infections at about 20%. The treatment is not standardized, but most are using pegylated interferon alpha for 1 year. For prevention, all you have to do is get hepatitis B vaccine, because if you don't get B, then you can't get D. Hepatitis C is next. The presentation can be similar to our other causes of hepatitis, but overall the symptoms are not very severe with Hep C. Patients are more often asymptomatic until they have cirrhosis. Hepatitis C is more likely to become chronic than any of our other hepatitis viruses. 50 to 85% of patients will remain chronically infected, and about 5 to 30% of patients will develop cirrhosis. Hepatitis C patients with cirrhosis are at a higher risk of hepatocellular carcinoma at a rate of 1 to 4% a year. These patients with cirrhosis should have an ultrasound performed every 6 months. Patients can also get extrahepatic manifestations, including membranoproliferative glomerulonephritis, essential mixed cryoglobulinemia, lymphoma, thyroiditis, porphyria cutanea tarda, lichen planus, and diabetes mellitus. Transmission is through blood, but it can be rarely passed through sexual contact. You can test for hepatitis C antibodies, and if that's positive, then you can confirm the diagnosis by testing for the presence of hepatitis C RNA. Treatment can get complex. There are different regimens for different genotypes of hepatitis C. I believe memorizing all of that is beyond the scope for your test. The old standards were peg interferon and ribavirin, but now we are using antivirals in combination more and more often. Now, hepatitis B, here's the tough one, the one that we're going to have to spend a little extra time on. The symptoms are similar to hepatitis C. Many patients are asymptomatic, but others can have jaundice, fatigue, right upper quadrant pain, and very rarely fulminant hepatic failure. Hepatitis B can be transmitted perinatally, through sexual contact, most common in the United States, and through blood. Patients can have just the acute form, but chronic hepatitis B occurs in less than 5% of patients who acquire the virus as an adult. But it progresses to chronic hepatitis in 90% of patients who get the virus perinatally. So there's a huge difference there. You do not want to get hepatitis perinatally. Hepatitis B can have extrahepatic manifestations like hepatitis C. This is thought to be due to circulating immunocomplexes. This includes polyarteritis nodosa, membranous nephropathy, and aplastic anemia. Hepatitis B can also increase the risk of hepatocellular carcinoma, even more so than hepatitis C. Like hepatitis C, you need to check ultrasounds every 6 months. Some will order alpha-fetoprotein, and though the alpha-fetoprotein increases detection, it also increases cost and false positives. The most complicated part of this whole lecture is figuring out what all of these serologies mean and how to determine the stages of the disease. Pay special attention because this can get tricky. So we'll go through each serology, then do some examples. The first one is hepatitis B surface antigen. So surface antigen, when that's positive, indicates active disease. Surface antigen means active disease. Next is hepatitis B surface antibody. A positive surface antibody will mean one of two things: recovery from an active hepatitis B infection, or it can mean immunization. So you've been immunized with the Hep B vaccine. So antigen always means active disease. Antibody to surface antigen means either you've recovered from the disease or you've been immunized. Next we have the hepatitis B core antibody. We cannot test for the antigen in the blood, just the antibody. The hepatitis B core antibody indicates a history of active disease. It will not be positive after immunization. So it's not going to be positive if you've just been immunized. You had to have actually had the disease for the hepatitis core antibody to be positive. Now, to throw another wrinkle into this, there are two types of core antibodies. There's an IgM and an IgG. Now the IgM will rise early in the disease. It's similar to hepatitis A. Early on you produce the IgM. Late in the infection you're going to produce IgG. I remember the IgG by thinking this infection is going, gone, or chronic. So hepatitis B core antibody, IgM early, IgG late. And then the next one is hepatitis B envelope antigen. We call this the E antigen. This will indicate active viral replication and high transmissibility. So if the E antigen is positive, you have high transmissibility. You are more infectious. There's also a Hep B E antibody, which will indicate low transmissibility. So it's just the opposite of the antigen. One more lab to add here is the Hep B DNA. Generally, we do this by PCR. Hep B DNA tends to be high during times of high infectivity and then tends to disappear after recovery. Why do we care about the Hep B DNA? The major clinical role of Hep B DNA is to determine when to treat the patient for their hepatitis B. The indications to treat are based on active liver disease, like elevated LFTs or high Hep B DNA levels. I separate this one because I can vary either up or down in each of the stages of hepatitis B. But all I really want you to remember is that when you have Hep B DNA high, there are signs of active liver disease, like elevated LFTs, that's generally when you're going to treat. So let's go over some scenarios that you could see on your test. The first one we have is an acute infection. The surface antigen is positive because the surface antigen means active disease. The surface antibody is going to be negative. When the surface antibody is negative, that means you have not yet recovered from this infection. Next is the hepatitis B core antibody. So remember, core antibody is going to be positive with any disease, whether new or old. But what type is it? It's going to be IgM. And it's because IgM is always there early in the course of the disease. So you have an infectious process and it's still early on, think IgM. The E antigen is going to be positive. And what does the E antigen mean? That means you are infectious. The E antibody is going to be negative, and the Hep B DNA is usually high. Now let's move on to the next one, an acute infection window period. So this can be tricky. It can really fool you because you're looking at all your tests and you notice almost everything comes back negative. Both the surface antigen and the surface antibody are negative. So how is this an acute infection? Shouldn't one of those be positive? Well, if you imagine that at a certain point during the infectious process, the surface antigen, HBsAg, is decreasing, and the surface antibody, HBsAb, is starting to increase. And then the number of surface antigens is equal to the number of surface antibodies, so they're going to cancel each other out. So we call this the window period. This patient is likely on his or her way to recovery. So the test will show a negative surface antigen and antibody, but the one thing that will come up positive is the core antibody. And since it's still relatively early in the course, you're going to have IgM predominance. The Hep B DNA can be high or low, it can vary, and the E antigen and antibody can vary a bit as well. Next, you have a past infection recovered. So you had the disease, but your body's cleared it. The surface antibodies have won the battle. So the surface antigen is negative, it lost, and the surface antibody is positive. The core antibody is going to be positive because you had the disease, but you're going to have a positive IgG, which is the chronic form of these antibodies. Your E antigen is going to be negative because you can't pass the virus on, you no longer have. And the E antibody might still be positive. The Hep B DNA should be 0. Next, we have vaccination. Now, vaccination is a little bit different. You've never had the disease, so you've only been vaccinated. The surface antigen is going to be negative because you have never had the active disease. The surface antibody is going to be positive. So the purpose of the vaccine is to build up immunity, so we can't get hepatitis B now because we all have those surface antibodies floating around protecting us. The core antibody is finally going to be negative here. It was positive in everything else, but because the patient has never actually had the infection, the core antibody will be negative. The E antigen is going to be negative, and the Hep B DNA is also negative. Next, chronic infection. Chronic Hep B can be a little more complicated because there are 3 phases to a typical chronic Hep B infection. First, even though this is a chronic Hep B, it still counts as active disease. So your hepatitis B surface antigen is positive and the surface antibody is negative. And the core antibody is positive. But now, finally enough time has gone by that this is considered a chronic infection. So we'll have IgG predominance. So IgG instead of IgM, which was early on. So that's the easy part. Next, we need to cover the 3 phases of chronic Hep B. So, how often does Hep B progress to chronic state? Only about 5% of those who get it as an adult, but 90% of those who get it as a newborn. When the patients get Hep B perinatally, initially there's a high level of Hep B virus replication, and the Hep B E antigen is positive, and the Hep B surface antigen is positive, and there are high levels of Hep B DNA. But even though there's a very high viral activity, there is no evidence of active liver disease. The patient is not jaundiced, the liver function tests are normal, or just not very elevated. This phase is called the immunotolerance phase. For some reason, the body is not really reacting to the virus, and very little damage is being done. The immunotolerance phase can last 10 to 30 years. The next phase is called immunoclearance. For some reason, the immune system has woken up and is responding to the hepatitis B virus. The E antigen is positive initially. The surface antigen is still positive. There is still active viral replication, so the Hep B DNA is generally high. And with the immune system active, there is now liver damage taking place. There is immune-mediated liver cell death. The liver function tests are rising. So I like to think about a battle taking place in this phase. The immune system versus the virus. And there is collateral damage taking place. The upside to this phase is that the immune system can win, and patients are more likely to clear out the Hep B E antigen. So the infectivity goes down and viral replication decreases. Patients this phase are more likely to respond to treatment. So if you get a question about the best time to treat chronic Hep B, then the answer is often in the immune declearance phase. The final phase of chronic hepatitis B is the inactive carrier phase. Here the patient has a normal LFT. The Hep B surface antigen is still positive. The Hep B E antigen is negative. This is still considered chronic Hep B. This is not true recovery from the disease because 20 to 30% of these patients can reactivate where there is viral replication and elevation in the LFTs. So, those are the 3 phases of Hep B. Immunotolerance, when you have a lot of virus but little damage. Immunoclearance, when your immune system wakes up but there's a lot more damage and the body has a better chance of clearing the E antigen. And the inactive carrier phase, where the E antigen is negative along with normal LFTs, but the surface antigen is still positive. So what about treatment? What are we going to be using? Like hepatitis C, Hep B treatment can get complex depending on the resistances to drugs and stage of the disease. In the past, we were using a lot of interferon. Now, we're using more antivirals. Tenofovir is one of the most commonly used drugs, but others include entecavir, telbivudine, lamivudine, and adefovir. The other topic that tends to get a lot of questions is what do I do with pregnant women who test positive for hepatitis B surface antigen? So, they have active disease. If the Hep B DNA is very elevated and there's active liver involvement, then sometimes the mother will be started on antivirals like lamivudine. But you can also dramatically decrease the transmission to the baby by giving the baby Hep B vaccine and Hep B immunoglobulin within 12 hours of birth. So you'll decrease transmission to the baby dramatically. All right, that's the end of this lecture. Let's move on to the end of session quiz. You guys know the drill. First question. Which hepatitis virus confers a high risk of chronic hepatitis? The high-risk one is hepatitis C. About 80% of Hep C patients will become chronic. Only about 5% of adults with Hep B become chronic, though rates are much higher in those with perinatal transmission. And then Hep A and Hep E don't cause chronic hepatitis. Next, which hepatitis virus confers the highest risk of hepatocellular carcinoma? Hep B virus. Hep C also increases the risk, but not as much as Hep B. Last question, what type of current or past hepatitis B exposure is present in the following scenarios? The first one, where the only positive is the core IgM antibody. That's an acute infection in the window period. The next one, a positive surface antigen and a positive IgG core antibody. That's a chronic infection. Then the next one, where there's only positive is your surface antibody. That's a patient who has been immunized by vaccine. And the last one is a patient who has recovered from an acute Hep B infection without becoming chronic. The positive core IgG antibody tells you the patient has had an infection, not just the vaccine, and a positive surface antibody tells you the patient has recovered from the infection. That's it for this lecture, guys. We'll see you at the next one.
It's time for another warm-up. Let's get going. Asthma is the predominant feature of which vasculitis? So this is eosinophilic granulomatosis with polyangiitis, also known as Churg-Strauss syndrome. So if you have a young patient with asthma and vasculitis, think of the Churg-Strauss syndrome. Next, what two side effects of ACE inhibitors are thought to be due to elevated levels of bradykinin? Well, the two side effects that you especially know are going to be known for ACE inhibitors. That's going to be that dry cough, so dry, kind of nagging, tickly cough in the back of your throat. And then the other one is going to be angioedema. And these are thought to be due to that elevated level of bradykinin. Next, what antibiotic combinations are used in the outpatient treatment of diverticulitis? Well, the organism you worry about here are the gram-negative rods and the anaerobes. So you can use a fluoroquinolone. We often use something like ciprofloxacin plus metronidazole. Now, you might do an alternative like trimethoprim sulfamethoxazole plus metronidazole, or you can use amoxicillin clavulanate by itself. All right, that's it for the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here. In this video, we're going to be talking about the effects of alcohol on the liver, from alcoholic fatty liver disease all the way to cirrhosis and portal hypertension. Long-term alcohol abuse can cause gradual progressive damage to our livers. The first thing you see is hepatic steatosis, which is fatty deposits in the liver. Here's a liver biopsy showing hepatic steatosis. These wide areas are big fat droplets within the hepatocytes. These aren't adipocytes. This is just lipid that accumulates within the liver cells themselves. This is hepatic steatosis, and early on, it's still reversible. So drinkers start getting steatosis and fatty liver, but if they stop drinking, the liver can begin to heal itself. With continued alcohol abuse, the steatosis turns in steatohepatitis, which means that there is fat and inflammation of the liver. You start to see some of the hepatocyte swelling and necrosis occur, and at some point this liver damage becomes irreversible, and the inflammation leads to fibrosis and scarring of the liver, which is called cirrhosis. This is a liver biopsy that shows cirrhosis. You've lost a lot of the normal liver architecture, and these lighter pink areas are more or less normal hepatocytes. But the darker areas are inflammation and fibrosis. All those purple cells are lymphocytes and inflammatory cells. This is a trichrome stain, where the collagen stains blue. So again, the pink areas are the residual nodules of hepatocytes, but a lot of the hepatocytes have undergone necrosis, and they've been replaced by collagen and fibrosis and scarring. There's also a disorder called non-alcoholic fatty liver disease, or NAFLD. This is liver disease that looks exactly like that early on reversible steatosis we see in drinkers, but it's in patients who do not have a significant alcohol history. Instead, NAFLD is associated with obesity and the metabolic syndrome. But just like alcoholic liver disease, NAFLD can potentially progress to steatohepatitis, which we call non-alcoholic steatohepatitis, or NASH. Then, possibly to cirrhosis and liver failure. So in some ways, obesity can be just as bad for the liver as alcohol abuse. NASH is associated with obesity, diabetes, hyperlipidemia, and insulin resistance. And that insulin resistance leads to accumulation of fat and lipids in the liver. One clue to the presence of NASH would be chronically elevated LFTs, AST, ALT, and ALK-Phos. So if they give you on the test an overweight patient with chronically elevated LFTs who isn't on a statin or some drug that could cause that, and who swears they don't drink, think about NASH. And what would be the next step in the handling of this patient? How would you make the diagnosis? You might image the liver, probably with an ultrasound. You can identify fatty changes on ultrasound, CT, or MRI, although you can't really identify inflammation and fibrosis with scans. The gold standard is a liver biopsy, although we don't often do the biopsies on these patients. The treatment for NASH is, first of all, avoid alcohol. Even though it wasn't alcohol that caused this, alcohol can certainly exacerbate it. Anybody who has evidence of liver disease should probably get off alcohol altogether. You want to counsel the patient to lose weight. You need to control their diabetes if they have it, and interestingly, TZDs like pioglitazone have been shown to improve LFTs and reduce some of the fatty change and inflammation. This is an off-label use, but how do TZDs work? By improving insulin resistance. So if you have a patient with diabetes plus NASH, TZDs might be a good choice. Now let's get back to alcoholic liver disease. Patients may be asymptomatic for years and years. It's not uncommon for patients with symptomatic alcoholic hepatitis to have a history of heavy drinking for 20 years or more. And once they start having symptoms, the liver is usually pretty far gone. But eventually, they'll start to develop jaundice, anorexia, nausea, vomiting. They might have right upper quadrant pain, abdominal distension due to the ascites. They can have hepatosplenomegaly and liver tenderness. They may have muscle wasting, and some have hepatic encephalopathy. We see lots of those signs and symptoms associated with cirrhosis as well. Lab work may show elevated LFTs early on, but when you become so cirrhotic that most of your hepatocytes are damaged, those labs could become normal or even low, because when you don't have many hepatocytes left, there's no more AST or ALT to spill out into the blood. Now in viral hepatitis, AST and ALT are usually equally high, but in alcoholic-related liver disease, AST is higher than ALT by at least a 2-to-1 ratio. You may think of AST as standing for a Scotch and tonic. So in alcoholic liver disease, the AST is more elevated than the ALT, usually at least twice as high as ALT. That's a pretty good clue clinically. Most other forms of liver injury will be elevated equally in AST and ALT, but with alcohol, the AST is at least twice as high as the ALT. If you have a patient with ALT of 200 and the AST is only 300, that's not likely to be due to alcohol. But if the ALT is 200 and the AST is 500, alcohol is one of the few things that will do that. Besides AST and ALT, these patients can have elevated ALK-Phos and bilirubin, and then also, when the liver is sick, it loses synthetic functioning. So these patients may have low albumin, and they may not be making their clotting factors, so you'll become hypocoagulable, and you'll see a prolonged PT and PTT. You could also see leukocytosis with a neutrophil predominance, and alcoholics are often malnourished, so they may have macrocytosis and large red cells due to the B12 or folate deficiency. And alcohol is toxic to bone marrow, so they may have thrombocytopenia. Those aren't due to liver disease necessarily, but they are frequently seen with these patients. So how do we treat alcoholic liver disease? First and foremost, the patient needs to stop using alcohol. You have to modify their diet, put in thiamine and folate supplements, plus a high-calorie diet, mainly to deal with the effects of the alcohol abuse, not so much for the liver itself. Liver transplant is a consideration in patients who are able to stay off of alcohol. But how long does that person need to be off of alcohol before they're eligible for a liver transplant? At least 6 months. Next, let's talk specifically about cirrhosis. Lots of things can cause cirrhosis. In the United States, the most common causes are viral hepatitis, especially hepatitis C, but also hepatitis B, alcoholic liver disease, and non-alcoholic fatty liver disease. Those 3 diseases make up about 80% of cirrhosis cases in the United States. Beyond those 3, you get into the rare causes, like autoimmune hepatitis, Wilson's disease, alpha-1 antitrypsin deficiency, primary biliary cholangitis, and primary sclerosing cholangitis. So lots of different things can cause cirrhosis, but the three biggest causes in the United States are hepatitis C, alcoholism, and non-alcoholic fatty liver disease. I like to divide the signs and symptoms of the liver disease in cirrhosis into manifestations that come about because of liver failure or hepatocyte failure, because the hepatocytes are diseased or dead, and manifestations that come out because of portal hypertension. Most patients with cirrhosis will have symptoms of both liver failure and portal hypertension. So let's kind of separate these out. We'll start with liver failure for now, and we'll come back to portal hypertension a little later. I like to think about liver failure in terms of the three main things that hepatocytes do. Hepatocytes conjugate bilirubin from the blood and excrete that into the bile. They synthesize proteins and they metabolize toxins. So, if the hepatocytes stop conjugating bilirubin and putting it into the bile, then bilirubin will build up in the skin, the eyes, and you'll see jaundice. If the hepatocytes aren't synthesizing proteins, you can have a lot of problems. If they don't synthesize coagulation factors, you get a coagulopathy and prolonged PT and PTT. So you might see bleeding and bruising. If they don't synthesize albumin, you'll have decreased ability to carry hormones and drugs that are normally bound to albumin. And you'll also have decreased osmotic pressure keeping the fluid in the vasculature. So that fluid will then weep out and you get peripheral edema. And this low albumin can also contribute to ascites or fluid building up in the peritoneal cavity, although a lot of ascites is thought to be due to portal hypertension. And if the hepatocytes can't metabolize toxins like ammonia, you get something called hepatic encephalopathy, which is confusion and delirium and hypersomnia, and even coma or death. This can cause something called asterixis or liver flap, where the patients extend their arms and extend their wrists and the hands will kind of flap because they can't maintain the wrist extension. Liver failure also alters sex hormone metabolism and can cause increased conversion of estrogen to estradiol. So with high estrogen, you may see testicular atrophy and gynecomastia in men. Or you can see spider telangiectasias, which are little telangiectasias, usually in the chest, with a little red spot in the center and tiny vessels radiating out from the center, which look like the legs on a spider. Those are called spider telangiectasias or spider angiomas. High estrogen causes that. High estrogen also causes palmar erythema, so these patients can have redness of the palms of their hands. Labs in cirrhosis may show an elevated ALT or AST, or these labs could be normal or even decreased as the cirrhosis progresses and becomes more severe. Alk Phos and bilirubin are often elevated. We mentioned low albumin and a prolonged PT and PTT. These patients frequently have some anemia and thrombocytopenia as well. We usually start imaging with an ultrasound, which will show a small nodular liver. This obviously isn't an ultrasound, but the gross image of a cirrhotic liver from an autopsy. You can see the liver is shrunken because all that collagen, all that scarring have kind of contracted down. And you can see that the surface of the liver is very nodular. It doesn't have that smooth, shiny, healthy appearance. So a cirrhotic liver is relatively small and nodular. Treatment of cirrhosis can be challenging. It's generally irreversible, but one of the key interventions is to slow or stop the progression of the cirrhosis and to prevent further damage to the liver by treating the underlying condition that has caused it. These patients should be immunized against hepatitis A and B if they haven't been already. They need to stop all alcohol, even with cirrhosis from something else like hepatitis C or Wilson's disease or whatever. You still want to counsel these patients to avoid alcohol. You want to avoid any other potential hepatotoxins like acetaminophen. We give lactulose to treat hepatic encephalopathy. What does lactulose do? Lactulose is a sugar that you can't absorb, and it lowers the pH of the colon so that the ammonia gets trapped in the gut and it can't be reabsorbed. So the lactulose allows you to excrete the ammonia in the stool rather than reabsorbing it. And because we can't absorb lactulose, it also causes osmotic diarrhea. This is actually how you know you're getting enough. You sort of titrate the dose until the patient's having 3 soft stools a day. We also sometimes give an antibiotic called rifaximin to treat the encephalopathy. Why do we give that? Ammonia can be generated by enteric bacteria. So by killing off some of the gut bacteria, you can reduce the ammonia levels and treat the hepatic encephalopathy. But lactulose is used more than rifaximin. And patients with severe cirrhosis may end up needing a liver transplant. You just need to make sure that they aren't still drinking so they don't end up damaging the new liver. We covered the problems that cirrhosis causes due to liver failure, and we're going to discuss the problems caused by the portal hypertension in another video. But before we wrap it up, there are a few other signs and symptoms that either don't fit neatly into either liver failure or portal hypertension. They're sort of non-specific. Patients with cirrhosis will often have a generalized weakness. They may have weight loss. You may find digital clubbing of the fingers, which we would usually think about in hypoxemia and lung disease, but cirrhosis can cause it too. You can also see Dupuytren's contractures, which are contractures of the flexor tendons in the palm of the hand. About a third of these patients with alcoholic cirrhosis will have these. They aren't always due to cirrhosis, but anytime you see Dupuytren's contractures, you may need to do some imaging in labs to look for evidence of cirrhosis. Now it's time for the end of session quiz. First question, what is the treatment for hepatic encephalopathy, lactulose, and possibly rifaximin? What vaccine should be given to patients with cirrhosis? The two main ones to remember are hepatitis A and hepatitis B vaccines, but these patients also need their pneumococcal vaccine regardless of age because chronic liver disease is an indication for a pneumococcal vaccine. And of course they need their standard immunizations like an annual flu vaccine and regular tetanus boosters and so on. Last question, what physical exam findings may be seen in the hands of a patient with cirrhosis? Remember we talked about palmar erythema is one of the classics, but also mentioned the Dupuytren's contractures, digital clubbing, and the asterixis, which is flapping tremor of the hands when the wrists are extended. It's also be seen in patients with hepatic encephalopathy and other types of metabolic encephalopathy such as renal failure. Now that's for this one, guys. We'll see you at the next one.
It's time for another 3-question warm-up. Let's get going. What are the most common causes of acute pancreatitis? So by far, the two most common causes are going to be gallstones and alcohol. After those, you have elevated triglycerides, hypercalcemia, trauma, and then drugs. Next question, which medications are used in the treatment of an ileus? So you can use something like erythromycin, you can use neostigmine, and you can maybe possibly use metoclopramide. Next question, which class of antihypertensives should be avoided in patients with gout? Well, you need to try to avoid the diuretics, especially thiazide and loop diuretics, because they'll raise the uric acid level and that can actually trigger a gout attack. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here. When we discussed cirrhosis, I mentioned that some of the signs and symptoms and complications of cirrhosis come about because of hepatocyte failure. And some come because of portal hypertension. So let's talk about portal hypertension, what that is, and the problems that it can cause. Portal hypertension means high blood pressure in the portal vein. Imagine the liver is a screen door, and that blood is flowing through the liver from the portal vein. As long as that liver is healthy, that blood can flow through that screen door without any problems. But if there's cirrhosis and scarring of the liver, it's like somebody threw a big handful of mud against that screen door and all the little holes are plugged up so the blood can't flow through anymore. So the blood coming from the portal vein gets backed up and the portal pressure will rise. Cirrhosis is the most common cause of portal hypertension, but it's not the only cause. We can divide the causes of portal hypertension into prehepatic, intrahepatic, and posthepatic causes of portal hypertension. Prehepatic causes would include portal vein thrombosis and a big clot in the portal vein. An intrahepatic cause of portal hypertension would include cirrhosis, parenchymal disease of the liver like alcoholic fatty liver disease, primary biliary cholangitis or primary sclerosing cholangitis, or amyloidosis, and also granulomatous diseases like sarcoid. And outside of the US, schistosomiasis is an important cause of portal hypertension. And then posthepatic causes would be right-sided heart failure with blood backing up into the liver, thrombosis of the hepatic vein, and also Budd-Chiari syndrome. Let's look at the next question. Let's talk about Budd-Chiari syndrome just for a second. Now don't get that confused with Guy Ferrari syndrome, which is where you get bleached hair and a bad taste in clothing. Budd-Chiari syndrome is thrombosis and occlusion of either the hepatic vein or the intrahepatic portion of the inferior vena cava, and it presents with the following signs and symptoms. The most common finding is ascites. Hepatomegaly is also common, and these patients have jaundice. So if they give you a patient that has a triad of ascites, hepatomegaly, and jaundice, think about Budd-Chiari syndrome. The acute presentation can include right upper quadrant pain and hepatomegaly with rapid development of jaundice and ascites, or the patient may have a more common subacute or chronic presentation with a gradual development of ascites, lower extremity edema, cirrhosis, and portal hypertension over a few months. And eventually, these patients would develop liver failure and hepatic encephalopathy. The best initial test for Budd-Chiari syndrome is ultrasound, which allows you to see the thrombus. The gold standard is to do a hepatic venography, which is the most sensitive and specific test we have. And for treatment, you treat with thrombolytics to dissolve the clot or treat with diuretics and anticoagulation. Sometimes we do angioplasty to open up the thrombosed vein, or we do shunting to allow blood to bypass the thrombosis. Again, Budd-Chiari syndrome is one potential cause of portal hypertension, but overall the most common cause is due to cirrhosis. Now, why is portal hypertension such a big problem? Well, for one thing, as the portal vein builds up pressure, the liver becomes somewhat engorged with blood, so these patients may have hepatomegaly. And if the blood backs up into the spleen, they can also get splenomegaly. And the serum can weep off that surface of the liver and accumulate in the peritoneal cavity, and we call that ascites. So very often these patients with cirrhosis and portal hypertension will have a great big swollen abdomen. And then, when the pressure is high in the portal venous system, the blood looks for alternative routes to get back to the heart. And the most convenient routes are areas where the portal venules anastomose with the systemic venules. These are called portosystemic anastomoses or portochival anastomosis. In patients with portal hypertension, these portosystemic anastomoses allow blood to bypass the liver and find its way back into the systemic circulation, which would be fine, except those anastomoses are normally very small. But now you have suddenly had dramatic increase in the pressure and flow through these anastomoses, and the anastomoses dilate. What do we call abnormally dilated veins? Varices. So patients with portal hypertension get varices. They get esophageal varices, they get anorectal varices, which aren't exactly hemorrhoids, but are extremely similar to hemorrhoids, and they get varices of the superficial epigastric vein near the umbilicus, right under the surface of the skin, which is visible in something called a caput medusa, because somebody thought it looked like the head of a mythological creature called Medusa who had a hair made of snakes. They can also get renal varices and paravertebral varices, but the ones you really need to remember are the gut and the butt and the caput. Esophageal varices, because these frequently lead to life-threatening GI bleeding, anorectal varices, which look like hemorrhoids, and caput medusa, because it's something you can easily pick up on physical exam, and it's really testable. I mentioned ascites, and when you see a patient with ascites, cirrhosis is often high on the differential, but a lot of things can cause ascites, and to evaluate ascites, you perform a paracentesis and calculate the serum ascites albumin gradient, which we call the SAAG. Take a look at your study guide. You've measured the serum albumin level as part of your standard liver panel, and you do a paracentesis and you measure the albumin of the ascites. And then the serum ascites albumin gradient is just the serum albumin minus the ascites albumin. It's not a ratio, so you're not dividing. It's a gradient, so you just subtract them. And if you have trouble remembering which ones to subtract from which, remember it's the SAAG, serum ascites albumin gradient. So serum albumin comes first. Then you subtract the ascites albumin. So serum albumin minus ascites albumin. If the SAAG is greater than 1.1, that indicates portal hypertension from various causes like cirrhosis, alcoholic hepatitis, heart failure, constrictive pericarditis, massive hepatic metastasis, Budd-Chiari syndrome. But in all of these, the albumin in the ascites is relatively low. If the SAAG is less than 1.1, that means the ascites is not due to portal hypertension. Either you have high albumin in the ascites from peritoneal carcinomatosis, for instance, ovarian cancer often causes ascites, or from TB or pancreatitis, or you have low serum albumin from something like nephrotic syndrome. And if the ascites has high albumin plus high LDH, that suggests cancer as a cause of your ascites. It's worth knowing that as well. And what's your next step in the situation? You need to do a workup for that cancer. Think about a colonoscopy, that if it's overdue, or a pap smear, or even a CT scan of the chest, abdomen, and pelvis, just looking for that cancer that has metastasized to the peritoneum and is causing that ascites. One of the most serious complications of ascites particularly ascites due to cirrhosis and portal hypertension, is called SBP, or spontaneous bacterial peritonitis. Ascites fluid is a great culture medium, and if the bacteria get into the peritoneum and that fluid, they'll likely grow like crazy and cause a lot of problems. Spontaneous bacterial peritonitis arises spontaneously. It is not SBP if there's specific intra-abdominal source of infection, like bowel perforation or an abscess. Something you can get in there and operate on. And it's an important distinction to make because patients with SBP have a very high mortality if you do an exploratory laparotomy on them. And patients with a secondary bacterial peritonitis have a very high mortality if you don't get in there and operate on them. But the good news is that I don't think you'll be asked to make that distinction in step 2. So clinically, SBP presents with fever, possibly some abdominal pain and tenderness. Very often they can have an altered mental status and possibly diarrhea from overgrowth of enteric bacteria like E. coli. And then, with your paracentesis, you'll want to calculate the SAAG, which will be greater than 1.1 because SBP is associated with portal hypertension, not other causes of ascites. You'll need to send the fluid for gram stain and culture, and you need to order a white blood cell count on the ascites fluid, looking mainly for neutrophils. If the ascites neutrophil count is greater than 250 cells per cubic millimeter, that suggests a diagnosis of SBP. Those are really the big 3 as far as labs, but glucose is often low because the neutrophils consume it, and LDH is often high because lysis of neutrophil releases LDH into the ascites. So, if a patient comes in with cirrhosis and ascites plus a fever or ascites plus altered mental status, you need to rule out spontaneous bacterial peritonitis. Once you've made the diagnosis, how do we treat SBP? Well, the first blank here is cefotaxime. You can give cefotaxime or ceftriaxone or another third-generation cephalosporin for at least 5 days to cover the enteric bacteria, staph, and strep. The next bullet is albumin. IV albumin will help maintain the plasma volume and preserve renal function and reduce renal impairment and mortality. Up to 40% of patients with SBP develop renal failure, and giving albumin can prevent that. Now, what can we do to treat portal hypertension in general? Not just SBP, but portal hypertension in general. If there is ascites, we give a single daily morning dose of the diuretic spironolactone and furosemide to help prevent fluid retention. If there are esophageal varices, we treat with non-selective beta blockers like propanolol or nadolol to reduce the likelihood of hemorrhage. If the varices are bleeding, we can give octreotide, which will reduce the splenic blood flow and help stop the bleeding, or you can go endoscopically and put a rubber band on the varix and stop the bleeding, or perform sclerotherapy, which is where you inject a solution that scars down the vessel, or interventional radiology can do coiling to clot off those varices. And then the last resort, you can reduce the portal pressure by hepatic shunting via a laparotomy or a TIPS procedure, which is a transjugular intrahepatic portosystemic shunt. It's a short-term solution for severe disease. This shunts the blood from the portal system into the systemic system by creating a channel through the liver. That will relieve the varices basically by allowing blood to bypass the liver. And when you do that, you're decreasing the blood flow into the liver. So whatever filtering capacity that liver had is going to be decreased as well. So the plus side of hepatic shunting is that you relieve the varices, but the downside of hepatic shunting is you're going to worsen the risk of hepatic encephalopathy because you're decreasing the liver's ability to filter blood. All that ammonia and all those toxins are just going to get dumped directly into the systemic circulation and go straight to the brain. Now it's time for the end of session quiz. First question. What antibiotics can be used to treat spontaneous bacterial peritonitis? Cefotaxime or other third-generation cephalosporins? Next question. What 2 diuretics are used in conjunction for the treatment of ascites and portal hypertension? Furosemide and spironolactone. Last question. What are the clinical findings in Budd-Chiari syndrome? Ascites, jaundice, hepatomegaly, and possibly right upper quadrant pain. But that's it for this one, guys. We'll see you at the next one.
It's time for another warm-up. Let's get going. First question here, which valvular heart disease is associated with a wide pulse pressure? The answer is aortic regurgitation. Next, in a patient with valvular aortic stenosis, development of what symptoms is an indication for valve replacement? So if you have angina or chest pain, if you have dyspnea that's potentially associated with CHF, or syncope. Next, what prophylactic antibiotics should be given to a patient with mitral valve prolapse prior to dental cleaning? Trick question. Prophylactic antibiotics are not recommended for these patients anymore unless the patient has a prosthetic valve or a history of infective endocarditis. And in that case, the antibiotic would be a single 2-gram dose of amoxicillin given about 30 to 60 minutes prior to the procedure. All right, that's it for the warm-up. Let's get to that lecture now.
Hey guys, Dr. Carmichael here, and we're going to wrap up the liver with a handful of hepatic parenchymal diseases, starting with hereditary hemochromatosis. Hereditary hemochromatosis is an autosomal recessive disease that causes excess iron absorption, and then all that iron gets deposited in tissues like the liver and the pancreas. We'll see how those manifest themselves clinically in a moment. Rarely, patients can get iron overload and hemochromatosis from too many blood transfusions or from chronic alcoholism. But for the most part, we're talking about hereditary hemochromatosis. Iron deposition in the liver can lead to hepatomegaly and abdominal pain, and eventually hepatic fibrosis and cirrhosis. Iron deposition in the pancreas affects insulin production and results in diabetes. Late in the disease, they can have skin hyperpigmentation from both iron deposition in the skin and increased melanin. You may sometimes hear this called bronze diabetes. If they give you a patient with diabetes plus hyperpigmented skin, think about hemochromatosis. Iron deposition in the anterior pituitary gland can cause hypogonadism, which will usually manifest as testicular atrophy and impotence, possibly amenorrhea in women, although less common. Women generally have delayed onset of problems from hemochromatosis because of menstruation. Iron deposition in the heart can cause either restrictive cardiomyopathy or dilated cardiomyopathy from hemochromatosis. Do you remember which one we had said was the more common? That's dilated cardiomyopathy. If they have arthralgias from iron deposits in the joints, this leads to squaring off of the ends of bones and big hook-like osteophytes on the second and third MCP joints. Not terribly high yield, but pretty easy to recognize. Labs will typically show mildly elevated AST and ALT from liver inflammation and possibly high glucose if they develop diabetes. Serum iron will be elevated, and so will the ferritin and transferrin saturation. Those are your typical screening tests for hemochromatosis. A common clinical scenario is a patient whose LFTs are always mildly elevated, and you think maybe it's from a drug or something, like a statin. So you take him off the statin and you check him again in a month and the LFTs are still elevated. So you start doing other tests. You check for viral hepatitis and maybe check a ferritin. And if that ferritin is elevated, you start to think about hemochromatosis. You might do other iron studies and eventually check a genetic test to make the diagnosis of hereditary hemochromatosis. If you do a liver biopsy and you stain it for iron, you'll see lots of little blue dots, which are granules of iron packed into the hepatocytes. We don't often need a liver biopsy to make the diagnosis, but you may see it done to determine the extent of liver damage and just to see how much cirrhosis and fibrosis is actually there. Treatment for hemochromatosis is phlebotomy to reduce iron storage. You would take blood out, you're basically forcing the body to take iron out of storage in order to make new red cells. You do phlebotomy about once a week until the iron is normal, and then you space it out and just do monthly phlebotomy. Iron chelators like deferoxamine are hardly ever used because phlebotomy is so effective. So phlebotomy is the standard therapy, and these patients should be counseled to avoid alcohol. Remember, whenever you have liver disease of any kind, you want to avoid exposing the liver to toxins like alcohol. And it's worth mentioning in passing that these patients are at increased risk of hepatocellular carcinoma. It's a major cause of death in hemochromatosis patients. Be sure that you can distinguish hemochromatosis from emochromatosis, which is where you wear eyeliner and spend all day crying about the fact that My Chemical Romance broke up. Next, we're going to discuss Wilson's disease, which is another genetic disease that results in metal buildup in the liver. Wilson's disease is an autosomal recessive disorder that leads to impaired copper secretion. In hemochromatosis, you're absorbing too much iron. In Wilson's disease, you absorb copper normally, but you can't excrete it into the bile, which is how we usually get rid of excess copper. And that leads to copper deposition. You're not going to be able to get rid of copper. Normally, the body excretes copper in bile, but in Wilson's disease, you're unable to excrete it, and then the copper builds up in tissues such as the liver and the brain. This is a disease that usually is diagnosed in the second or third decade of life, teens and 20s. Although it can be diagnosed later, it's uncommon to diagnose Wilson disease in patients over 40. Copper accumulation in the liver leads to hepatomegaly, hepatic steatosis, and eventually cirrhosis, and it may lead to liver failure, jaundice, and all the rest. Copper accumulation in the brain causes neurological symptoms like dysarthria, slurred speech, dystonia, tremor, Parkinsonism because copper accumulates in the basal ganglia. Copper in the brain can also lead to psychiatric problems like depression, irritability, personality changes, or even psychosis. Other classic findings of Wilson's disease are Kaiser-Fleischer rings or KF rings, which occur when copper accumulates in the cornea, and it causes greenish or brownish rings that are visible in the peripheral cornea, overlying the edges of the iris. These used to be seen a lot more frequently 30 to 40 years ago. Now we're catching Wilson disease earlier and treating it earlier. So KF rings usually don't have a chance to develop predominantly, but you look closely, you might be able to see them with a slit lamp on examination. Besides elevated LFTs and other lab findings suggestive of liver disease, the main lab you need to remember for Wilson's disease is low serum ceruloplasmin. Decreased ceruloplasmin is not the cause of the disease, but it's a sign of the disease. Ceruloplasmin is a protein that binds copper and transports it in the blood. In Wilson's disease, one of the effects of the genetic mutation is that the copper can't be incorporated into the ceruloplasmin in the liver. So serum ceruloplasmin is low in Wilson's disease, and that's the usual screening test. So if you have a patient with elevated LFTs, you're going to check viral hepatitis serologies, you're going to check ferritin to rule out hemochromatosis, and then one of the labs you might check is ceruloplasmin. Now in the real world, you're only going to check ceruloplasmin if the patient is under 40. In the patients over 40, you pretty much assume that Wilson's disease would have presented earlier in life. So a patient comes in with elevated LFTs and 65 years old, you can probably cross Wilson's disease off the differential. We don't check ceruloplasmin in those cases. These patients can also have increased urinary copper. Then, if your ceruloplasmin is low and your urinary copper is high, you can do a genetics test for the specific mutation which causes Wilson's disease. Or you can do liver biopsy and stain for copper, and you'll see lots of these brownish copper deposits in the liver, as well as some steatosis and possibly some portal fibrosis and cirrhosis. And you can also do a quantitative copper analysis on the biopsy specimen. For treatment, you can use trientine or penicillamine as copper chelators. You may remember that pennies are made of copper, and that helps you remember penicillamine, but trientine causes fewer side effects than penicillamine, so trientine is becoming the preferred drug. Zinc supplements are also helpful because zinc interferes with copper absorption. These patients should also restrict dietary copper. Copper can be found in shellfish, organ meats, chocolate, nuts, and mushrooms. So you want to restrict all of those so they're not consuming too much copper. But dietary copper restriction itself isn't enough. You need copper chelation too. Sometimes these patients end up requiring a liver transplant if they develop liver failure. Our next disease is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is an enzyme that inhibits the enzyme elastase, which breaks down elastin in the tissues. Patients who are deficient in alpha-1 antitrypsin will have too much elastase activity, and that elastase will break down lots of the elastic tissue in the lungs, leading to paninsular emphysema. That's discussed further in the pulmonology videos. But the mechanism of liver disease and alpha-1 antitrypsin deficiency is very different. It has nothing to do with elastase. What happens instead of some of these patients make a mutated form of the alpha-1 antitrypsin that builds up in the hepatocytes where it's made, and that is toxic to the liver. This is an autosomal codominant disorder, kind of like your ABO blood types. There are lots of different alleles and there's lots of different phenotypes depending on the two alleles you happen to inherit. Some patients get emphysema at an early age, as young as their 30s without even smoking, and some phenotypes result in lung disease plus liver disease. Even though the mutation is present from birth, they don't develop liver disease until adulthood, and they can get liver inflammation with elevated AST and ALT, and eventually they may develop fibrosis and cirrhosis. They are also at an increased risk for hepatocellular carcinoma. In addition to genetic testing, you can also diagnose this with a liver biopsy. And then the treatment is basically a liver transplant and even lung transplant in a severe case. There's one other rare liver disease that I want to discuss briefly, which is autoimmune hepatitis. We often think about hepatitis as an infectious disease, but the generic term just means liver inflammation. In this case, it's an autoimmune process that causes the inflammation. Like most autoimmune diseases, it's more common in women than in men, and most patients are asymptomatic, but it can cause acute liver failure and also cirrhosis. There are two different types of autoimmune hepatitis, although clinically speaking, they're basically identical. Type 1 is the classic type, and it's associated with a positive ANA and a positive anti-smooth muscle antibody. And type 2 autoimmune hepatitis is associated with antibodies against liver, kidney, microsomal antigens, and also antibodies against the liver cytosol antigens. You might also see that written as anti-LKM antibodies and anti-liver cytosol antibodies. Make sure you know those. The anti-smooth muscle antibodies are more classic, but anti-LKM and anti-liver cytosol are worth knowing too. And then treatment options include steroids or steroids plus immunosuppressant azathioprine. Let's finish up by discussing hepatic neoplasms. There are several types of benign liver tumors like hemangiomas, which are vascular tumors, focal nodular hyperplasia, which is the most common non-vascular hepatic tumor, and hepatic adenomas and hepatic cysts. Let's talk about hepatic adenomas for just a moment. They're most often seen in women ages 20 to 44, and the major risk factors for all of these benign liver tumors is oral contraceptives, OCPs. So, hepatic adenomas are most common in reproductive aged women when they're taking OCPs. If you see a hepatic adenoma in a man, think about anabolic steroids as a cause, and glycogen storage diseases type 1 and 3 are also risk factors. These adenomas might cause some right upper quadrant pain or vague fullness, but usually they are completely asymptomatic. They're usually just found incidentally on CT or MRI that is done for some other reason. The problem is about 10% of these adenomas can undergo malignant transformation. 10% isn't a huge number, but it's not rare either. So adenomas need to be monitored periodically. If they're on oral contraceptives, you need to stop them because that could make them grow. You need to monitor it with serial imaging and serial alpha-fetoprotein because AFP is a marker for hepatocellular carcinoma. So if you're monitoring the adenoma and it's growing rapidly, or it starts to develop malignant features on imaging, or you start to see the AFP rising, that's worrisome for malignant transformation. And if you stop the oral contraceptive and the tumor is still getting larger on CT, you may need to resect it, or if it's getting bigger than 5 centimeters in diameter, you want to go ahead and resect it anyway. Now let's talk about malignant liver tumors. If you get an abdominal ultrasound or CT for some reason, and there's a liver mass with malignant features, what's the most common type of malignant tumor in the liver? The answer is metastatic disease from somewhere else, like breast, lung, or colon cancer. So think about METs before you think about hepatocellular carcinoma. So in a patient with an incidentally found liver mass with malignant features, what's the next step? So in a patient with an incidentally found liver mass and malignant features, what's the next step? You start with a CT of the chest, abdomen, and pelvis to look for a primary lesion. If you don't see anything, you may even consider doing a colonoscopy if the patient is at high risk for colon cancer, or if the patient is screening age and hasn't been screened recently. Where does the colon drain? To the liver. So colon cancer will commonly metastasize to the liver. The most common primary liver malignancy, a malignant tumor that arises from the liver, is hepatocellular carcinoma, or sometimes it's informally called a hepatoma, which is a malignant tumor of the hepatocytes. The main risk factors for hepatocellular carcinoma are hepatitis B and hepatitis C and cirrhosis. Anything that causes cirrhosis can increase the risk of hepatocellular carcinoma, whether it's alcoholic liver disease or hemochromatosis or any other type of cirrhosis. Another rare but interesting risk factor is consumption of aflatoxin from food that has been infected with the mold from Aspergillus. Being infected with Aspergillus isn't the risk factor for hepatocellular carcinoma, but Aspergillus that infects corn or peanuts or soybeans can produce something called aflatoxin. And if you ingest a lot of these infected foods, the aflatoxin can be a risk factor for hepatocellular carcinoma. We don't see this much in the US, but you might see this in developing countries where the food sources are more likely to be contaminated and they'd exposed to high doses of aflatoxin. Most of these patients don't have any symptoms from the cancer itself. They just have symptoms from their chronic liver disease. They might go from compensated cirrhosis to decompensated cirrhosis, so they suddenly develop ascites or jaundice or encephalopathy. They could have non-specific findings like weight loss or hepatomegaly or right upper quadrant pain, and sometimes you can hear a bruit over the liver because these tumors are fairly vascular. So you can hear blood flowing through all these new blood vessels that the tumor is growing. Hepatocellular carcinoma also sometimes causes a paraneoplastic syndrome. Remember, a paraneoplastic syndrome is an effect of cancer that arises not from the local effects of the tumor, but rather because of some hormone or chemical the tumor produces. The paraneoplastic effects associated with hepatocellular carcinoma include polycythemia or erythrocytosis, excessive red blood cell production, because of the secretion of erythropoietin. This is one you should definitely know, and we'll come back to that one in a moment. It can cause hypercalcemia because of secretion of PTH-related peptide, just like squamous cell lung cancer. It can cause watery diarrhea because of secretions of things like vasoactive intestinal peptide, or VIP. It can cause mild hypoglycemia because these tumors have high metabolic needs, so they just may suck up a lot of glucose. And hepatocellular carcinoma can cause various types of obscure skin lesions. Now, going back to the elevated erythropoietin, there are 4 main malignancies that will secrete erythropoietin and cause polycythemia as a paraneoplastic syndrome. You may want to jot these down in the margin. A student from Tulane sent us a terrific mnemonic, which is potentially really high hematocrit. I love a mnemonic that fits what you're trying to remember. Potentially really high hematocrit stands for pheochromocytoma, renal cell carcinoma, which is pretty easy to remember because erythropoietin is normally produced in the kidneys, hepatocellular carcinoma, which is what we're talking about here, and hemangioblastoma, which is a type of brain tumor, a blood vessel tumor in the brain. Now, going back to hepatocellular carcinoma, these patients will usually have elevated LFTs because, again, most of these patients have chronic liver disease, but the main lab to know is an elevated alpha-fetoprotein because, again, AFP is a marker for hepatocellular carcinoma. If you see AFP on your test, think about hepatocellular carcinoma because that's probably what they're going to be pointing you towards. It's not a screening test for the general population, but it could be useful for monitoring progression of the cancer itself. You can often see a liver mass with ultrasound, but you can't really tell one type of solid tumor from another. So an ultrasound won't be able to distinguish a benign adenoma from a hepatocellular carcinoma. But a CT or MRI often can tell you if it is malignant. Not always, but there are certain features to look for. If the diagnosis still isn't clear with a CT or MRI, you could do a core needle biopsy. But again, these are very vascular tumors, and if you stick a needle into it, you're going to have a bleed. So it's possible we're just going to make the diagnosis using imaging plus an AFP. For treatment, small tumors can be treated with surgical resection, either a lobectomy or a partial hepatectomy. Obviously, you can't take out the entire liver, but you can take out a large portion of the liver and still get by without it. Then, following resection, you want to do chemotherapy. Unfortunately, hepatocellular carcinoma is very aggressive cancer and is often too advanced to resect. Unresectable tumors might get treated with liver transplant because, again, this is a sick liver to start with, or radiofrequency ablation, or chemoembolization. But hepatocellular carcinoma has a very high mortality. Now it's time for our end of session quiz. First question. What is the most widely used screening test for hemochromatosis? Ferritin. Next question. What copper-related lab test would you order in a patient with suspected Wilson's disease? Serum ceruloplasmin level, which should be low. Next, what is the treatment for hemochromatosis? The answer is phlebotomy, usually weekly, until the iron stores are normal and the ferritin normalizes, and then monthly. And last one. Use of what drug is a major risk factor for developing a hepatic adenoma? Oral contraceptive pills. That's it for this one, guys. We'll see you at the next one.
According to a recent survey, over 8% of the population has diabetes. But I know you. You don't want just plain average diabetes. You want to be different. So for a limited time only, now you can get bronze diabetes. You love bronze. Bronze medals, bronze statues, weapons. Bronze just makes everything better. Be the first one on your block to get this shinier classic version of diabetes for only 4 easy payments of $29.99.
Really, this is ridiculous. You're actually trying to sell people diabetes.
Bronze diabetes!
Oh, this is just stupid. You may now have actually lost it. Bronze diabetes occurs in hereditary hemochromatosis. You have iron deposition in the pancreas, which causes diabetes, plus iron deposition in the skin, which causes hyperpigmentation. Hemochromatosis patients have to get regular phlebotomies. Do you know what that is? That is bloodletting. Who do you think is going to buy that?
Well, no one when you put it like that. You gotta add some flair to it. Let me show you how it's done. Bronze, bronze, bronze! Bronze makes everything better, even diabetes!